Dr. Kersha Patel and Dr. Miguel Canzos, live from the DeBakey studio at Houston Methodist. Now, I'm sure you will hear a lot today that cardiovascular disease still remains the #1 cause of death in US. But at the same time, I think it's also time for us, especially for those in the cardiovascular prevention community, to celebrate that with a comprehensive approaches over the last 4 decades, we have witnessed significant reduction in mortality from cardiovascular disease. At the same time, we need to be cautioned that with the changing structure of our society, resulting in more sedentary lifestyle, worsening diet, stress, we are noticing gradual increase in burden of obesity, diabetes, and hypertension that seems to be cutting into some of these gains. While these trends are alarming, I think it's also a very exciting time for preventive cardiology as we see significant expansion not only in our tools to capture early risk, we are increasing our understanding of special groups, but there is a growing capacity for not early lifestyle intervention, but we are aided with an amazing spectrum of therapeutic options to lower cardiovascular disease risk. However, with the widening of knowledge, tools, and options, it also brings in challenges how best to approach cardiovascular disease prevention in real-world scenario for busy clinicians. So, to address this are 4 state-of-the-art sessions led by an outstanding panel of speakers that will cover a wide range of topics across 4 major domains that may hopefully provide you not only broader but also in-depth insights on these issues of immense interest. Our first session addresses the holy grail for our medical community: how best to assess the risk of the person not only in front of you but also at the population level. In this session, you will hear on a wide range of topics, starting with the role of traditional risk factors and biomarkers that still remain the backbone of our current approaches, but also get insights on exciting progress made on supplementing with imaging phenotypes with the whole new notion of see disease, treat disease. Followed by, not too far away from now, I'm very hopeful that genetic applications will be widely adopted. And finally, some deliberations on whether there is room for social determinants in our risk assessment tools. Now, from this, we will pivot to an exciting session where our speakers will focus on 5 pillars of cardiovascular disease prevention, with emerging emphasis on heart failure prevention. You will get practical tips to manage cardiometabolic risk among diabetics. What can we do medically to manage obesity beyond lifestyle and surgical interventions? How to wisely use the wide range of lipid-lowering arsenal now available to us, and reminding that we should not forget hypertension management may provide the highest dividends for cardiovascular disease prevention. Now, we also know that not all are created equal as far as cardiovascular disease risk is concerned. So the third session, one of my favorite, will emphasize why pregnancy is such a critical time to think about CV health. Some new understandings on high-risk ethnic groups such as South Asians. Also, there is a wide group of inflammatory conditions that deserve our special attention, followed by the dilemma of how to manage cardiovascular risk and prevention in a growing number of men with low testosterone and the emerging role of testosterone replacement therapy. And finally, we'll end this half-day symposium with focus on common dilemmas faced in our clinics, such as statin intolerance. What is it all about and how to manage? Advice on stress reduction strategies for mitigating cardiovascular risk, and commonly faced question from our patients: what should I eat and what should my diet look like? And finally, ending with a reminder that the focus is shifting from risk reduction to attainment of optimal health, which should remain our exclusive goal. I sincerely hope that whether you're a cardiologist, endocrinologist, primary care physician, NP, early carrier, or an established professional, this wide range of topics from world experts in these domains will energize your focus on prevention with practical tips and information on how to maximize cardiovascular health among your patients. Also, there are some housekeeping tips for today's event. If you have any questions during the session, please type them in the chat box on Zoom or text DeBakey to 37607 and text your questions. Also, if you plan to share content throughout the day via social media, use hashtag DeBakey Prevention and don't forget to tag at DeBakeyCVEDU. We will also send an email early next week with links to our evaluation. Your feedback is critical to help us improve our courses as we explore this new digital format, so please complete the survey. And finally, I would like to take a moment to gratefully acknowledge Amarin for providing educational grants to partially support this activity. And now I will hand it over to my co-director, Dr. Karsha Patel, to jumpstart our first session.
Thank you, Dr. Nasir, and welcome everyone. Good morning. For our first session, we are going to be joined by an expert panel for our first session titled, What's Your Risk? The 4 Pillars of Evaluation in Preventive Cardiology. We're going to have Dr. Salim Virani moderate our first session. Dr. Virani is a professor of medicine at Baylor College of Medicine. He is the Cardiovascular Disease Fellowship Program Director. He is well known for his expertise in lipid management and recently won the President's Service Award from the National Lipid Association. And we're thrilled to have Dr. Virani join us and get us started with this first session. Thank you, Dr. Virani. Get us started with this first session. Thank you, Dr. Virani. All right, so we will have, as part of our first session, looking at understanding our risk for cardiovascular disease. We'll have several expert speakers joining us from across the country, and so we'll have Dr. Virani join us to moderate this session once we're able to get connected live. Okay. So welcome, Dr. Virani. We had some slight technical issues, but now we're going to get back right on track. So for our first session, again, it's titled, What's Your Risk? The 4 Pillars of Evaluation in Preventive Cardiology. So Dr. Virani, thank you for helping moderate this session, and we'll go ahead and get started.
My pleasure to introduce our first speaker, Dr. Anne-Marie Nawar. As Dr. Patel mentioned, it's about 4 pillars in cardiovascular disease prevention. The first speaker is Dr. Anne-Marie Nawar, who's an associate professor in the section of cardiology at UT Southwestern in Dallas, Texas. And she is going to be talking about risk factors and biomarkers. So the title of her talk is Starting with Risk Factors and Biomarkers, Practical Choice. So let's hear Dr. Anne-Marie Nawar. Thanks.
Thank you to Dr. Virani and the organizers for the opportunity to join you again this year for this important symposium. Today, I'll be talking about starting with risk factors and biomarkers to identify patients for statin therapy, a practical approach. These are my disclosures. I think it's important for us to start off by reminding ourselves about the data and the amazing data we have for the efficacy of statin therapy. In hundreds of thousands of patients, we've seen statins are effective. And we can see in this particular meta-analysis from the cholesterol treatment trialists that for every millimole per liter, or about 38 milligram per deciliter reduction in LDL cholesterol, we have about a 20% reduction in cardiovascular events. We also know that starting earlier is better because the time on treatment is associated with an increasing hazard ratio for reduction in cardiovascular events. We also know from CTT there's no interaction in any subgroup, be it age, comorbidities, or LDL cholesterol, in the relative risk reduction experienced on statin therapy. So given that statins work equally well on a relative basis for all patients, how do we identify those who are going to benefit the most? Well, we need to figure out who's at the highest absolute risk of cardiovascular disease, and then guide statin therapy to those at the highest absolute risk. Now, there's a lot of difficulties and complexities in the latest guidelines, but I'm a simple preventive cardiologist, and I like to think about it sequentially, starting with the low-hanging fruit. So there's some obvious groups that we need very little information about to know who to treat with statins. This is the Primary Prevention Guidelines from 2018, and we see that those with the highest LDL cholesterol over 190, which includes those with familial hypercholesterolemia, need to be on a high-intensity statin. So do those who have diabetes and other risk factors for cardiovascular disease need high-intensity statin, and those with diabetes, regardless of risk, need at least a moderate-intensity statin. The final group is those who have a 10-year predicted risk based on the pooled cohort equations over 50%. And here, we don't need a lot of biomarkers. The only biomarkers that are part of the pooled cohort equations are blood pressure, total cholesterol, and HDL cholesterol. So we can identify a large proportion of patients who benefit from statins without getting very complicated. So just to recap, lowest hanging fruit, LDL over 190 in patients with FH, people with diabetes, and people with a very high 10-year risk. Now, what about the intermediate risk group and those who are younger, i.e. those aged 20 to 39? The guidelines tell us to estimate lifetime risk and to consider statins if those have family history of premature heart disease and an LDL over 160. Here is where my practice deviates a little bit from the guidelines, and it's because of the biology of atherosclerosis. We know that atherosclerosis starts early with the deposition of atherogenic lipoproteins in the arterial walls, starting in your teens and 20s. And if we can prevent the initial deposits from forming, we're much more likely to prevent atherosclerosis in the long run. Multiple studies have shown that prolonged exposure to elevations in LDL cholesterol increase long-term risk of heart disease, similar to the way we think about pack years and smoking. These are data from the Framingham Offspring study, where we showed that for every decade of exposure to LDL cholesterol, we saw a stepwise increase in future risk of heart disease at the age of 55. And when we adjusted for other clinical risk factors, we found that someone's average LDL cholesterol prior to the age of 55, independent of what their LDL or non-HDL cholesterol was at the age of 55, increased their risk of heart disease, even in fully adjusted multivariable models. And that risk started at a non-HDL cholesterol of 125 milligrams per deciliter, or about an LDL cholesterol of 100 milligrams per deciliter. So for all of our primary prevention patients early in life who have LDL cholesterols over about 100, we need to recognize that their increased risk of heart disease, and that risk is entirely almost modifiable by lipid-lowering therapy, particularly statins. We also know in young people that the pooled cohort equations and 10-year risk equations aren't very good at identifying those who are going to develop premature heart disease. We looked at data from the Duke Data Bank, and under both the 2013 and the 2018 guideline, just about half or fewer adults less than the age of 55 who had early myocardial infarction, i.e. before the age of 55, would have been identified for statin therapy even when we include all of the risk enhancers in the current guidelines. So I think we're missing an important prevention opportunity in young people. And my approach is young people with elevated LDL cholesterol particularly those with a premature family history, need to be treated with statins. But I actually go beyond this. And in people with elevated LDL cholesterol in the 130 to 160 range, I offer therapy in the same way that I would treat somebody who had a systolic blood pressure of 140 or 150 because of the epidemiologic data showing long-term cumulative risk. Now, you might say that young people don't want to take statins and we can't get anybody to take a medication. But I would argue that if we look at the proportion of young people who are taking supplements or vitamins to try to prolong their long-term health, in fact, 71% of US adults are taking some form of a supplement or vitamin now, that we see there's a substantial appetite for cardiovascular prevention. We just have to be able to frame it and offer it appropriately to patients. We talked about the highest risk group, those over 20%. But what about this intermediate risk group? The low risk group, less than 5%, or the intermediate risk group in the 5 to 20% range? How do we better risk stratify those patients to determine who's eligible for statin therapy? And this is where biomarkers and additional lipid testing beyond our traditional lipid panel can be helpful. And it's important to remember that not all lipoproteins are the same. In fact, when we check LDL cholesterol, all we're measuring is the volume of LDL particles in the blood. But a number of other ApoB100 containing lipoproteins, including VLDL and IDL, also increase future risk of cardiovascular disease. Fortunately, for the majority of patients, if their LDL-C is normal, so is their ApoB. Conversely, those who have high LDL cholesterols often have high ApoB. However, we know that that's not the case for everybody, and a number of people have discordant measurements between their ApoB and their LDL cholesterol. The group we worry the most about are the people who are sliding under our radar, who might have a low LDL cholesterol, but a very high ApoB. This is this third column here on the slide. These patients look like they're at lower risk based on their LDL, but in fact are at much higher risk of cardiovascular disease than a standard lipid panel might indicate. So who are the patients that tend to be in this group? Those with metabolic syndrome, diabetes, inflammatory conditions, high triglycerides, lower HDL, and older adults. And we've seen from numerous epidemiologic studies that the group that has discordantly low ApoB relative to their LDL cholesterol have some of the highest rates of cardiovascular disease. And in pooled data across a number of cohort studies, we see that the relative risk increase for cardiovascular events is higher for ApoB elevations compared to non-HDL or LDL cholesterol, suggesting that ApoB is probably the measurement that's best encapsulating LDL lipoprotein-related risk. Now, what other factors do we need to think about besides ApoB and LDL cholesterol? Triglycerides. These are data from the Framingham study showing someone's average triglyceride level between the age of 40 to 65 and future risk of cardiovascular disease. And while we often think about triglycerides over 150 as increasing risk, we actually found that starting well below 100, increases in triglycerides are associated with an increased future risk of cardiovascular disease, even in adjusted modeling. So particularly important to be paying attention to our patients with triglycerides in the 150 or above level, but even thinking about triglycerides as a risk enhancer in the 100 to 150 side. Many people wonder if triglycerides are an independent risk factor for cardiovascular disease. This is subject to a lot of debate. Triglycerides in some studies have been shown to be independently associated with CVD, but we know that a lot of the factors that increase triglycerides are confounding this relationship. I would posit, for the sake of risk assessment, it doesn't really matter. Elevated triglycerides are an important risk enhancer nonetheless. When we see patients with elevated triglycerides, we should be thinking that they're at higher risk of heart disease than we may be able to capture in the pooled cohort equations. Another important lipoprotein is Lp(a). Lp(a) is a tiny little lipoprotein that looks like an LDL particle, but it has a different surface molecule. And although it contributes to a small fraction of measured LDL-C, it actually is substantially associated with cardiovascular risk. And we can't measure it with the traditional lipid panel. The only people that we can detect with elevated Lp(a) are those who we send a specific Lp(a) test for. The nice thing about Lp(a) is that it's mostly genetically determined. So if you check it once and it's normal, you don't really need to keep checking it again. On the other hand, a lot of patients will have elevated LPA and not know it because it doesn't well correlate with the rest of the lipid panel. Elevations in Lp(a) are quite common. Up to 20% of the general population would have an elevated Lp(a), depending on the population study. And numerous studies, this is the emerging risk factor collaboration pool data across a number of cohort studies with over 100,000 patients. We see that elevations in Lp(a) increase the risk of non-fatal MI and coronary death, and at extremely high levels, increase the risk of ischemic stroke. The 2019 ESC guidelines remind us that those with extremely high Lp(a), i.e. over 180 milligrams per deciliter, have a cardiovascular risk equivalent to the risk associated with heterozygous FH. So when we're thinking about how to evaluate patients in that intermediate risk zone, it's important for us to have all of the information that we need at our fingertips. The AHA guidelines recommend that we assess various risk enhancers. That includes a number of clinical conditions, including CKD, reproductive specific factors related to women, the presence of inflammatory diseases, and certain ethnicities, but also lipid biomarkers, i.e. persistently elevated triglycerides or elevated ApoB or Lp(a). Elevated high sensitivity CRP is also recommended as a risk enhancer to help us identify patients at increased risk of heart disease. So if we continue on our low-hanging fruit analogy, who else do we need to be thinking about for statin therapy? I would include those at intermediate risk for heart disease with an elevated ApoB or high triglycerides, those who have multiple clinical risk enhancers, and those with an elevated Lp(a). The final piece is, once we've done all of our biomarker evaluation, what's the last test that we can think about to help risk stratify and identify patients for statin therapy? And that's coronary calcium. The guidelines recommend that in intermediate risk patients in whom your decision about statins or the patient's decision about statins is uncertain, to consider measuring coronary artery calcium. And if coronary calcium is present, we should be considering those patients at much higher risk and recommending statin therapy. Compared to all of the other biomarkers that we've evaluated, CAC is the strongest in terms of improving risk prediction. This is performance of the pooled cohort equations in the green line. And then what happens when we add in different risk factors? ABIs, high sensitivity CRP, and family history all contributed very little to reclassifying adults in terms of their risk of cardiovascular events. On the other hand, in orange, we see that when we add coronary artery calcium to the pooled cohort equations, we have a substantial increased discrimination to identify the highest risk adults for coronary disease. And to put this into better context, these are data from Mike Blaha and team looking at the net reclassification index, or the proportion of patients that are reclassified correctly, either into a high or low risk group, based on the presence or absence of different risk factors. And we see that the CAC score NRI is 13.7. It eclipses all of the other NRIs for the other biomarkers, including things like CRP, BNP, homocysteine, and microalbuminuria. I will point out, though, that the presence of carotid plaque or elevated CIMT or ABIs did have a pretty strong role in reclassification, likely because, similar to CAC, these are factors that identify the presence of subclinical prevalent atherosclerosis. So when we think about how to risk stratify patients who you're seeing for the first time in clinic, we start with a certain lab workup. All patients need to have a lipid panel at least every 5 years, according to AHA and ACC guidelines. And then more frequently, if they experience changes such as big changes in their weight, medications, lifestyle, or menopause. I add an initial ApoB to all of the patients that I get a lipid panel on to assess for the possibility of discordance between ApoB and LDL-C. If ApoB and LDL are discordant, then I follow ApoB and not LDL-C to make treatment recommendations and evaluate treatment response. It can be a challenge to know which patients are at highest risk for elevated Lp(a). And because the cost of the test is fairly minimal and usually covered by insurance, and because we have a number of Lp(a) therapies that are in development, that I think it's important for us to be able to identify potentially eligible candidates, I check an Lp(a) on all patients that I see at least once. and particularly in those that have a family history of premature coronary artery disease. It's also important when we're talking about biomarkers not to forget about other risk enhancers, including inflammatory disease like HIV, rheumatoid arthritis, and hepatitis C, and reproductive factors such as premature menopause or complications of pregnancy like hypertensive disorders and gestational diabetes. So to summarize, what's my biomarker-based approach to statins and primary prevention? Important that we always assess patient preference and perform a comprehensive clinical risk assessment. And as I mentioned, I check a lipid panel, an ApoB, and an Lp(a) in all of my patients. In my low-risk patients, if they have multiple risk enhancers or if they're young and have high LDL cholesterol, I offer statin therapy as part of a comprehensive discussion with the patient about long-term prevention of cardiovascular disease. In older patients, where it's more likely to find coronary calcium, I do consider CAC in my low-risk patients. In the very high-risk group on the right, I think we can often treat without collecting additional information, particularly if the patient is willing to initiate statin therapy. This includes all of those with subclinical disease or CAC, those with very high LDLs or 10-year risk, Lp(a), or those who are at intermediate risk with multiple risk enhancers. Finally, in this intermediate bucket, it's important to assess someone's willingness for therapy. If somebody's not at all interested in initiating a statin, then it's a waste of resources and time to order a bunch of additional testing. If they're on the fence, a CAC score can be really helpful, both to risk stratify, but also to motivate the patient to initiate statin therapy. And in the intermediate risk bucket, when patients are willing to take a statin and want to do everything they can to lower their risk, I offer statin therapy without further risk stratification because of the long-term safety and efficacy profile that we have for statins. And with that, I thank you for your time, and I look forward to your questions.
Thank you, Dr. Navarre. That was a very nice presentation and giving us a practical approach to baseline risk assessment for our patients. And so for our next speaker, I'd like to welcome Dr. Blankstein, joining us virtually from Boston. He is a professor of medicine at the Harvard Medical School. He's the director for cardiac computed tomography, as well as a past president for the Society for Cardiovascular Computed Tomography. Dr. Blankstein is an expert in atherosclerosis imaging. And so today he's going to be joining us to discuss his topic of atherosclerosis imaging, the major role in risk assessment and management. So thank you, Dr. Blankstein.
It's a great honor for me to be part of today's symposium, and I will be speaking about atherosclerosis imaging. I'll start with a message that I think we all know very well, and that is that contemporary medical therapy works. This, of course, was shown in many studies, including most recently in the ischemia trial. But we can use this information to then ask the question whether plaque imaging can help us identify the individuals who are most likely to benefit from preventive therapies. You know, when I talk about plaque imaging, it's both calcium scoring, which we typically do in asymptomatic individuals, or coronary CT angiography that we typically do in symptomatic patients. If we start with calcium scoring, today we know that calcium scoring is now endorsed by our cholesterol guideline and prevention guideline. Specifically, there's a class 2A indication that we can use this test if the decision about statin use remains uncertain. This approach has also been adopted by other statements and guidelines, including the National Lipid Association scientific statement and the endocrine guideline. In fact, if we look at the rationale that the guideline authors put together when they gave this indication, it is that calcium scoring has superior utility over any serum biomarker for the prediction of future ASCVD events. This, was not known maybe a decade ago, but today we know that identifying plaque is a stronger predictor of future risk than any other risk factor that we know, any combination of risk factors or any serum biomarker. In fact, a high calcium score, which identifies a larger burden of plaque, is associated with a risk of various types of cardiovascular endpoints, including myocardial infarction, stroke, revascularization, heart failure, atrial fibrillation, and valvular disease. So many endpoints that we all care about as clinicians and as preventive cardiologists, we can impact if we identify the patients who are at higher risk of having those events. But calcium scoring, of course, we know is not just about telling us who has a higher risk of event, but who has a low risk of event, and specifically patients with a calcium score of 0 who have an annual rate of 0.1% per year in most cohorts. Why is this important? This is important because in the past, we used calcium scoring to screen cohorts to identify who has a higher risk. We now use calcium scoring as a decision aid tool to help us make more personalized decisions when there are patients who prefer to avoid statin therapy if their calcium score is 0 and instead focus on lifestyle interventions. Now, importantly, we also know that when plaque is identified, and this slide is a summary from a meta-analysis conducted by our group, but when plaque is identified, we as clinicians are more likely to start our patients on aspirin, on lipid-lowering therapies, blood pressure-lowering therapies, to have them exercise more and also to promote dietary changes. So many beneficial changes occur once we identify patients who have plaque. So I talked about calcium scoring. Let's now talk about coronary CT angiography. When it comes to coronary CT angiography, I think it's important to know that we now have new guidelines, at least from Europe. We have the 2019 European Society of Cardiology guidelines that provide a class 1 indication for use of coronary CTA as an initial test to diagnose coronary artery disease. In the US, we actually don't have a new chest pain guideline quite yet, but this document is scheduled to come out in a couple of weeks, so stay tuned. So if we look at the European guidelines, why is it that coronary CTA now has a much stronger indication than it did in the past? And of course, this was driven by data and by trials. But before I go over some of that data, I want to start with the premise of why is plaque identification important? And this applies to symptomatic patients now with coronary CT angiography. And the reason it's important is that most stress tests that we do today in the US are normal. This slide here shows, or this figure here, the frequency of abnormal stress tests among patients referred for a SPECT MPI at 5%. Now, we also know, and this is from a sub-study from PROMISE, that most events occur in patients who have a normal functional study. And it's not that the study is wrong, it's just that functional studies and stress tests, by design, they're supposed to identify flow-limiting disease. So if a patient has extensive amount of atherosclerosis and that's not limiting blood flow, the test will be normal. As a group, those patients still have a lower risk than patients who have significant ischemia. However, that group is very large. So if most patients have a normal study and some normal patients may have a large amount of underlying plaque, as a group, there's going to be more events in that population. Lastly, we also know that the plaque burden identified by coronary CT angiography predicts risk, and in fact may predict risk just as well, if not better, than stenosis. So today, when we do a coronary CT angiogram, it's not just about what's the worst lesion, what's the stenosis, but how much plaque do individuals have. So I had mentioned here that plaque identification is important. And of course, the question we should all ask is, yes, but does it lead to better patient outcomes? And we never really knew the answer to this up until a few years ago, where we now started to have data that the use of coronary CT angiography by identifying plaque and leading to more preventive therapies is associated with better outcomes. We saw this in the Scott Hart study, where patients with stable chest pain were randomized to either standard of care, which was typically an exercise treadmill test in this study, or a coronary CT angiogram added on top of standard of care. And importantly, the addition of the coronary CT angiogram resulted in a 41% reduction in myocardial infarction or CHD death. In PROMISE in the US, using a different endpoint, there was no difference between the two groups. However, in a pre-specified sub-analysis, patients with diabetes randomized to coronary CTA had better outcomes than the diabetic patients who did not undergo coronary CTA and had functional testing. Of course, the reduction in events with CT has also been shown in meta-analyses and also in retrospective studies, such as this on the bottom right here, a large Danish registry that was published in 2017. When we put all this data together, and we come up with recommendations on how to manage patients based on coronary CTA findings, we know that stenosis is important, but so is the amount of plaque. So generally today, if a patient has non-obstructive disease, we think that preventive therapies are warranted, and the intensity of those therapies depend on the overall amount of plaque and possibly also on whether patients have high-risk plaque features. Patients that have severe stenosis, in them functional testing or sometimes invasive angiography may be needed. But even in patients with severe stenosis, if they don't have limiting symptoms, preventive therapies may also be an option. So one of the key concepts here is that preventive therapies is not a black or white issue. We now have more intense therapies. And here we state that the intensity may be influenced by the overall amount of plaque that individuals have. So let's talk more about that. How can we use coronary CT angiography to identify our highest risk patients? And this is a figure from the SECT Atherosclerosis Expert Consensus Statement. And in this pyramid, it suggests that the way we can truly identify high-risk patients is by integrating not just who has stenosis, but how many vessels have stenosis, the location of that, and also the amount of plaque and the type of plaque. So essentially, the highest risk patients are those who are going to have a higher burden of disease, and those are the ones who would benefit from more intensive therapies. Importantly, because prevention is not just about statins anymore, and you can see on the right side of the slide, all the various medications we may use, we now know that for these high-risk patients, we should be thinking about many of these therapies. So I want to next answer the question of what actually matters for risk assessment when we do coronary CT angiography. I alluded that the overall amount of plaque is important and stenosis is still important, but what else can we look at? So one measure is high-risk plaque features, and on this figure here, you can see the four most common ones, which include positive remodeling, a napkin ring sign, which is really a sign of having a necrotic core, low attenuation plaque, which may associate with fatty-rich plaque, as well as spotty calcifications. I'll speak about high-risk plaque in a bit, but also other high-risk features on CT that we may use more in the future include a pericoronary fat attenuation. And essentially, this is a measure that we can obtain by looking at the fat around the coronaries. And the premise here is that when there's inflammation in the coronary arteries, that may affect the fat and change the attenuation of the fat around the coronaries. So this is now a non-invasive technique that we can use to identify inflammation. The hemodynamic significance of lesions with CT-FFR is also important for risk prediction in some cohorts. Shear stress, certainly important as well, even though this is mostly in the experimental realm. This has not been used as much clinically, but we know that plaque is more likely to develop in areas of low shear stress and also more likely to progress. Finally, it's important to know that no single anatomical plaque feature alone is ever going to predict everything we want to know about our patients. We have to integrate the imaging findings together with other underlying risk factors, which may also include in the future polygenic risk scores. So back to high-risk plaque, both in the PROMISE study, which was done in the US, the Scott Hart study, which took place overseas, you can see that patients who have high-risk plaque features, and they're defined differently between these two cohorts, have a higher risk. But importantly, in the PROMISE study, the higher rate of events in patients with high-risk plaques was more significant in patients that had non-obstructive CAD. And this may make sense once a patient has severe stenosis and a very large plaque burden. These high-risk plaque features may not add as much, but it's the patient who have mild stenosis or finding these high-risk plaque features may make a bigger difference for risk assessment. Now, in the Scott Hart trial, also adverse plaque characteristics were quite common. Part of this could be because they also included spotty calcifications. But one of the interesting findings here is that all patients underwent a coronary artery calcium scanning. And once these results included a calcium scoring, so once you adjusted for a calcium scoring, which is a very good surrogate of the overall amount of plaque, high-risk plaque features were no longer associated with future events, emphasizing again the importance of overall amount of plaque and how important that is for risk prediction. So hopefully I've convinced you that the amount of plaque that patients have, whether that's detected with a coronary CT angiography or calcium score, really matters for risk. And in fact, this slide here now shows a recommendation we made at the SCCT Atherosclerotic Plaque Expert Consensus Statement, and that is that for patients who do have evidence of plaque, the conclusion of the report should include a statement regarding the overall amount or extent of atherosclerotic plaque. Now, how do you do this? This could be done using a visual assessment of the amount of plaque, which imagers at your center should be able to do if they look at a coronary CT and seeing how extensive the disease is. It can also be done with a calcium score if that is added on top of a coronary CT angiogram, or it can be done with a semi-quantitative assessment known as the segment involvement score, which essentially represents the overall number of segments that have plaque. So today, our recommendation is when a coronary CT angiogram is reported, there should always be a statement regarding the overall amount of plaque that the patient has. Now, a common question is, well, what about quantifying this? Can you push a button that will automatically tell you how much plaque an individual has? And the technology actually is now available to do that, and this is now being tested. There's multiple vendors working on perfecting this technique, but importantly, this will require validation. So I think a lot more to come in this era. So in conclusion, identification of plaque, whether in asymptomatic or symptomatic patients, or whether using calcium scoring or coronary CT angiography, is associated today with more aggressive downstream preventive measures. And in fact, because of this, in some studies, such as the Scott Hart trial, a lower event rate and a reduction in myocardial infarction. The absence of plaque, and specifically the power of zero when calcium scoring is done with a calcium score of 0, is associated with very low event rate. Not an event rate of 0, but an event rate that is low enough that it may be reasonable to avoid statin therapy, avoid medical therapies, and instead focus on lifestyle changes. So this is important because it now gives our patients some flexibility in decision making. Patients who have a higher burden of plaque have a higher risk, and there's a whole gradient of risk here. And if we understand this, we can now identify the highest risk patients. These are the ones who have the largest amount of plaque or who may have high risk plaque features. And for those patients, secondary prevention therapies would be warranted. So this is now no longer just statins, but other aggressive agents to lower LDL. This may include in the future anti-inflammatory therapies. This may mean that these are patients who we want to treat more aggressively when it comes to blood pressure lowering, weight reduction, diabetes management, potentially in the future, agents to lower lipoprotein A, and even medication like icosapent ethyl or other therapies to lower triglycerides. So these are all agents that today we think of as secondary prevention agents. And I think the paradigm now is not just, are you a primary or secondary prevention, but what's the risk? And if you have a sufficient level of risk because you have underlying plaque, you may benefit from these therapies. Lastly, I touched on the fact that we now have fully quantitative plaque assessment. This is not yet used clinically, but this is now more feasible. It's being used in some clinical trials looking at plaque regression. But I expect that in the not too distant future, this will now be used in the clinical setting as well. Of course, we're going to need some validation of a lot of the different measures and a lot of the different vendors who are out there working in this space. And ultimately, we will have to link findings on coronary CTA with respect to plaque analysis with what are the right downstream therapies that would benefit our patients. With that, thank you all very much.
Thank you, Dr. Blankstein. That was a fabulous talk on the role of imaging in cardiovascular disease prevention. Now we'll move on to the third talk of this session, and it's my pleasure to introduce Dr. Amit Khera, who's a cardiologist and a human geneticist and population biologist from Mass General Hospital. He also serves as the group leader for MGH Center for Genomic Medicine and also an assistant professor at Harvard Medical School. And Dr. Khera is going to talk about genetics, new kid on the block for cardiovascular disease prevention. Dr. Khera.
Hello, my name is Amit Kara. I'm delighted to be here today to discuss genetics, a new kid on the block for cardiovascular disease prediction. I recently went back and read a study by Dr. Paul Dudley White, who founded our cardiology division nearly 100 years ago. It was published in JAMA, and it was one of the first studies to really show that a family history was present in about 27% of people coming to the hospital with a heart attack at a young age, as compared to only 14% of controls. Now, this observation has stood the test of time. We know to this day that those who have family history have about a doubling of their risk. But it also inspires a much more interesting question, which is what are the precise molecular determinants of these increased risk which runs in families? And it's only within recent years that we've had the tools to really start to answer that question. So we recently set out to say what is state of the art for genome interpretation for risk of myocardial infarction in 2021. As a thought experiment, we said, what would happen if the same 100 patients came into our hospital here today? We designed a whole genome sequencing study involving 2,000 patients who presented to a US hospital at age less than 55 years and nearly 4,000 controls. So from a conceptual standpoint, how might someone's DNA get them to a heart attack, especially one at young age? Well, the traditional approach is to focus on monogenic mutations, single mutations that disrupt a very specific pathway and in and of themselves can have a large effect on risk for disease. Cardiologists are most familiar with familial hypercholesterolemia mutations, which we found actually in 1.7% of the patients, and on average, they were associated with about a 3.8-fold increase in risk. Now, many of you know that these mutations actually prevent clearance of bad cholesterol or LDL cholesterol from the circulation. Here I'm showing you the y-axis, measures of LDL cholesterol, and on the x-axis, presence of a monogenic mutation. And what you can see is that although there's some overlap, on average, the mean cholesterol was 202 for those who carried a mutation versus 124 for those who didn't. So this means that LDL cholesterol is an imperfect but reasonable proxy for the presence of these mutations. We then said, okay, well, can we actually identify additional patients with what we now call a polygenic model? Here, it's not one mutation, but actually many variants scattered across the genome, each of which has a small effect. But in aggregate, you might imagine that the risk would be more substantial. And importantly, these variants tag many different pathways. So to design a new genetic predictor, really to say, how might we explain the remaining 98% of these patients? We first performed a genome-wide association study. We looked at 60,000 people who presented with heart disease and 120,000 controls. We said, which of the variants are more common in the cases, that's the risk variant, and which are more common in the controls? At the end of the study, we ended up with a simple list of 6 million variants, which were commonly variant in the population, and for each of them, an association with risk. We used a computational prediction algorithm to combine information from all of these variants into a single number called a polygenic score. And we then sought to validate that score in 300,000 people. So here I'm showing you the x-axis percentile of the polygenic score, and on the y-axis rates of coronary disease by the time people reach middle age. What you can see is a striking risk gradient from about 1% to 11% based on common genetic variation alone. Now, the traditional approach, as I mentioned, for genetics is to compare carriers to non-carriers. We said, what if we arbitrarily call the top 5% of the distribution a carrier and the bottom 95% a non-carrier? Well, here's what was really striking. We actually found that the risk was more than triple for those in the top 5% of the polygenic score distribution. We came back to our whole genome sequencing data set. Again, young people coming to the hospital with a heart attack. It turns out it wasn't 1.7%, but actually 17% of the patients who inherited a very strong genetic predisposition on the basis of a high polygenic score. In fact, the odds ratio was nearly identical, 3.7. Now, because this was a multi-ethnic study, we were able to look at this risk across race. What you can see is that in white patients, it was associated with about a 5-fold increased risk, whereas for Black, Hispanic, and Asian, it was between a 2 to 4-fold increase. Now, this doesn't mean that genetics is less important in non-white ancestries, but rather that we need more training data and new approaches for these other populations. And closing this gap is a major focus of my lab and others around the world right now. So these 1 in 20 people have very high genetic risk. Can traditional risk factors actually be used to pinpoint them? Here I'm showing you just baseline characteristics stratified by polygenic score. You can see family history is a bit more common, 44% versus 35%, hypertension, 32% versus 28%. And what you see is that all the causal risk factors are slightly enriched, but none enough to be useful in finding these individuals and picking them out from a crowd. So why is that? Well, it turns out if you look at just the top 50 most strongly associated variants, about 15 or 20% of them come from cholesterol pathways, which we do routinely measure. And another 20 to 30% come from pathways like inflammation, cellular proliferation, and vascular tone, things that we either don't or can't reliably measure within clinical practice. And the remaining 50% of variants, interestingly, we can say beyond a shadow of a doubt they are associated with coronary disease, but the exact underlying mechanism is largely unknown. And in some cases, we've been able to uncover new biology by studying these variants. But taken together, you can see why a polygenic score is largely orthogonal to the traditional risk factors we currently use in clinical practice. In fact, if you look at the association between the polygenic score and the pooled cohort equation, the 10-year risk estimator used in the United States, you see almost no correlation. And that's because the current equation is mostly based on age, sex, and smoking. Here we looked in the UK Biobank. On the x-axis, we stratified individuals based on their pooled cohort equation, 10-year risk. And a 10-year coronary event rate is shown on the y-axis. What you can see is that within each individual bin, you see a striking gradient according to the polygenic score. For intermediate risk folks, 7.5 to 20%, where we're often on the fence about starting a medication, you see the risk range from 2.8 to 8%. We went on to replicate these results almost identically in the Malmo diet and cancer study, an important prospective cohort study from Sweden. So what about earlier in life? And one of the main advantages of genetics is that you can calculate it from the time of birth. Recently, we studied the Cardia study, 1,600 people recruited in their mid-20s and followed for 30 years. I'm showing you first rates of coronary calcification, which ranged across the quintiles from 5 to 18%. This was at year 15 of the study period when folks were around 40 years of age. Look what happens when we move forward in time. By year 25 study visit, folks were about 50 on average. The rates of calcium range from 21 to 45%. So you can see that there's a striking difference in the trajectory of developing this subclinical disease. It turns out when you look at heart events, heart attack, or death, we see a very similar pattern where only about 1.5% of the people over the 30-year study time went on to develop a heart event versus 12% in the top quintile. Because we had both calcium and genetics, we were one of the first to be able to look at the interplay of the two factors. If you look at those with no calcium at year 15 and follow them up for heart disease, 1.2% of those with the low polygenic score versus 4.5% in the high polygenic score went on to develop disease. By contrast, for those with calcium present, as you can imagine, all of the risk was much higher. But here again, we see a gradient of 7 to 32%. So is DNA destiny? And does high genetic risk go on to mean you're predetermined to develop disease? Well, we looked recently in observational cohort studies at a healthy lifestyle. Here I'm showing you only those with a high polygenic score. And what you can see is that those with an unhealthy lifestyle had a risk of about 11%, versus the healthy, it was only about 5%. So associated with about a 48% lowering of risk for disease. What about medications? Well, here we went to look at data from statin trials. Nobody knew what their polygenic score was at the time. But what you can see is that in the placebo group, 20% of them went on to have an event versus only 12% for those on a statin. So there was a 44% relative risk reduction and an 8% absolute risk reduction for primary prevention. So this is really a high statin benefit group. So how do these pathways come together? And can polygenic background actually modify the penetrance of a monogenic variant? So penetrance in genetics means the probability that someone with the high risk mutation actually goes on to develop disease. So we designed a case control study of 13,000 people. We first confirmed that the monogenic familial hypercholesterolemia mutations were associated with about a tripling of risk. But we now layered in the impact of the polygenic score. And what you can see is that those with a low polygenic score but a monogenic mutation, the odds ratio is about 1.3, comparable to the population average. By contrast, for those who had both a high polygenic score and a mutation, this is what we consider a genetic double whammy. And they were actually predisposed to about a 13-fold increase in risk for heart disease. So here I'm showing you the traditional approach, which is monogenic mutation equals high risk, present in about 0.5% of people. On the y-axis here, I'm showing you the risk by age 75, which we estimated to be at 41% for those with the FH mutation versus about 3-fold lower, 13% in those who didn't. But look what happens if you now model in the impact of the polygenic score. The black dots are the ones I showed you before, but the blue dots, you see Even for carriers of these mutations, the risk ranges from about 18 to 78% based on common genetic variation alone. So it really stands to reason that the state of the art now is to look at both monogenic and polygenic drivers of inherited risk. In summary, polygenic scoring is a quantitative measure of inherited risk. It distills that risk into a single number. It's available from birth, which gives you the potential for a decades-long head start to overcome inherited risk. The risk prediction actually exceeds that of traditional risk factors, and high polygenic score individuals currently are flying under the radar in our practice. High polygenic scores up to 10 times as common as rare monogenic variants, and even for those who have one, it modifies their penetrance. Lastly, what's really exciting is that from a single test, the scores can be measured for a whole range of preventable diseases. So based on these observations, we set out to build a new preventive genomics clinic at my hospital about 2 years ago. And it's the genetic information to better understand, predict, and prevent disease. So who do we see? We guide asymptomatic individuals with a pathogenic variant like BRCA1 for breast cancer or LDLR for heart attack. We discuss genetic testing for symptoms or family history. And lastly, we want to be able to interpret the genome for those who are curious or concerned for any reason. In this slide, we were very excited last December to launch the first clinical test in collaboration with Color Health, a company in the Bay Area, which is the first test to look at both monogenic and polygenic risk for coronary disease. The test involves sequencing very carefully the familial hypercholesterolemia genes and a low coverage sequencing, which allows to capture all the common variants that are needed for the polygenic score. So the test costs $249 at current pricing, but the pilot was able to offset costs for the first 100 patients. So the first patient was actually a 49-year-old man who came in with a heart attack, but he had no traditional risk factors. And here the question was, well, why did this actually happen to me? Second, a woman with was 30 years old with a strong family history and mildly increased cholesterol, too early for calcium or the risk equations to really be that helpful. And here the question was, should I start a medication? And the genetics actually prove useful in that shared decision-making process. So for the first 50 or so patients, we've seen about 24 of them based on a strong family history, about another 18 based on a personal history of cardiovascular disease, 9 were just concerned, and 4 had a very high LDL cholesterol. And so we're interested in both the familial hypercholesterolemia mutation, but also the polygenic background. So based on this, we gained some experience, which I think has been quite helpful in terms of how we might tailor clinical management. Things like statin intensification or initiation, additional testing, things like coronary calcium or lipoprotein A, recommitment to lifestyle measures, and other ways we can try to tailor this approach. And we're looking forward to being able to share that data with the scientific community. And overall, when we looked at the patients, 94% of them actually reported learning very valuable information about their health from this genetic risk assessment. So in conclusion, genome interpretation for cardiovascular disease does require assessment of both monogenic and polygenic drivers. A high polygenic score, which we defined as the top 5% of the distribution, actually confers risk that's equivalent to a familial hypercholesterolemia mutation, about a tripling or even quadrupling of risk. DNA-based risk assessment is available from the time of birth, giving high-risk individuals a decades-long potential head start for prevention. There's a key need to improve genetic risk estimation across ancestry and also develop integrated genetic and non-genetic models, which is something we're actively working on now in my group. And lastly, this integration of genome interpretation into routine practice, as we started to do in our preventive genomics clinic, will require new clinical infrastructure and also new evidence. So thank you so much for listening, and I very much look forward to your questions.
Thank you, Dr. Kara. That was a really enlightening talk about polygenic risk scores and how they play a role along with the monogenic disorders that we traditionally have been looking at. With that, we'll move on to the last talk of this session, last but not the least important, in fact, fairly important. And we're going to be talking about new concept in CVD risk assessment, social determinants of health. And this talk is going to be given by Dr. Khurram Nasser, who's currently serving as chief for the Division of Cardiovascular Prevention and Wellness at Houston Methodist DeBakey Heart and Vascular Center. And Dr. Nasser also serves as the co-director for Center for Outcomes Research at Gerald B. Katz and a Gerald B. Katz investigator for the Academy of Translational Research. at Houston Methodist Hospital. So let's welcome Dr. Nasser and listen to his talk on social determinants of health.
Good morning, everyone. Welcome to the second annual Houston Methodist Cardiovascular Prevention Symposium. It has been a wonderful morning so far, learning at the traditional and emerging risk assessments domains. So today I will talk about some emerging consideration regarding social determinants of health. Now, as a preventive cardiologist, it gives me an immense pleasure and also pride that despite being the #1 cause of morbidity and mortality for so long, as a community, we had made significant strides over the last 3 decades, cutting into our losses. And if you look at the trends, it appears that very soon we will be losing the #1 killer tag in the US. However, that bothers many of us that unfortunately, these gains have not been equal, and many of our most vulnerable individuals have left behind. For example, data from CDC shows significant racial and disparities in CV risk factors, especially among African Americans and Hispanics. Non-Hispanic Blacks are more than twice likely to die from heart disease compared to other minority groups, pointing to a fact that there is still significant ambiguity to potential significant unencountered factors beyond traditional assessments that may point towards these disparities. Now, also as recently shown by Doctors Mahajan and Carabello from Yale, that in the last 20 years, while there have been modest improvement in racial gaps for insurance coverage, mostly in the last decade, there has been no substantial reduction in access to care. The gaps in foregone or delayed medical care have persisted, potentially contributing to the long-standing, persistently elevated risks seen in minorities and vulnerable populations. Apart from racial inequities, disparities also form along several societal fault lines, and many believe that the deepest and most persistent divide surrounds income. America poors of any race or ethnicity, as shown in this paper by Dr. Villaro, are more likely to suffer adverse cardiovascular risk profile than well-off Americans. In fact, these differences not only persist, but continue to grow over time. Those in the lowest income group were 36% more likely to have at least 4 established cardiovascular risk factors. And these disparities between the highest and lowest resource groups have widened, with nearly 25% increase versus none seen in those with the highest income group. In a similar fashion, Hannah Verma, a pre-med student at Yale, and Dr. Villaro, a senior author, suggested that even beyond access and insurance, pre-screening for cardiovascular risk factors and general counseling lacks significantly across the income divide. Though we are pleased that in the years after the passage of ACA, disparities for 3 out of the 5 preventive services studied have narrowed, though still the persistent gaps remain a major concern. So, now, important insights generated in our clinical interactions, as highlighted by the previous speakers, do relate to cardiovascular disease risk. It is also becoming clear that in our aspirations and pursuits of health does not only start in the clinic, and the impact of the conditions in which people live, learn, work, play, grow, affect a wide range of health and quality of life risks and outcomes, also commonly called social determinant of health, which we believe readily outstrips the impact of the best medicine can provide. But the big elephant in the room is how do we incorporate that in our risk assessment decisions? For this, in a recent white paper led by Hashim Jilani, as well as our star fellow Zulkarnain Heather, while we addressed this topic more broadly, we also provided recommendations from the cardiovascular risk assessment and management perspective, and how we can reimagine the complex interplay of wide range of upstream SDOH markers with potentially downstream intermediate determinants of risk. But more importantly, how do we systematically approach this process? First, to date, there appears to be more, and rightly so, focus on the main categories such as highest education attained, income, and insurance. However, it's becoming more clear that we need to think beyond the big 3 and also pay attention to additional factors such as neighborhood and physical environment conditions, access and quality of food, community and social network, and host of healthcare barriers beyond insurance. For example, in the wealthiest country in the world, as shown by Dr. Mahajan from Yale Navy, 1 in 7 individuals with cardiovascular disease, about 3 million nationally at national level, have limited or uncertain access to adequate food, something that we have paid little attention so far. Now, I cannot think that with this information on hand, how can we make medically sound care decisions on the cardiometabolic risk in silo, considering that housing and food insecurity, all associated with lack of access to healthy nutrition, increased risk for diabetes, hypertension, foregone medical care, and medication adherence. All of these factors contribute independently to the CVD risk. The second step is that not only we need to broaden our overview of the SDOH domains, but we also have to think deeper beyond the main components. For example, while insurance and education are the predominant pillars of social risk, there are many additional independent features in these domains that we have not yet paid much attention. For example, now we know that beyond mere income, which may not capture the full picture of economic instability in healthcare, especially where the number one fear of the US public, irrespective of income, is bills out of pocket cost and death related to medical care, where 1 in 10 low income have catastrophic healthcare expenditures. 20% can't pay their medical bills at all, and directly related to cost related non-adherence, foregone medical care, poor quality of life measures, and risk of depression. Now think for a moment how and why these issues are not considered in our risk profile. No wonder the inaccuracies of the current conventional risk assessment tools. A third step in this strategic framework is probably learning from our genetic colleagues, such as Dr. Khera, who eloquently shown that the manifestation of cardiometabolic disease, especially, rather than being influenced by a few major genes, is more likely to be manifest by multiple interacting genes, the polygenetic risk score. So can't we agree to broaden our overview at the complex, interconnected social risk factors in aggregation than looking at them individually? I think that's possible and can be done at 2 levels. The first is at the population or census level. Safi, our star cardiology fellow, in an upcoming circulation paper, reminds us that you can use simple measures like social vulnerability index, which is a composite measure at the census level, accounting for socioeconomic status, household composition and disability, minority status, language, and transportation. Basically, it was used to guide public health officials respond to emergency needs in the community. However, as you can see, it also almost in one-to-one predict which zip codes are going to have the highest risk of premature risk, cardiovascular disease. Clearly, where you are born, live can be a more important predictor than just your genetics. I want you to pause again for a second. Think for once, would these populations have the same risk of cardiometabolic disease? Recently, also, as you have seen what Safi has done, we also expanded that at an individual level, and we took a massive undertaking of aggregating about 39 individual subcomponents across all 6 domains highlighted at an individual level in a US nationally representative population, which is the National Health Interview Survey. I can definitely detail all the factors that were accounting offline if anyone is interested. And coming back again, Safi again in a team of energetic postdoc asked whether we can capture at a patient level social risk for premature stroke without the requirement of presence of individual risk factors. For example, in this paper soon to be published, we found a curvy linear relationship of prevalence of stroke among the young, as you can see across the accumulative polysocial risk score, especially in the last decile, with tremendously increased risk of stroke, something we have interestingly noted in the polygenetic risk scores. Also, those with this high polysocial risk scores are nearly 3-fold higher likely to have a history of stroke even after adjusting for demographics and traditional risk factors, and similar relationships is seen across aging, gender, as well as additional race ethnic subgroups. Zulkarnain Javed from our group also further showed similar good distribution of polysocial risk score among those without and with CVD, and suggested that maybe an abbreviated version rather than the expanding can provide similar discrimination with the same degree of association across all age groups, independent of traditional risk factors. In addition, Dr. Garima Sharma from Hopkins showed that the same polysocial risk score can also identify pregnant women with poor cardiovascular health that we now know are not only associated with downstream poor risk in these women, but is also associated with offspring cardiovascular health at ages 10 to 14 years. I think there's no better place to enhance population health than thinking about this group. Clearly, if at the national level, the goal is to promote population health while addressing social factors, I think so there is no better opportunity than to target and focus on the most marginalized individuals that can be identified by these polysocial risk scores. In conclusion, I think we have come a long way over the last 2 decades, going from a place where we focus mostly on risk factors and scores, expanding our arsenal around select biomarkers, and now well-established imaging-based disease detection, such as coronary artery calcium, to a horizon of a polygenic risk score, which should be there in the near term. And I'm hoping that we can complete this cycle by diligently assessing the independent impact of the polysocial risk score for cardiovascular disease. And eventually we can incorporate that in our risk models, so that we can ensure equitable capture of risk, especially among the most vulnerable segments of our societies. Thank you so much for your attention.
Excellent. Well, thank you so much for that excellent presentation from Dr. Nasir. And so now I'd like to introduce again Dr. Virani, who's going to help lead our question and answer for this next session. Thank you, Dr. Virani.
Sure. So I think this was a fabulous session talking about 4 pillars of cardiovascular disease prevention. So we talked about lipid markers, biomarkers, we talked about imaging, we had a very good talk on polygenic risk scores, and then just to top it off, the new kid on the block, which used to be polygenic risk score, now it's the social determinants of health. Of course, social determinants of health have always been there, but we're realizing more and more now how important they are. So with that, I thought we'll start out some discussions and have some questions. And please, everybody, chime in. Our first question for Anne-Marie, fabulous talk, by the way. For a practicing clinician, you know, there's always this tension between non-HDL cholesterol and ApoB. Some people call non-HDL cholesterol a poor man's ApoB, and depending on which meta-analysis you look at, one can perform better than the other. They can both perform as well. So do you think that there is a need to go beyond non-HDL cholesterol, since the correlation is almost close to 0.9, 0.92? How do you think a person should use it if they are also calculating non-HDL cholesterol in their practice? Do they need to measure ApoB? What are some tips you will provide to practicing clinicians?
So I'd like to keep it simple. And although non-HDL is probably better than LDL cholesterol, it's pretty consistent that ApoB is slightly better than non-HDL. The other nice thing about ApoB is it's less subject to some measurement error, particularly if your patients are non-fasting, because you're measuring particle numbers and not trying to infer based on the amount of triglycerides or other things in the blood. I also like ApoB over non-HDL cholesterol in patients who I'm treating with PCSK9 inhibitors and getting their LDL cholesterol very low, because you end up with a little bit more accurate than you get these weird numbers for LDL cholesterol. So for me, rather than try to decide when I'm going to stick with non-HDL versus ApoB, it's just easier for me to order an ApoB and track that. It's also really easy to explain to a patient what it means. And so, we're counting the number of dangerous particles that you have. So my practice is generally just to get an ApoB on all of the patients that I see in clinic.
Thank you. That was very helpful. Ron, going towards the talk you had, quite a lot of data that has recently come out on the use of CTA, especially with plaque morphology, especially in symptomatic patients. What is your recommendation? Where are we right now with the use of plaque morphology when it comes to asymptomatic patients? Do we gain anything beyond calcium score? And you showed some data from Scott Hart, and I know you and others have been involved with the CAC consortium as well. What do you think are some practical tips that clinicians can have for use of CTA, if any, in asymptomatic patients for risk assessment beyond calcium score? What are some tips you can provide us, since you're just the expert on this topic?
Yeah, Salim, that's a great question. It's probably one of the most popular questions that I'm asked these days. And I would say, there's pros and there's cons. The advantage is you can identify non-calcified plaques. So you have to think, who are the patients who are most likely to have it? It is young patients with FH. It is patients with systemic inflammatory diseases, probably patients with diabetes, patients with HIV as well who are young. So certainly in some subgroups, there's going to be the advantage. You're going to pick patients that have a large burden of non-calcified plaque. Having said that, for most of our patients, they're also going to have calcium as well in addition to that. So calcium scoring is going to identify most of the asymptomatic patients. But we have to say, can we add, and probably we can add a little bit by looking at non-calcified plaque, but it's going to be more expensive. And I'll tell you that the biggest concern I have is that when you start doing coronary CT in asymptomatic individuals, you may find occasionally those with mild or moderate stenosis, individuals that all of us know that all they need is preventive therapies. But now somewhere in the US, there's going to be the potential implication of now doing unnecessary testing on an asymptomatic person just because of what we saw in a CTA. So that's actually the biggest concern in the field. I have to say, I mentioned the Scott Hart trial. There's actually an ongoing Scott Hart 2 that's specifically looking at outcomes in asymptomatic individuals who are now randomized to have coronary CTA. So stay tuned. We'll have some more data from that and other trials, but it's an excellent question. I think as of today, you have to be selective. For most asymptomatic, a calcium score, there's probably some exceptions, some patients in whom a coronary CTA might make sense.
And on the same lines, this question comes up quite often. And I think, Khurram, you should also chime in on this particular question. You have some patients who are in their mid-30s, very positive family history, early 40s. Typical patient would be a South Asian or somebody from Middle East who's coming to see you, and dad had an MI at the age of 42, 43, and they're 35, 36 right now. Calcium score is 0. Is that somebody you would look more closely, not in everyone, but in these particular cases with a CTA, and see maybe you can pick up some early non-calcified plaque? Is that something you would recommend in very select cases? And then, Khurram, you should chime in on this one.
Yeah, it's a good question. I always tell young individuals that if you have we'll do the calcium score, but if it's 0, you're definitely not out of the woods. We're only using it in young individuals that if you have plaque, even a small amount, you're at higher risk. So I think in that case, it might make sense to use a coronary CTA if we think the results would change how we treat them.
So, would you like to comment?
Yeah, I think so. This is a fantastic question. We see this pretty much often in our clinics these days. And as you know, the paradigm shifting more to the younger people. The question is if and what's the role of the coronary calcium score. So most of the data to date has been for middle-aged adults above 40 years, but emerging studies from Cardia, some work from Mike Blaha, and a recent study from Denmark did suggest that individuals with family history and multiple risk factors such as metabolic syndrome, at least you can identify 1 in 3 or 1 in 4 those who may have early plaque. Now, any plaque in a 35-year-old, you should consider that something like a calcium greater than 160. The most aggressive therapies, it's not just only about statin or aspirin, but all the other cardiometabolic therapies that Ron just mentioned. Now, the question about the non-calcified plaque, I think so it's an open-ended question. And recently, with collaborators and of course you on board, there is a study being launched in Pakistan that would be enrolling around 2,000 individuals with young men and women with family history and risk factors to assess this very question: what is the presence of non-calcified plaque? I truly think that it's going to be a more comprehensive approach. Of course, aggressive lifestyle and minimal therapies, even if the calcium score is 0. But I think early plaque detection will help us move them into the high CVD risk that should also include other emerging interventions.
I think those are very practical tips and very important questions that we all are looking for answers. Moving on, Amit, as always, fabulous talk. Every time we listen to you, even if it's after 2 months, there is some new data there. So kudos to you and the entire team for not just moving, but moving very quickly in this area, which is just a growing area. I think that the question I would ask is, as a practicing clinician, when you get these polygenic risk scores, and then you all started this now, in these patients, the last few slides you showed as well. Amit, what are some of the practical tips you have in terms of communicating this polygenic risk with the patient? And maybe if then the patient wants to have the entire family get screened, what are some recommendations? So 2 questions. What are some best practices that you have in terms of communicating? And then if you do find somebody who's in the 98th percentile, what do you tell them about their family when it comes to polygenic risk score?
Yeah, sure. It's an exciting area and an open area of research, how best to communicate this new type of genetic risk factor. We've kind of made a point to really make static PDFs and do comprehensive user experience testing to try to test it out. And I think it's important for us to think we're going to educate both the patients and the clinicians about this new type of risk factor, which at least I think will be quite powerful moving forward. But I think I would say it's pretty analogous actually to what Dr. Blankstein discussed about the calcium score, which is if it's high, I think it's quite important and suggests that they really are on a very different trajectory from the time they're born. If it's low, I don't think it necessarily means they're out of the woods, because you can outdo good genetics with other risk factors. So I think it's like any if you measure cholesterol or blood pressure, most people are in the middle of the distribution. So it doesn't necessarily change how you think about the patient in a major way. But some meaningful proportion, let's say top 10%, top bottom percent, actually have the risk meaningfully changed based on this. So I tend to talk, if it's in the middle, I say, you're about average genetic risk. And that would be communicated in that way. But we're really looking to find people in the very extreme tails where we think the risk increment is quite substantial. And then I think for the implications on the family, I would say, so if you think about a traditional approach, a monogenic mutation, if I have a familial hypercholesterolemia mutation, on average, half of my siblings will have it. But it's a 0 or 1. Half of them will and half of them won't. Versus a high polygenic score, assuming we have the same parents, on average, the score is actually the same. So if my mom scores a 0, my dad scores a 1, on average, it's about a 0.5. And so you can reasonably surmise that a sibling with the same parents would have a roughly similar polygenic score. And that's a conversation I have with the patient. Is it important to quantify that, or is it not? I will say that just by chance, right? Like with meiosis, there is a distribution around it. So if your dad scores 0, your mom scores 1, on average, all the siblings would be 0.5, but there is a distribution. And we actually showed recently that if you actually say 2 siblings, one's affected by disease and one's not, how often is it the case that the one who got affected had a higher polygenic score? And the answer is about 70% of the time. So it can explain these subtle differences from 0.5 do explain why one sibling might get affected and the other might not.
Very nice. And then maybe one more comment, since we have the imaging experts here and we have a polygenic risk score expert. We always say that imaging is the risk integrator, right? I mean, whatever risk you have, whether it's biomarkers, lipids, blood pressure, diabetes, unknown risk markers, possibly social determinants of health, if they're coming through a biologic pathway, which of course they don't, they go through a lot of other pathways that could have alluded to. Do you think So there is a role, of course, as you very nicely showed, in early part of life when you may not have imaging at a point where it's clinically detectable. But let's say that you have somebody who's 45, who has a calcium score of 0. Do you think doing a polygenic risk score would be helpful? Or 50 years old, where you may be able to pick up some subclinical athero? So if that's negative, or do you think that there could be other pathways for these polygenic risk scores where something like imaging, which we always think of as a risk integrator, is not capturing? What are your thoughts? And I don't expect that we have very good data. You showed some in one of the slides, but where do you think that question would lead us?
Yeah, I mean, I also use imaging a lot, and I find it incredibly useful. But I would say imaging's CAC score of 0 just means you haven't developed calcium yet, and it doesn't mean that you won't. And for a middle-aged person with a calcium score of 0, we do know that there's a number of different risk factors that could be used to refine that risk estimate. You could take socioeconomic factors into account. You could measure ApoB. You could measure polygenic score. What we do know is that the polygenic score tends to have a little bit better risk discrimination increment compared to the other risk factors that I mentioned, but all of them could have a role. And so I think it's that does get into the art of medicine, which test you order, and then also would you order several at once. So it's never going to be the case that any factor for a complex disease is going to cleanly separate people who go on to develop disease and won't. They're going to be highly overlapping distribution. That's what we see for cholesterol, ApoB, polygenic score, and everything. So it's really important to just understand, like, you're not going to, get an AUC of 1, right? You're going to modestly increase AUC by 0.02, 0.03 for any of these risk factors. And, if you've seen in that light, I think the polygenic score stacks up pretty favorably with all the other ones.
And I think, Celine, your question gets at the concept that there is going to be an age, and we can argue what that age is, when you're in your 60s or 70s. If you have a calcium score of 0, I think regardless of the genetics, you have something that's protecting you. And I think the value of the polygenic risk score is going to be lower. And of course, there's on the other end of the spectrum, an age where a calcium score of 0 is not going to mean a whole lot, and the genetics are going to be much more powerful at predicting. In your question, thoughtfully pick the age of 45, where there's probably a contribution of both. I guess we can decide in those 3 scenarios how much each test might add.
Exactly. I think I think that's where the precision medicine concept is going, right? What age do you say, okay, fine, if I don't see anything on imaging, I think I'm done. Khurram, going back to you, I know you've pivoted quite a bit lately in social determinants of health, the entire group, with some fabulous work. Of course, whenever we talked about social determinants of health, if we look a decade back, it was all policy level interventions. And now, of course, all the guidelines talk about it as well. There are separate sections in each of the guidelines. Based on this tremendous body of work, what are 2 or 3 practical recommendations for clinicians who might be listening to you today? If there are 2 or 3 messages that they should think of, what would those be? How to use them in practice?
Yeah, as you pointed out, a very complex issue, and it's hard, but of course, learning from all the groups, the journey from risk factors to imaging, the polygenic concept, and how do we try to incorporate that into the practice. I think so the easiest one is use census level data to really identify those at risk. There are ongoing efforts where simple questionnaires that could be around 10 to 15 questions can truly identify those who are at the highest risk. For example, what we are finding, premature stroke, 1 in 2 of these individuals without the knowledge of any risk factors have stroke. So how do we incorporate that? And as you're seeing that the risk factors and the disease progression is likely going to be different, their interventions are going to be different. And in this day and age, when we have significant tools of I would say management, which are going to be very costly, without the incorporation of your social risk, I just don't think we'll be able to do justice not only for that, but also for the incidence of diabetes, hypertension, cost-related non-adherence. Now, how do we incorporate that? I think so all of us needs to get together, especially with the HA. I'm sure that you're leading some of those efforts, and hopefully by the next version, we'll have some more practical tips, as you pointed out. But I would say start screening. You don't need to go broad. Use census level. A simple 5 to 10 questionnaire would help too.
Thank you. That's very helpful. Anne-Marie, I'll ask a very quick question to you, a short response. Lp(a), we all talk about it. We always get worried because of the ethnic differences, very different distributions, blacks versus whites, Hispanics, South Asians have another distribution. What do you say in terms of that question? Should I use one threshold or not? And I know Amit's group has also done some work in that space from the UK Biobank study, but what do you tell people when they say that, do I use one cutoff for every ethnic group that I'm looking at?
The short answer here is we don't know yet, but I do know that extremely high levels of Lp(a) confer extremely high risk of cardiovascular disease, equally to what we would see in somebody with familial hypercholesterolemia and extreme elevations of LDL. So the first part is, for the vast majority of people, it doesn't matter. It's sort of low normal or extremely high. Those who are sort of in the middle, there's some nuance there. And I think we can just be honest with our patients and say, your Lp(a) is high compared to the general population. It may not be as high if we just looked at people of your same race or ethnicity. But so far, the biology suggests that elevations confer equivalent risk, even if the distribution is slightly different. So especially as we're looking at development of new therapies to lower Lp(a), I think it's important that we at least start to measure. And the more that we're measuring, the more we'll be able to tell what truly is an appropriate population reference range, and should be different for men and women or different racial ethnic backgrounds.
Thank you. So with that, we will conclude our first session. I thank all our speakers, not just for the talks, but also for the Q&A and the discussion session. I know I personally learned a lot, took a lot of notes. And with that, we'll finish our first session. And we'll move on to our second session, which is going to be as great. So I'll give it back to you, Karan.
Salim, thank you so much. And then again, Dr. Nawar, Dr. Blankstein, Dr. Kara, thank you so much for having this wonderful discussion on the 4 pillars of cardiovascular disease risk assessment. Now, moving ahead, I couldn't be excited more about the next sessions, which are going to be practical tips on developing CVD, focus on CVD prevention beyond the risk factors. So to start with, of course, I'm very delighted to introduce my co-director, Dr. Karsha Patel, who is also the director for cardiometabolic clinic at Houston Methodist and assistant professor at Weill Cornell Medical Center, focusing really, giving us insights on why we should start thinking beyond just cardiovascular disease and why it's important to focus on heart failure. So Karsha, thank you so much.
Thank you, Dr. Nasir, for organizing the Cardiovascular Disease Prevention Symposium and for inviting me to speak during this wonderful forum. Today, we're going to go beyond atherosclerotic cardiovascular disease prevention and also focus on heart failure prevention. I have no conflicts of interest, but there will be some off-label discussions of medications, but this will be based on published data. So let's get started. Heart failure is common, affects over 6 million adults in the United States, and is associated with increased morbidity and mortality. So here we see that heart failure mortality has been increasing dramatically since 2011. And taken together, it suggests that it is imperative that we develop heart failure prevention programs to combat this growing epidemic. Cardiovascular disease prevention programs should go beyond preventing atherosclerotic cardiovascular disease to also include heart failure prevention. Our understanding of heart failure pathophysiology and development has evolved over the years, and we recognize that heart failure develops over multiple stages across a spectrum, from risk factors to adverse cardiac remodeling to clinical signs and symptoms of heart failure, and subsequently, in some cases, refractory heart failure. The 2013 Heart Failure Guidelines highlight these 4 stages and can be broken down into 2 major categories: the at-risk stage for heart failure and clinical heart failure. So in clinical practice, we commonly care for patients with stage C heart failure, and our advanced heart failure colleagues engage with patients with stage D heart failure. But what about stages A and B? Well, this at-risk stage is a much larger group of patients, and I believe that preventive cardiology programs should also be considering this patient population. So we're briefly going to go over the 2013 Heart Failure Guideline recommendations, while the remainder of this discussion will highlight some of the more recent developments in heart failure prevention. So in 2013, the heart failure guideline recommendations were clear and recommended that blood pressure and lipid control should be based on contemporary guidelines. For stage B heart failure, among patients with reduced left ventricular ejection fraction, those patients should be prescribed evidence-based beta blockers, angiotensin converting enzyme inhibitors, and angiotensin receptor blockers. And there's also a class 3 recommendation for patients with reduced left ventricular ejection fraction to avoid non-dihydropyridine calcium channel blockers. So in 2013, the authors also made a call to action for heart failure prevention, identifying 3 major needs, specifically screening tools, strategies to modify heart failure risk factors, and effective treatments to prevent the progression of heart failure across those stages. Well, since 2013, there have been major developments that we'll go through. So these are data from the St. Vincent's Screening to Prevent Heart Failure study, which was a randomized clinical trial that enrolled over 1,300 patients with risk factors across multiple sites in Ireland. BNP, a specific type of natriuretic peptide, was measured in all participants at baseline and annually. And then participants were randomized to either a usual care arm or an arm of BNP-driven care. So the providers for patients taking care of participants in the BNP-driven care were disclosed the BNP levels. And for those with a BNP greater than or equal to 50 picograms per ml, those individuals underwent echocardiograms and referrals to cardiologists, as well as risk factor management and lifestyle counseling. And so after about 4 years, the primary endpoint of a composite of heart failure or left ventricular dysfunction had a lower odds of 45% in the BNP-driven care arm, suggesting that BNP-driven care and natriuretic peptide-based screening programs may be helpful for prevention of heart failure. In a different trial design, specifically the Pontiac trial, these investigators enriched their patient population with patients with type 2 diabetes and high risk for developing heart failure. Specifically, those individuals had to have an elevated NT-proBNP greater than 125 picograms per ml. Participants with a history of cardiovascular disease were excluded, and so 300 patients were randomized either to routine care or cardiology care with intensified treatment focused on inhibition of the renin-angiotensin system. Specifically, patients were initiated and intensified therapies with ACE inhibitors and beta blockers, and these agents were up-titrated to achieve reductions in NT-proBNP levels as well as target doses of these medications. And so we can see here that neurohormonal blockade in the treatment arm of this trial led to a reduction in the primary composite endpoint of cardiovascular hospitalization or death. So taken together, these data led the writing committee of the 2017 update to the 2013 heart failure guidelines to endorse biomarker-based screening combined with team-based care to prevent heart failure amongst those individuals who are considered at risk for developing heart failure. So now we're going to talk a little bit about risk factor modification. And first, I want to highlight lifestyle factors. So it's been increasingly recognized that there are 2 distinct heart failure subtypes, specifically heart failure with preserved and heart failure with reduced ejection fraction. Now, recent data suggests that lifestyle factors may have a differential impact on risk of those heart failure subtypes. So in this pooled analysis of multiple epidemiologic cohorts, we see that higher levels of physical activity was associated with lower risk of heart failure with preserved ejection fraction, but not heart failure with reduced ejection fraction, suggesting physical activity may be associated with differential risk of heart failure subtypes. Now, similarly, in a patient population with type 2 diabetes, we saw that declines in specific measures of fat, such as total fat mass as well as waist circumference, were both associated with lower risk of heart failure with preserved ejection fraction, whereas the total reductions in fat mass over 1 year follow-up were associated with lower risk of heart failure with reduced ejection fraction. In contrast, changes in waist circumference were not associated with heart failure with reduced ejection fraction, suggesting again that there may be differential contributions of specific factors with heart failure subtypes. So now we'll focus more on traditional heart failure risk factors. For now, we're going to discuss hypertension. And so the 2017 update to the heart failure guideline recognized the benefits of intensive blood pressure lowering to a target blood pressure less than 130 over 80 millimeters of mercury for preventing heart failure. And that was based on findings from the SPRINT trial. Now, briefly, I want to highlight some of the major findings from the recent STEP trial, and I hope we have the opportunity to discuss this more later on. Now, in this patient population of more than 8,000 adults aged 60 to 80 years from China with hypertension, participants randomized to a systolic blood pressure goal of 110 to 130 millimeters of mercury versus 130 to 150 millimeters of mercury had approximately a 26% reduction in their primary composite cardiovascular endpoint that included stroke, acute coronary syndrome, heart failure, coronary revascularization, atrial fibrillation, and cardiovascular death. Now, looking at one of the individual components of that primary composite endpoint, heart failure risk was also dramatically reduced with intensive blood pressure lowering, targeting this lower systolic blood pressure goal. Now, one of the major differences between the STEP trial and SPRINT were that STEP enrolled approximately 19% of individuals who had diabetes, whereas in SPRINT, no patients with diabetes were included at baseline. So now I want to talk a little bit about a new class of agents that has emerged as a heart failure risk reduction therapy in type 2 diabetes. Now, the sodium glucose cotransporter 2 inhibitors were originally developed to improve glycemic control. So briefly, these SGLT2 inhibitors, as I'll refer to them as, these work to lower glucose in the serum by preventing the reclamation of glucose in the proximal tubule of the nephron, leading to glucosuria and a reduction in blood sugar. Now, originally studied and evaluated to improve glycemic control, the FDA changed their guidance to industry and actually required these agents to undergo large-scale cardiovascular outcome trials to demonstrate cardiovascular safety. And serendipitously, we saw across several large-scale randomized clinical trials that these agents in type 2 diabetes reduced the risk of heart failure. And these were in secondary prevention as well as primary prevention. Specifically in this pooled analysis of multiple cardiovascular outcome trials, we see that the benefits for heart failure hospitalization were seen across both patients with and without established atherosclerotic cardiovascular disease. Now, these findings have been recognized by the European Society of Cardiology in this 2019 guideline, identifying with a class 1A recommendation that certain SGLT2 inhibitors can reduce the risk of heart failure hospitalization. And just briefly, I want to mention that there are other specific agents that are not recommended for patients with heart failure, specifically saxagliptin. Now, the 2021 ESC heart failure guideline that was recently published highlights also the role of SGLT2 inhibitors to prevent heart failure and adds other agents within this class for individuals with diabetes and high risk for cardiovascular disease to prevent heart failure. So we've touched on medications working on the renin-angiotensin system, and we know a little bit about mineralocorticoid receptor antagonists like eplerenone and spironolactone in heart failure with reduced ejection fraction. However, there's a relatively newer agent called finerenone, which is a selective non-steroidal mineralocorticoid receptor antagonist that's recently been evaluated in large clinical trials. And so these are data from the Figaro DKD trial that enrolled individuals with type 2 diabetes and chronic kidney disease from stage 1 to stage 4. Now, this trial excluded individuals who had heart failure with reduced ejection fraction, and they observed a reduction in their primary composite endpoint of CV death, myocardial infarction, stroke, and heart failure hospitalization. And in looking at one of those, the heart failure endpoint, we see that there was also a dramatic reduction in the risk of heart failure hospitalization. Now, whether finerenone can reduce the risk of heart failure in patients beyond those with DKD, so that remains to be seen. And hopefully we'll get more data to see what this agent can do from a heart failure prevention in a more broader study population. But those data, hopefully we can see sometime in the future. Now, finally, I want to just highlight that there are heart failure risk prediction tools. So this is a risk prediction tool called WatchDM, which is a risk score that is used to estimate heart failure risk among patients with type 2 diabetes. And we see that it includes readily available clinical characteristics that we oftentimes obtain just in our examination of our patients with type 2 diabetes. And this stratifies 5-year risk of heart failure quite well. Additionally, there are risk scores available to estimate heart failure risk in the general population, as observed here in the pooled cohort equations to prevent heart failure, the PCPHF, led by Dr. Kahn. So I want to thank you again for your attention, as well as for allowing me the opportunity to share with you some insights about heart failure prevention. And I'm looking forward to learning from all of the other speakers in this session, as well as the others, as well as look forward to participating in the question and answers. All right, thank you so much.
Dr. Patel, thank you so much for reminding us that cardiovascular prevention is not only about heart attacks and strokes, but heart failure is a critical component. Now, moving along, it is truly a pleasure to introduce my dear friend, Dr. Michael Blaha, Professor of Cardiology and Medicine at Johns Hopkins, and Director of Cardiovascular Prevention Research at the Ciccone Center for Cardiovascular Prevention. He will be talking about his suggestions, insights, practical tips, how to manage high-risk cardiovascular disease among patients with diabetes. So Mike, thank you so much for joining us. Look forward to hearing from you.
Thank you so much for having me today. Present on an important topic, practical tips for managing cardiovascular risk amongst high-risk diabetes. My name is Dr. Michael Blaha, and I work at Johns Hopkins Hospital. I think that managing diabetes in preventive medicine or preventive cardiology is one of the most important topics in 2021 because of the advent of the new cardiometabolic therapies that reduce cardiovascular risk that have been slow to be implemented in cardiology practices, especially with the advent of things like cardiometabolic clinics, which our institution and many others are developing. It's important to get everyone on the same page with who should be treating diabetes and what drugs we should be using to manage cardiovascular risk. So let's start today with the case. Let's consider a 55-year-old woman who's a smoker. She has stage 2 obesity, and she has subclinical coronary disease. In fact, she had atypical chest pain in the past and had a CT angiogram which showed diffuse, mild, moderate atherosclerosis, including a nearly 50% stenosis of her mid-LAD. She has a history of prediabetes. And when you talk to her, she's got a family history of premature coronary disease. Her father had a cabbage in his 50s. She works as a bank accountant and has a sedentary lifestyle with no exercise. She's had mild doses of an antihypertensive and a statin. And her BMI is 36. Blood pressure is a little elevated at 140/80, and no signs of fluid overload on exam. You check new labs, and her new A1C is 7.1%. She's progressed to overt type 2 diabetes, but her creatinine is preserved, GFR that's well above 60. So the question comes up in a prevention clinic, what should we do for this patient? What changes should we make to her regimen? In particular, as far as her new onset of diabetes goes, what considerations would lead us to select new therapies for her diabetes? So let's summarize her case again real quick. The red flags in her case, she's a 55-year-old woman with a family history, obesity, sedentary lifestyle, and new onset of type 2 diabetes. So again, she has a family history, she has hypertension, she smokes, clearly has a history of insulin resistance, and she has that subclinical coronary disease highlighted by the 50% stenosis on her CTA and this new elevated A1C. So beyond intensifying her statin and, of course, talking to her about smoking cessation, I want to dive deeper today about what the next steps would be in your preventive cardiology clinics. What would we do next to lower her cardiovascular risk? And really, of course, that gets to her new diabetes. So what are the critical questions for her diabetes care? I would argue that number one, what should we start for therapy? Should we start, for example, a GLP-1 receptor agonist or an SGLT2 inhibitor or metformin for her? Or number two, if we choose to prescribe a GLP-1 receptor agonist or an SGLT2 inhibitor, which one should we choose? So let's dive into these questions. Let's take the practical question number one first. Should she be started on an SGLT2 inhibitor or a GLP-1 receptor agonist or metformin? Now, it's important to think back about the history of development of metformin and the evidence base. And one of the realities with metformin is there's never been a large, well-powered cardiovascular outcome trial of metformin or that supports the reduction of cardiovascular events with metformin. Yet, most all new therapies like GLP-1 receptor agonists and SGLT2 inhibitors were tested in cardiovascular outcome trials against a background of metformin therapy, where 80% of more patients were on metformin. And basically, the evidence supporting metformin for cardiovascular risk reduction comes mainly from non-randomized evidence and observational studies and suggest a moderate benefit. So really, the picture of metformin is a little muddled. There's no strong data supporting its use, but it has always been used as a background therapy in general. And really, the main reason that we recommend metformin to our patients is because of the long experience with it, and it's because it's cheap. As you can see here on the left, metformin, sulfonylurea, and TZDs are all very inexpensive generic drugs. On the right, you see the high out-of-pocket and then deductible cost for SGLT2 inhibitors, GLP-1 receptor agonists, and DPP4 inhibitors. So cost is always an issue, but really that is the reason why metformin has remained the first line therapy. So what do we do in a case like the patient I presented earlier? What do the guidelines say? So let's look at the European Society of Cardiology guidelines for diabetes care. And let's look specifically at the algorithm for treating patients with type 2 diabetes and ASCVD or at very high risk of ASCVD who are drug naive, like our patient. Now, no diabetes therapies, new diagnosis of diabetes. The first thing to consider is the risk of the patient. It says that the patient has existing ASCVD or is at high or very high risk of ASCVD. You go to the green box that an SGLT2 inhibitor or a GLP-1 receptor agonist should be your first drug of choice. And only if there isn't a high-risk feature or no ASCVD is metformin recommended as the first drug of choice. That's in the ESC guidelines. So what does it mean by high or very high risk of ASCVD? Well, if you look closely, it says very high risk of ASCVD, patients with diabetes and established CVD, or patients with an end organ damage like a microvascular complication, or who that have multiple cardiovascular risk factors. And when you look at those risk factors, those include age, hypertension, dyslipidemia, obesity, and smoking. Like many of your diabetes patients who have multiple risk factors, these are very high-risk patients. High risk would be a patient with a diabetes duration greater than 10 years and at least one risk factor. So most of your patients will be in that high or very high-risk group. And for moderate risk in the ESC guidelines, it's just those young patients with a diabetes duration less than 10 years. But importantly, there's another way to get in that high or very high-risk group in the ESC guidelines. For example, if your patient has had a calcium score and that calcium score is elevated, that would be a reason to push someone from that moderate risk category into the high or very high risk category. And while there's a class 1 recommendation for an SGLT2 or a GLP-1 receptor agonist in the ESC guidelines, there's only a class 2A recommendation for metformin in patients that are overweight or just moderate CVD risk. So once again, in these drug-naive patients, you're going to be thinking about a GLP-1 receptor agonist or a SGLT2 inhibitor first if they're high risk. So what do the ACC guidelines say? Well, they're much the same. In a patient who's 18 years or older with type 2 diabetes and one or more of the following: ASCVD, heart failure, diabetic kidney disease, or at high risk of ASCVD, with those high-risk features of ASCVD being risk factors such as age, hypertension, obesity, smoking, or dyslipidemia. On top of lifestyle, you're going to add a GLP-1 receptor agonist or an SGLT2 inhibitor as your first therapy. So the cardiology guidelines now are pushing you in high-risk patients towards thinking about an SGLT2 inhibitor or a GLP-1 receptor agonist earlier in the treatment cascade. So what do the ADA guidelines say? The ADA guidelines are just a little bit different in that they still recommend metformin as first-line therapy on top of lifestyle modification, as shown here. But then after that, it says if the patient is high risk of ASCVD or has existing ASCVD, chronic kidney disease, or heart failure, you're going to be picking an SGLT2 inhibitor or GLP-1 receptor agonist independent of the A1C for its cardiovascular risk reducing properties or its kidney risk reducing properties. And if ASCVD predominates, you're going to select a GLP-1 receptor agonist. And if heart failure or kidney disease predominates, you're going to lean towards an SGLT2 inhibitor. So really the guidelines are pointing towards earlier use of SGLT2 inhibitors and GLP-1 receptor agonists in the patients we commonly see in the cardiology preventive care practice. So practical question number 2 in such a patient, well, which one do we select in our patient in the case, an SGLT2 inhibitor or a GLP-1 receptor agonist? So I think this table from the ACC guidelines is extremely practical on this question. It helps compare the agents and helps you make decisions. The first thing to think about are contraindications, right? If a patient has severely reduced kidney function, a history of genital candidiasis or urinary tract infections, or a history of diabetic ketoacidosis, you're going to steer away from an SGLT2 inhibitor. Now, if a patient has a lot of gastrointestinal side effects that already exist, like gastroparesis, or active gallbladder disease, or recurrent pancreatitis, you're going to lean against a GLP-1 receptor agonist. Also, if there's a history of a rare genetic autosomal dominant MEN2 syndrome, that's also a situation where their GLP-1 receptor agonists are contraindicated. Now, the vast majority of patients won't have a contraindication, and you'll have to select between them. The SGLT2 inhibitors are oral therapies, while predominantly the GLP-1 receptor agonists are subcutaneous injections, although there is the oral version of semaglutide now available. Now, for heart failure and kidney disease progression, the data really resides with the SGLT2 inhibitors. That is where these drugs are the strongest. Now, when it comes to weight loss, of course, GLP-1 receptor agonists are the strongest. In fact, they're probably the strongest weight loss drugs ever marketed, and in fact have an indication at high doses for weight loss. As far as MACE prevention, 3-point MACE prevention, the drugs are really similar. They both offer prevention of heart attacks, strokes, and cardiovascular death in the cardiovascular outcome trials. And what I'll add to this, of course, is really the impact of the weight reduction in your patients that are already quite obese, and the stronger A1C reduction in patients with GLP-1 receptor agonists that might lead you towards that in select patients. So really what it comes down to, I think, is some of the mechanistic differences between the drugs, where really, as far as anti-atherogenesis, I think GLP-1 receptor agonists have a slight advantage over the SGLT2 inhibitors. On the other hand, when it comes to hemodynamic properties, the SGLT2 inhibitors clearly have the advantage over GLP-1s. So they really have distinct mechanisms of action that actually can be additive, but can help you decide who you should start with an SGLT2 inhibitor or a GLP-1 receptor agonist. And if you look closely at the ADA guidelines, they have a very simple algorithm that I think makes a lot of sense for getting started with these drugs in a cardiology practice. If ASCVD predominates or heart failure or chronic kidney disease predominates, you're going to make your decision henceforth. For example, if ASCVD predominates, you're going to start preferably with a GLP-1 receptor agonist or an SGLT2 inhibitor with proven benefit. And if heart failure or CKD predominates, you're going to lean towards the SGLT2 inhibitor. So in your patients, you're going to be asking, which of these risks predominates in my patient? So let's return to our patient. I presented a case of a 55-year-old woman who is quite obese, had a sedentary lifestyle and new onset of diabetes, and had a lot of atherogenic risks, including subclinical atherosclerosis. So in this case, based on what I've showed you so far, I think you're going to select, for example, a GLP-1 receptor agonist as your first-line therapy, preferred over metformin, given her risk profile. She's not at high risk of heart failure or CKD in this case. So let's talk about some practical points about using GLP-1 receptor agonists in your practice. First of all, side effects. You need to talk to your patients very clearly about side effects up front with these drugs. You need to tell the patient that they're incretins that work through the gastrointestinal tract, so they will cause some gastrointestinal side effects. That's why you need to start at the lowest dose and titrate up slowly per package label no sooner than every 4 weeks to the next dose to get to your target dose. And this is a great time to talk to your patients about eating smaller meals and not overeating and eating healthier. That helps these drugs with their tolerance. So patients may get a little nausea, less likely they'll get some vomiting, diarrhea, or dyspepsia, or constipation, and injection site reactions are rare. And if you talk to your patients about these side effects up front and talk about lifestyle change at the same time, most of your patients will come back and say, well, gosh, those side effects weren't nearly as bad as I thought because you prepared me for them at the time of initiation. I think that's really important to talk to your patients about these side effects at the time of prescription. And I've mentioned before, there are some warnings. You're not going to be prescribing a GLP-1 receptor agonist in general with a history of recurrent pancreatitis. Risk factors for pancreatitis, like very high triglycerides, for example, in general, gastroparesis, or a family history of medullary thyroid cancer or MEN2. So the question always comes up, okay, let's say it's not a new initiation of a GLP-1. Let's say the patient has existing diabetes. What do I do with the other anti-hyperglycemic therapies? Here are some practical recommendations for you. Now, you want to be getting your patients off sulfonylureas in general, given the risk of hypoglycemia and the absence of cardiovascular benefit. And if the patient is already near goal with the A1C, just stop the sulfonylurea and add a GLP-1 receptor agonist. If the A1C is, let's say, 8% or so, you can cut down the dose of the sulfonylurea at first as you up-titrate the GLP-1 receptor agonist, hoping eventually to get the sulfonylurea off. And if the A1C is very poorly controlled, then it's just reasonable to add the GLP-1 receptor agonist to their existing therapies, and hopefully at a later time with the weight loss to titrate off. Now, if they're on insulin, it's still very reasonable to consider a GLP-1 receptor agonist for that cardiovascular benefit. So if you're already at a reasonable A1C goal, you should reduce your basal insulin by about 20 to 30% as you add the GLP-1 receptor agonist. If a patient has more complicated diabetes, certainly a history of diabetic ketoacidosis, of course, you're going to want to do this with close coordination with the primary care doctor and the endocrinologist. But in general, it's reasonable to start titrating insulin down a little bit and adding a GLP-1 receptor agonist for that cardiovascular benefit. DPP-4 inhibitors generally don't combine a DPP-4 inhibitor with the GLP-1 receptor agonist, given the slightly overlapping mechanisms of action through the incretin system. You can go ahead and change out the DPP-4 for a GLP-1 receptor agonist. In general, other therapies don't require any adjustment. And if you select one of the weekly GLP-1 receptor agonists, they're hepatically cleared, so there's no renal dose adjustment required. Now, the question always comes up about combination therapy. Let's say you start the GLP-1 receptor agonist and the A1C remains elevated, or the patient starts to develop risk of CKD or heart failure. It is reasonable to consider combination therapy. This is from the ACC Guidelines. It says it appears reasonable to use both an SGLT2 inhibitor and a GLP-1 receptor agonist with demonstrated benefit concomitantly, if clinically indicated, even though such combination therapy has not been tested in a dedicated CVOT. Now, of course, the cost might be a limiting factor, but these distinct mechanisms of action might provide an additive benefit for your patients, and there's some real-world data to support that. So in conclusion, some practical tips on treating diabetes in your cardiovascular practice. I think if you have routine, early isolated diabetes in the absence of cardiovascular risk factors, metformin is a great first choice. Now, most patients in your cardiology practice, because of their risk status, you're going to be thinking about a GLP-1 receptor agonist or an SGLT2 inhibitor. Now, I think if you've got a patient like our patient in this lecture, they have obesity or metabolic syndrome features, a high A1C, primary prevention of ASCVD risk, where ASCVD risk predominates, you're going to be selecting a GLP-1 receptor agonist. And I want to give you some practical tips again about GLP-1s, and that's to adjust your other diabetes meds as needed, including getting off agents that can cause hypoglycemia, to start at the lowest dose and titrate slowly based on the patient's tolerance to make sure that they really can stick with the medication. It's a perfect time to recommend diet changes. Smaller meals, healthier meals help you tolerate GLP-1 receptor agonists. And you need to have a frank discussion of the side effects and to reassure them and help them through, because many of these side effects will get better over time, and provide that patient support to keep them on the drug long term. So hopefully you find some of these hints to be practical for your cardiology clinic. And thank you once again for inviting me to speak today.
Hey, Mike, thank you so much. This was an exciting talk. truly diabetes is such a high risk, and now in an era where amazing interventions are available, I think so this was such a brief practical summary on not only for primary care but cardiologists, and how to figure out the combinations of medications that we can use and how to mitigate the risk. So as before I move to our introducing our next speaker, I just also wanted our audience to remind them that if you have any questions, you can type them in the chat box in the Zoom, or you can also text Debaki 37607, text that in your message. You can go to pollev.com, enter Debaki, and then respond to the activity. So now moving along, it is a tremendous pleasure for me to introduce the next speaker, our first inaugural cardiovascular disease prevention fellow, Mohammed Taha, who will talk about medical management, whereas in the recent past most of the focus still remains on lifestyle and at the other extreme, bariatric surgery. But I think so with the growing options for the medical management, this is an exciting time for primary care physicians, cardiologists, and endocrinologists. So welcome, Dr. Taha.
Hello, everyone, and welcome again to the Houston Methodist Cardiovascular Disease Prevention Symposium. My name is Mohammed Taha, and I am a Preventive Cardiology Fellow at the Houston Methodist. I would like to thank Dr. Nasser for inviting me and giving me the opportunity to present today. It is my pleasure to present medical management of obesity. This is truly an exciting time to discuss this topic, as some say that the future is bright and others say that the future is already here. So let's start and have you decide on that. First, I want to highlight the challenge of increased obesity prevalence throughout the country. If we look at the obesity trend over the last 20 years, we can see the rates of obesity increased from 30 to 42%, and the prevalence of severe obesity, which is defined by BMI more than 40, almost doubled. What is even more concerning is the projected obesity prevalence by the year 2030. It's expected that 1 in 2 adults to have obesity and 1 in 4 to have severe obesity by the year 2030. Among different groups in the United States, African Americans, women, and low-income adults are most severely affected. In a large-scale meta-analysis of about 240 prospective studies, results show that for every 5 BMI units above the normal weight range, there is a 30% increase in overall mortality and 35% increased risk of cardiovascular disease. These increased risks were more prominent in men and younger individuals. In addition to mortality risk, metabolic health in obesity is also something of a concern. Within 3 to 5 years, 30% of obese individuals become metabolically unhealthy, and that includes higher risk of incident diabetes, ASCVD, and heart failure. So the question is not should my patient lose weight, but rather how much weight loss is needed to gain incremental benefits. And here we see that the weight loss is beneficial for a wide range of cardiovascular risk factors. Although the percentages vary, but the magic number seems to be 10% to gain benefits. The Look Ahead trial looked at at weight reduction and cardiovascular risk benefits in people with type 2 diabetes. With a weight loss of 8.6% at 1 year, there was no reduction in cardiovascular mortality or MACE at 10 years. However, in a subgroup analysis, those who lost 10% or more body weight, we see a 20% reduction in cardiovascular mortality and MACE. This figure here shows that until recently, treatments were unlikely to get people to lose 10% or more of body weight. Medical management is indicated in individuals with BMI 27 to 30 with at least one health condition, or BMI greater than 30. I want to highlight some major guideline recommendations for medical management of obesity. Number 1, medical therapy works to reinforce lifestyle change and should be considered as an adjunct to lifestyle interventions to help achieve target weight loss. Number two, the combination of medical therapy and lifestyle intervention results in greater weight loss compared to individual approach. And number three, if a patient is on medical therapy but has not lost at least 5% of initial weight after 3 months of maximum therapy, the provider should reassess the risks and benefits of that medication and consider stopping this therapy. There are many considerations on how to choose the appropriate medication, and they are based on obtaining good history from the patient and trying to understand their medical and social perspective. The 5 C's here outline and summarize the important consideration, and they include contraindications and cautions, comorbidities, as many anti-obesity medications may serve as a double duty medicines, especially in cases of diabetes and cardiovascular diseases. Cues, for example, if a patient describes appetite control symptom, if a patient prefers a certain mode of medications delivery, for example, oral versus injectable, combination therapy, and cost and coverage, which is a huge issue in the medical management of obesity, as I'm sure many of you have encountered already. I will start by talking briefly about the traditional medical management. Then I will shift the discussion about the more recent and exciting medications. Orlistat is a pancreatic lipase inhibitor, leads to malabsorption of about 1/3 of diet fat. With regard to outcomes of weight loss, average weight loss is 8.8% compared to 5.8% in the placebo group, and close to 39% of patients achieved weight loss of 10% or more. Some of the main side effects include diarrhea, malabsorption, and nephrolithiasis. Naltrexone bupropion, it helps with the behavior of repetitive consumption of food, plus the addition of antidepressant. With regard to outcomes of weight loss, average weight loss is 6% compared to 1% in placebo, and close to 20% of patients achieving weight loss of 10% or more. Some of the main side effects include GI adverse events, decreased efficacy of opiates, insomnia, mood changes and tremors, and it lowers the seizure threshold. Phentermine is one of the most popular weight loss medication in the country. It increases release of norepinephrine. With regard to outcomes of weight loss, average weight loss is 6% with regard to 2% in placebo, and close to 20% of patients achieving weight loss of 10% or more. Some of the main side effects include insomnia and anxiety. We do not use it in patients with established ASCVD, atrial fibrillation, uncontrolled hypertension, or hyperthyroidism. Caution with interaction with other antidepressants. Phentermine topiramate, the combination further decreases craving and alters taste sensation. With regard to outcomes of weight loss, average weight loss is 10% compared to 1% in placebo, and close to 50% of patients achieving weight loss of 10% or more. Some of the main side effects is concerning regarding teratogenicity, in addition to effects on memory, fatigue, and renal stones. Now, switching to GLP-1 receptor agonists, they have been available since the year 2006, and FDA-approved agents for weight loss are liraglutide and semaglutide. GLP-1 receptor agonists have hosts of mechanisms and activities that I am sure many of you are aware of. As regard to the mechanisms for weight loss, they decrease appetite and decrease gastric emptying and motility. Liraglutide, with regard to outcomes of weight loss, average weight loss is 8% compared to 2% in placebo, and close to 33% of patients achieving weight loss of 10% or more. There is a dose-dependent effect on weight loss, and as regard to dosing, starting dose is 0.6 milligram daily and is increased typically by 0.6 milligram weekly over 5 weeks, until reaching 3 milligram daily. Side effects including GI symptoms, it increases risk of pancreatitis, increase in heart rate, and this is especially important in patients with heart failure. And it is contraindicated in people with history of thyroid C-cell tumor or MEN type 2B syndrome. Semaglutide is the most recently approved treatment for obesity. Average weight loss, as seen in the STEP trial, is 15% compared to 2% in placebo, and close to 70% of patients achieving weight loss of 10% or more. In addition, over 30% of patients achieved weight loss of 20% or more, and this is a bariatric range weight loss effect. As regard to dosing, starting dose is 0.25 milligram weekly and is increased typically every 4 weeks until reaching 2.4 milligram weekly. Side effects including nausea, diarrhea, and constipation. This table here shows the effect of different medical therapies compared to placebo on weight and blood pressure at 1 year in patients with hypertension. Semaglutide had the most robust change in weight, with an average weight loss of about 15% in 1 year, and results in 6-point drop in systolic blood pressure and 3-point drop in diastolic blood pressure. So how to medicate or manage side effects and increase success rate in GLP-1 receptor agonists? First, counsel your patients on treatment benefits, including weight loss, cardiovascular benefits, and improved quality of life. Second, discuss the preference of the patient in selecting daily versus weekly injections and oral versus injection therapy. Third, prepare for injection therapy, maybe even have the patient receive their first injection in the office. And finally, discuss GI adverse events, including nausea, diarrhea, and constipation. Tell patients that these adverse events are typically mild and resolve within weeks. Eating smaller meals and minimizing fat content may help. In addition, stool softeners and fibers for constipation, and titrate the dose slowly. This is an overview of the medical therapy for weight management. Main considerations are related to effect on weight loss, side effect profile, availability of long-term data, and price range. The newer medications, the GLP-1 receptor agonists, they have the most robust effect on weight loss. At the same time, they are the most expensive ones. On the horizon, there are several medications to look forward to, including tirzepatide. It's a novel GIP and GLP-1 receptor agonist from the SURPASS trial. Average weight loss is 11% compared to 1% in placebo, and close to 50% of patients achieving weight loss of 10% or more. There's also a phenomenal drop in fasting blood glucose, A1C, and drop in systolic blood pressure by 5 points. The ongoing SURPASS-6 trial of tirzepatide versus dulaglutide will determine its benefit for cardiovascular risk reduction. Cagrilintide in combination with semaglutide. This is a phase 1b trial. Average weight loss is an impressive 17% compared to 12% in the semaglutide group. I would like to finish with a few take-home messages. 1, determine BMI and record in the patient's medical record at each visit, and monitor the trend over time. Number 2, evaluate patients with obesity for obesity-related medical conditions. Number 3, counsel patients that even the modest amount of weight loss, average 5 to 10%, can reduce cardiovascular risk factors and other complications. 4, discuss GLP-1 receptor agonists with patients for long-term weight management, as they have shown sustained benefits for up to 68 weeks. And finally, consider a patient-specific factor when selecting an appropriate GLP-1 receptor agonist, and provide patient counseling to increase success rate. Thank you all for listening, and I'll be happy to answer your questions during the Q&A session.
Dr. Taha, what a fantastic overview. I think so the future is bright, and as you pointed out, the future is really here. Obesity management is CVD management. So moving along to the next topic, I'm so excited to introduce my dear friend Raul Santos, who's the current president of International Atherosclerosis Society. I must say one of the most prominent lipid expert in the world. He's the director for a lipid clinic at INCOR and associate professor at University of San Paulo. So he'll be talking about the emerging options in lipid management beyond statins, and I can tell you there are few already established and many in pipeline. So welcome, Raul. Look forward to your thoughts on this.
Hello, everyone. I'm Raul Santos from the University of São Paulo, Brazil, and Albert Einstein Hospital. I really like to thank my good friend, Dr. Khurram Nasir, for inviting me to participate on your meeting. And I do hope that in the future, I might be able to visit you in Houston. So basically, the subject of my presentation will be on current and emerging options in lipid management. So this is my conflict of interest with some pharmaceutical companies. And the idea is discussing the unmet needs in dyslipidemia to show you how important dyslipidemia is for the onset of cardiovascular disease, the importance of LDL cholesterol reduction, and discuss a little bit about the so-called residual risk that might be attributed to persistent elevated LDL levels, triglyceride-rich lipoproteins, and Lp(a), and how the genes have taught us to develop newer therapies to reduce these lipids, and discuss a little bit the ongoing and newer therapies. So there's no doubt about the importance of dyslipidemia as a cause of atherosclerosis, and definitely this is data from the global burden of disease showing how it is important as a cause of death for ischemic heart disease. And definitely statins have changed the way how we practice preventive cardiology, and statins are and will be for a long-term time the cornerstone of lipid-lowering therapy with an aim of reduction in cardiovascular disease. First, because they've been around here for more than 30 years, they're safe, they're affordable, and they can make a lot of difference. So, and if we take a look, this is data from a meta-analysis that was published in 2016, clearly showing that if we use a potent dose of a statin like atorvastatin 40/80 or Rosuva 20-40 milligrams, and we reduce the LDL robustly by 80 milligrams per deciliter, and we treat 10,000 people for 5 years, usually we will prevent 1,000 events in secondary prevention and 500 events in primary prevention, clearly showing that statins bring robust reduction in cardiovascular events. And in addition to that, statins not only are effective, but also they are very safe therapies. So typically for the same 10,000 patients treated for 5 years, one would expect 5 cases of myopathy, the precipitation of 50 to 100 new cases of diabetes. Statins do not cause diabetes. Statins may raise glycemia, but they do not cause diabetes. And 5 to 10 hemorrhagic strokes, basically because these drugs also have antithrombotic effects and not because LDL is reduced. So extremely safe if we measure and compare the benefits and the possible adverse events of these therapies. We can definitely use statins as we do it in our clinical practice. So what about the residual risk? We all know that despite intensive LDL cholesterol lowering with a potent statin, even when we achieve, let's say, LDL levels of maybe between 80 and 60, as we had in ideal teen in chronic coronary heart disease or in the acute coronary syndrome setting as IMPROVE-IT, we can clearly see here that even despite intensive LDL cholesterol lowering, between 9 to 12% of patients in stable coronary heart disease recur the events, and around 22% of patients in 2 years recur the events, IMPROVE-IT, clearly showing that this so-called residual risk is still operative. Of course, part of this is attributed to atherosclerotic burden, smoking, diabetes, obesity, inflammation, but definitely dyslipidemia still plays a very important role in the residual risk. And of course, one of, I think, of the problems is that we definitely in most situations do not achieve the recommended LDL cholesterol goals. This is data from the Da Vinci study made in Europe, clearly showing that less than 20% of these very high-risk patients achieve the recommended LDL cholesterol goals of less than 55 milligrams per deciliter. And definitely, still persistent LDL cholesterol levels are a cause of residual risk. And indeed, actually, not only still high LDL, but actually other lipoproteins are still associated with recurrence of cardiovascular events. And definitely genes have taught us very important lessons, because we know that loss of function variants of different genes are associated actually with reduced levels of lipids and a lower risk of cardiovascular events. And we have evidence for loss of function mutations of PCSK9, ANGPTL3, ApoC3, and Lp(a). And actually people who are born with this loss of function variants, they have reduced levels of these lipoproteins, and they, in the long term, they have a lower risk of events. And actually, we have learned from the genes that we can, if we try to block these lipoproteins with different therapies, we might be able to reduce the risk of events. And that's how these drugs are being developed nowadays. So basically, we can actually try to reduce the residual risk by going further in reducing LDL cholesterol levels. And definitely ezetimibe and PCSK9 inhibitors can further reduce the LDL. And we have strong evidence from randomized clinical trials that independently, if we use a statin, ezetimibe, or a PCSK9 inhibitor, what is important is to reduce LDL cholesterol. And for every 40 milligrams per deciliter or 1 millimole per liter that we reduce the LDL with any of these different medications, we will get around a 20% reduction in the risk of events. And of course, the benefits will be greater for those who have higher LDL cholesterol levels, but even people with baseline LDL cholesterol level less than 80 milligrams per deciliter, they were enrolled in these clinical trials. You can see more than 325,000 people in clinical trials like that. These individuals with LDLs less than 80, so more than 22,000 people, will get an additional 20% reduction in risk, clearly showing that we must go further and reduce the LDL cholesterol. And definitely, PCSK9 inhibitors can make a lot of difference for these patients because they bring robust reduction in LDL cholesterol. And we have evidence from randomized clinical trials like FUHER and ODYSSEY outcomes that if we push LDL lower from 90 milligrams per deciliter, you'll get additional benefits. And now we have sub-studies clearly showing that actually higher risk individuals that were enrolled in these trials, like those with recent MI or high burden of atherosclerosis, or have high LPA, or are diabetics, or have PAD, actually these individuals will have a greater benefits from the therapies for the same relative risk reduction. They will get a greater absolute reduction in risk, and the numbers needed to treat will be much lower, and definitely therapies will be much more cost effective. And there is one disease that will need further LDL cholesterol lowering is familial hypercholesterolemia. And this we clearly showed here last year in Taussig that actually in severe heterozygous FH and in homozygous FH, PCSK9 inhibitor like evolocumab can further reduce LDL by 55% in the heterozygous FH and around 20% in homozygous FH. And in those with very high risk, who have FH, additional LDL cholesterol lowering certainly will bring benefits. And actually, we can even expand PCSK9 inhibition now for children and adolescents who have FH and who persist with LDL cholesterol, elevated LDL cholesterol, as we saw here in Hauser. And this drug, evolocumab, actually added around 40% additional reduction in LDL cholesterol on top of statins. And now we have 2-year follow-up of this medication showing safety. And I do hope that in the future, this drug is approved for kids who persist with very high LDL cholesterol levels despite the use of statins and ezetimibe. Actually, we have learned that we can block lipoproteins not only by binding the circulation lipoproteins with monoclonal antibodies, but also using these RNA-based therapies. Actually, we can reduce the production of these proteins, mainly by the liver. So we have the antisense oligonucleotides, and also we have the small interfering RNA. And actually, these new compounds can really reduce lots of different lipoproteins very robustly. And this is what we have, right, with inclisiran. That's a small interfering RNA for PCSK9 that, differently from the monoclonal antibodies, they block the production of PCSK9. The monoclonals bind the circulating PCSK9. And we, as you can see here, both in FH and usual hypercholesterolemic individuals, inclisiran can bring around 50% reduction in LDL on top of the standard lipid-lowering therapies. And the big advantage of this therapy is that actually we should give 3 shots in the first year and 2 shots per year after that. So this definitely will make therapies much more easier to administer, and hopefully will increase adherence to therapy. This drug is already approved in Europe, hopefully will be available in the US and other parts of the world soon. And so far we have no evidence at all of any safety sign. So we also have other drugs that we have learned from genetic studies that they can reduce the LDL and probably reduce the risk of events. This is a small molecule, bempedoic acid, that blocks the synthesis of cholesterol in the liver, inhibiting ATP citrate lyase. And this enzyme is not encountered in the muscle. And this might be maybe an alternative for individuals who have intolerance due to side effects, muscle side effects of statins. And this drug can add an around 17% extra reduction in LDL cholesterol on top of statins. It's available in the US, and hopefully one big study that's called Clear Outcomes will show that bempedoic acid will reduce not only cholesterol, but most importantly, the risk of cardiovascular events in statin-intolerant high-risk people. We also have learned from genetic studies that if we inhibit angiopoietin-like 3 protein, we can reduce lipids. Actually, this is evinacumab, a monoclonal antibody that binds circulating ANGPTL3 and can bring robust reduction in LDL cholesterol, not only in heterozygous FH patients, but most importantly in homozygous FH patients that were refractory to statins, ezetimibe, and PCSK9 inhibitors. And you can see here further 40 to 45% reduction in LDL, even in those FH patients, whole FH patients who had new variants in the LDL receptor. So this is extremely robust, and this really can bring a new hope for these patients that are very hard to treat. So what about triglyceride-rich lipoproteins? We all know that actually people who persist with elevation in triglyceride-rich lipoproteins, even in LDL reduction, is robust. They still persist with a high risk of recurrence of events. And actually, many therapies were developed to really try to tackle these lipoproteins. We have this discussion whether fish oils will reduce or not the risk of events. So there's discussion about reduce it versus the strength. But one thing is pretty clear, even in reduce it, actually, the benefits were not attributed mostly to reduction in triglycerides. So this is something that we still are trying to understand. This story is not over yet. There's another study that's going on, the prominent study that's testing a different drug. It's not a fibrate. It's a selective PPAR alpha agonist, and this drug can reduce triglycerides robustly, can reduce also inflammation. And hopefully the prominent study in diabetic patients will bring us new information on really how to deal with persistent triglyceride-rich lipoproteins that are associated with a greater risk of events. Also, there's another drug that is called vupanorsen that actually is an antisense drug that blocks ANGPTL3, similarly to evinacumab, but not a monoclonal antibody. This one blocks the production actually of ANGPTL3. And this study in moderate hypertriglyceridemia patients showed that actually this drug reduced triglycerides by around 44%. Quite interesting, not only reduced ANGPTL3 as expected, but also reduced ApoC3. And we have evidence from median randomization studies that reduction in ApoC3 is associated with a reduction in risk of events. Talking about ApoC3, actually, there's one drug that is an antisense oligonucleotide for ApoC3 that basically blocks the production, reduces the production of ApoC3. And this drug is approved in Europe for patients with familial chylomicronemia syndrome. Here, we're not talking about coronary heart disease or atherosclerosis because we have accumulation of big chylomicron particles that do not enter the arteries. We're talking about people with refractory hypertriglyceridemia who have an elevated risk of pancreatitis. And actually, this drug, volanesorsen, robustly reduces the levels of triglycerides by around 75%, not only in people with FCS, but also in people with severe hypertriglyceridemia of other causes. And actually, this drug might be a really huge advance for the therapy of definitely one of the most refractory patients that we have in lipidology, that are those patients with severe hypertriglyceridemia. I do hope that this drug can really bring a lot of difference for our patients. And finally, we know that Lp(a) is independently associated with the greater risk of events. Lpa is a modified LDL with an additional apolipoprotein, and we have evidence from observational studies, Mendelian randomization studies, and genome-wide association studies showing that elevated Lp(a) is associated with a greater risk of events, even in patients taking statins. And now we have at least one therapy, very robust therapy, an antisense oligonucleotide that blocks the production of apolipoprotein, and this drug, pelacarsen, reduces Lpa up to 80%. And hopefully, the Horizon trial will show that this drug will reduce the risk of events in people who already have cardiovascular disease, are taking statins, and still have persistent elevated Lpas. So I'd like to invite you to join us in our Essentials of Residual Risk course at our website, athero.org. This is a course that is dealing with the different parts, different factors associated with residual risk, and is coordinated by our former IAS president, Dr. Virgil Brown. And I do hope you can join us. It's totally free. Just log to our website, and you will be very happy with what we have to present to you. And to conclude, these lipidemias are a cause of atherosclerosis. LDL cholesterol reduction prevents cardiovascular disease events. However, despite that, the risk still persists. More intensive LDL cholesterol lowering with the statins, ezetimibe, PCSK9 inhibitors, and bempedoic acid can further reduce the LDL and hopefully will prevent the risk of events. We're just waiting for the bempedoic acid study. We all know that statins, ezetimibe, and PCSK9 inhibitors will reduce the events. Definitely, higher risk people will have a greater benefit. These therapies are apparently very safe, and definitely newer therapies are being developed based on genetics to really reduce residual lipoproteins, triglyceride-rich lipoprotein remnants, Lp(a), and hopefully they will bring reduction in risk of events of our patients. Again, I'd like to thank Ron Nasir and the organizers for inviting me to participate on this symposium, and I do hope we have some time for discussion. Thank you very much, my friends.
Raul, what a wonderful presentation. It just reminds me how far we have come over the last 10 years, and really the future of lipid lowering, and not only LDL, but all across the spectrum, is truly bright. So to wrap up our final session, I'm truly honored to invite a special guest from Boston, Stephen Juracek, who is an assistant professor at Beth Israel Deaconess Medical Center and Harvard Medical School, a leading expert in blood pressure management, and leading many therapies as well as lifestyle intervention clinical trials in trying to assess the impact of appropriate blood pressure monitoring. So, Stephen, thank you so much for joining us. All yours.
Thank you for the opportunity to speak with you all today regarding hypertension management and greater returns than expected in cardiovascular disease risk prevention. I am supported by the NHLBI to study blood pressure patterns in older adults. I have no other conflicts to disclose. So I'd like to start a little bit with a discussion about what is normal blood pressure. And when we think about normal blood pressure or hypertension, we all have in our mind either 130/80, 140/90, and that's based on a population distribution in largely the Western world. However, in this interesting study by Fuchs et al. In hypertension, published in 2020, they made an interesting point showing that comparing unacculturated or indigenous populations, so non-Westernized populations, compared to Westernized populations. And what they noted is that if you were to define hypertension based on
the same percentile in the distribution of blood pressure, the hypertension value would be 120 over 70 in the unacculturated populations compared to the 140 over 90 in acculturated populations. And if you were to take this 120/70 to classic Western civilization or countries today, what you would see is the vast majority of folks would be hypertensive just based on the unacculturated definition. And it really gets at this kind of questions our underlying concepts or stereotypes about what a high blood pressure hypertension should be, what's normal. And if you sort of going to today's world, looking at the NHANES data, we know that blood pressure control, even using kind of Western definitions, has been reached a plateau and even been worsening in recent years. And this is from NHANES, age-adjusted blood pressure control in adults with hypertension and among those taking hypertension medications. And you could see that we are not achieving, we're about 50% and now dropping down to 40% of control among adults who've been told they have hypertension, and then dropping down to about 60% among those who are actually taking a hypertension medication. And so when you think about why this is important, well, blood pressure is probably one of the strongest risk factors for cardiovascular disease that we know of. And so this is these data here presented are from a meta-analysis of 61 different cohorts in 1 million adults, and published by Lewington and colleagues in the Lancet in 2002. And we can see here on the left-hand side is risk of ischemic heart disease according to age, based on blood pressure, systolic blood pressure in the population. And you can see that regardless of age, there's a linear increase in risk of ischemic heart disease related mortality, regardless of age and across blood pressures, suggesting that this is a continuous increasing risk. Notably, this meta-analysis also looked at what's the risk of heart-related outcomes associated with a 20 millimeter mercury lower usual systolic blood pressure. So compared, if you had lower than the typical in these studies, what was the association by 20 millimeters mercury? What was the association with heart failure, aortic aneurysm, hypertensive heart disease, atherosclerosis, sudden cardiac death, inflammatory heart disease, rheumatic heart disease, pulmonary embolism, et cetera. And you can see dramatic risk reductions among those with lower systolic blood pressures in this population, this pooled population of 1 million adults. Moreover, clinical trials have strongly demonstrated that blood pressure reduction is consistently associated with lower risk of cardiovascular disease mortality. This is SPRINT, one of the most well-known studies, especially probably by this forum here. This is the primary outcome. You can see from intensive blood pressure treatment where the goal was less than 120 systolic blood pressure, right? This which was achieved throughout the study compared to a range of 135 to 140, significant lower risk of cardiovascular disease and mortality. And looking at mortality itself, which is really stunning if you think of what we can do medically to save people from dying from any cause. Very early on, there was initial separation that was maintained and widened over time with all-cause mortality from more intensive blood pressure reduction. And building upon this, the blood pressure lowering treatment trial is collaboration in Lancet 2021, so just recently, based on 48 randomized trials of 340,000 participants, looked at blood pressure reduction in adults with and without cardiovascular disease. And you can see the kind of red lower line is the intervention in the comparator group among those with cardiovascular disease, among those with no cardiovascular disease, significant reductions in major cardiovascular events from intensive or more intensive blood pressure reduction, regardless for both secondary and primary prevention. And they concluded a 5 millimeter of mercury reduction in systolic blood pressure reduced risk of major cardiovascular disease events by about 10%, irrespective of previous diagnosis of cardiovascular disease and even at normal or high normal blood pressure values. So very strong evidence that blood pressure reduction is not just for folks with existing cardiovascular disease, but also to prevent cardiovascular disease. And there's even emerging evidence that in favor of blood pressure, lower blood pressures with regards to primordial prevention. So in this observational study from the MESA cohort, with about 1,000 or 1,500, nearly 1,500 adults free of atherosclerotic cardiovascular disease, Seamus Walton and colleagues demonstrated a graded incremental association between blood pressure level and diffuse CAC, or CAC greater than 0, and then also for a near continuous linear relationship with incident ASCVD among those with no known disease at baseline, even in the normal blood pressure range, suggesting strongly that this is important even for primordial prevention prior to the development of hypertension. Benefits of blood pressure reduction are commensurate with the magnitude of reduction, and regardless of starting point. So again, going to this blood pressure lowering treatment trials collaboration, here we have a meta-regression of the various different trials, and you can see here the magnitude of the blood pressure reduction between treatment groups and risk for cardiovascular events. And you can see the more blood pressure is reduced, the greater the risk reduction across trials, and regardless of starting point. So you can see there's evidence the magnitude or direction effect was inverse, even at the lower systolic blood pressure ranges, all throughout to the higher ranges. No evidence of an interaction across these strata, suggesting that we should just be lowering blood pressure in order to achieve risk reduction in cardiovascular disease events. I also point out this important secondary analysis from the SPRINT trial by Bedu and colleagues. So we know there's a J-shaped curve with regards to diastolic blood pressure and cardiovascular disease risk. And Bedu and colleagues examined this in the SPRINT trial, looking at straight-up baseline diastolic blood pressure and with regards to the effect of the intervention on the primary outcome, all-cause mortality, and then incident chronic kidney disease. And what was notable is that there was no difference, no increased risk of the primary outcome among those with a low diastolic blood pressure at baseline, no increased risk of death across strata of baseline diastolic blood pressure, right? So no significance here. And the risk of adverse events, so, the most common we think of, right, AKI or kidney disease progression or injury, no increased risk among those with the lowest diastolic blood pressure at the pre-randomization. Again, suggesting that at least in this study, and you might argue, well, most people had higher blood pressures, but at least in those that were examined in this study, there is no evidence that having a lower diastolic blood pressure was associated with greater risks throughout the trial period. What about older adults? We frequently hear folks are concerned about older adults in aggressive therapy. This is, again, another publication from a similar blood pressure lowering treatment trialist collaboration of 51 randomized trials with 358,000 participants stratified by age, and this is follow-up years, major cardiovascular disease events. You can see overlap, unclear benefit in the 85 plus group. Though arguably maybe there's some lack of power, maybe there does seem to be some degree of separation that we just can't detect, but very clear evidence for benefit even early on among individuals in the 75 to 84 range, 65 to 74 range, that just increases over time of the intervention, suggesting that blood pressure reduction among those with more advanced years is beneficial. And there are benefits that are relevant to older adults beyond cardiovascular disease, so dementia. When we think about dementia and sort of the poor evidence for some anti-dementia or anti-cognitive decline agents, well, there's clear evidence of the role of vascular disease and the progression of dementia. And blood pressure reduction is one of the most studied and potentially most evidence-based approaches to stave off cognitive declines and incident dementia. And this is evident by this meta-analysis published in JAMA in 2020, suggesting that there's a clear benefit to preventing dementia development from more intensive blood pressure treatment. What about orthostatic hypotension, a major fall risk factor? We demonstrated this in an individual level meta-analysis that we published last year, where more intensive blood pressure treatment was associated with reduced risk of or odds of developing or having orthostatic hypotension. This is true both in when we combined trials of comparing blood pressure treatment goals and trials with both goal and or active treatment versus placebo, suggesting that even concerns of fall risk factors are not supported by the evidence. When we think about implementing blood pressure treatment strategies in the population, I wanted to point out this concept of your treatment goal in the population and sort of what you're hoping to achieve or your population benchmarks. In the primary care setting, we frequently think of like HEDIS measures, how much of your population is below 140/90, right? And you get fiscal incentives if you have 70% of the population below 140/90. And when we think about this concept and with regards to Gaussian distribution, and theoretically apply the standard deviation of sprint, which is about 15 millimeters of mercury at baseline, and we know in clinical practice, probably the standard deviation is even wider than sprint. But if you were to set your population treat goal at 140, then with a standard deviation of 15, your expectation would be to have about 50% at goal at any given time, right? And if you were to go, if you set your treat goal to be one standard deviation below 140, so at 125, then just applying a classic normal curve, you would achieve, if you had 100% application across the population, so penetrance of the intervention got, everybody that was on board was treating to 125, then you would achieve the benchmark of among about 84% of the population, with about 2% below the 95 or a theoretical hypotensive range. And then if you set your treat goal to 110, that's when you'd really achieve most of the population being at goal at the expense of an increasing sizable number below 95 millimeters of mercury or some hypothetical hypotensive range. And so what I'm getting at here is that if we're really serious about getting most of the population compliant with what we saw in SPRINT and really this idea of making a difference in all-cause mortality, preventing cardiovascular disease, just limiting ourselves to about a 130 goal as espoused by guidelines is going to, again, with 100% penetrance of the intervention would get you right around 70% compliance. And really, if we targeted more aggressive from the population, a more aggressive treat goal, we would start to see better results around population in terms of number of people with controlled blood pressure, which I think is an important thing to keep in mind when implementing a prevention strategy. I also want to point out this idea of screening. Guidelines recommend more than one measurement in a single clinic visit and measurements across visits, right? Because of between visit variability, within visit variability. This is a very nice study by Liu and colleagues that demonstrated the impact of overdiagnosed. So consistent blood pressure is this dark black line, but if you miss hypertension because you don't do a second or third measurement, very clearly this group is at greater risk of cardiovascular event that's quite close to those with the consistent hypertension versus those with overdiagnosed hypertension or consistent. We always worry about the overdiagnosed, but it's important to keep in mind that it's the missed group. So the group that on that first measurement seems to be in the gray zone or without hypertension or controlled hypertension that we should really be thinking about in terms of our population screening strategy. And on panel B, that they show very nicely, well, if you just check the folks who are elevated on first measurement, and you can again see it's the missed folks that I think really we should all be the most concerned about, even with this kind of adapted or modified strategy. There are some that advocate for the idea of using ABPM to help clarify or out-of-office measurements to clarify the gray zone where white coat and mass hypertension tend to lie the most. But I'd point out on the right-hand side, this is a nice publication by Lama Ghazi in Jaha using sprint data. There's very poor concordance between the office blood pressure and ambulatory or home blood pressures. And so I think when we consider this idea of refinements, I think it does make sense. It could prevent adverse events. But even just treating the office blood pressure, we know in sprint, had all-cause mortality benefits. And really, we should be anchoring our strategies toward let's treat the blood pressure we see in clinic because it's going to save lives, and worry less about, well, are we entirely getting it right, or over diagnosing folks, because it's the missed individuals that tend to have more to lose if we do not treat them. So conclusions: elevated blood pressure and hypertension are widespread in the United States. Higher blood pressure is associated with cardiovascular disease, and reduction of blood pressure lowers cardiovascular disease risk. Benefits from blood pressure reduction are realized regardless of cardiovascular disease history at any blood pressure starting point. Blood pressure reduction lowers CVD risk in older adults with benefits beyond CVD. And achieving population goals require proactive treatment and sound screening strategies, with office blood pressure still being the bedrock for clinical decision making. So thank you so much for your attention. I look forward to the discussion afterward. Thank you for the opportunity to speak today.
Stephen, thank you so much. This was wonderful. So clearly, in prevention, cardiovascular prevention, we have to think beyond lipids. If almost similar, or I think so, even better risk reduction. 130 seems to be the new 140. Huge dividends as far as dementia and other outcomes are concerned. So totally agree that we need to be proactive. So before we jump into the next session, we have 5 more minutes, and thank you so much all of you for joining us, and we'll try to keep this session brief. So I'll start with Dr. Patel. So Dr. Patel, clearly we know that at least in the primary care setting, physicians are much well versed who are the patients that they need to send for primary prevention for atherosclerotic cardiovascular disease risk reduction. What would be your message? Who are the patients who are primed for heart failure prevention that should have more risk stratification or be sent to a cardiovascular prevention clinic?
That's a great question. Thank you for that. What I would say the guidelines suggest in patients who have high risk for cardiovascular disease, whether that's defined by risk factors or some other types of markers, who have elevated natriuretic peptide levels, those individuals in the randomized clinical trials, when they were referred to cardiologists, those patients had reductions in risks of clinical endpoints like LV dysfunction or development of heart failure. So patients who are at high risk based off of risk factors plus some other type of risk enhancer, as we talk in atherosclerotic cardiovascular disease, like a natriuretic peptide level, would be the right candidates for seeing a cardiologist. And I think that's has some pretty good evidence from these clinical trials that we discussed earlier.
Thank you, Dr. Patel. Dr. Jha, thank you so much for joining on behalf of Dr. Michael Blaha. I know that you are actively working with him on the cardiometabolic clinic. Now, clearly Dr. Blaha showed a significant benefit and yields with the novel cardiometabolic therapies. In real world, we clearly see that either in the primary care settings, as well, especially within our own cardiology community, there is a hesitancy of initiating these cardiometabolic interventions with risk reduction. How do you outreach to primary cares and especially your cardiology colleagues in getting the message out, but getting them into your own clinic?
Thank you, Dr. Nasir, and thank you, Dr. Patel, for having me here. So that is a great question. Like when we started our cardiometabolic clinic at Hopkins, the thing that came to our mind was that what will be our inclusion and exclusion criteria. So we brainstormed with Dr. Blaha, and then we came up with a plan that any patient with a subclinical CAD or like for primary secondary prevention patient, if they have a diabetes or obesity, and we're trying to accept those patients, but there was some exclusion criteria as well, like someone with type 1 diabetes, someone who is on insulin pump requiring higher dose of insulin. So those were the patients we thought that will not be a great candidate for our clinic. So far, our clinic is just growing. We have like 80 referrals so far. And what we do to evaluate the appropriateness of a referral is that we have we have an email and we evaluate the appropriateness of those patients, and then we reach out to the primary care and tell them that, yeah, definitely we can see those patients. So overall, our main criteria for taking a patient or accepting patient is anyone with a cardiovascular disease, with diabetes, type 2 diabetes, and or obesity as such. That's the mantra so far, and we're still trying to explore what are the patient-specific barrier, physician-specific barrier, and what are the healthcare barrier as well for decreasing the therapeutic inertia against these medications.
So, Dr. Jha, thanks for this tremendous initiative. I think so. The cardiometabolic clinics, of course, starting right now, tiptoeing into managing diabetic patients. But where I see the future of this will really extend to obesity management, where I think, as Dr. Patel was just alluding to me, 50% of the population will be obese in 2030. Now, Dr. Taha, the question really is, there has been a persistent stigma about medical management obesity in the past. In your opinion, what are the ways that we can overcome that? And are there any better candidates? You showed us a whole spectrum that would be better than a GLP-1 receptor agonist, especially semaglutide.
Yes, thank you again, Dr. Nasser and Dr. Patel. As we see that obesity is not only a disease by itself, it has a high risk of cardiovascular, such as atherosclerotic cardiovascular disease and heart failure on one side, and metabolic diseases on the other. So I believe there is just a strong case, as Dr. Jha was saying, a strong case for cardiometabolic centers to encourage on one side and collaborate on the other side in medical management of obesity. I think this approach is going to be the most beneficial given the current and the future burden. And I think one of the inclusion criteria should be in these clinics as well is to focus on the patient population within the US that are most severely affected. And we're talking about minorities, African Americans, low income, and women. I think this is one way of fighting this stigma and encourage the current use of these medications.
Perfect. Thank you so much, Dr. Taha. Now pivoting to Rahul, you definitely showed that tremendous amount of innovation in lipid-lowering therapies, just beyond statin over the last 10 years. Many upcoming. The question really is, in your opinion, how are we going to work on the adoption, whereas we are seeing that even with the PCSK9 monoclonal antibodies inhibitors, the adoption has not yet happened, and especially in low income communities or societies or countries. What's your experience been? At one end, of course, we have this tremendous innovation, but do you think the adoption is catching up, and how can we get there?
Thank you, Kuram. So I think especially for developing countries like mine, it's always a challenge because we don't have PCSK9 inhibitors in the public system. So if patients have to pay from their own pocket. And I see with the minorities and also low-income people in developed countries like yours, I think it's more or less the same kind of problem. So basically, I think what we have to do is try to use what we have in the best way. So statins, highest dose, ezetimibe, and really try to control cholesterol the best that we can. And for those who are still persist with LDL, basically we have to deal with risk stratification. So in secondary prevention, we know there are many people that have higher risk than others. So those who persist with uncontrolled risk factors, those with high plaque burden, those who are diabetic, so people with high LPA, these people will have higher risk and will get greater benefits from the PCSK9 inhibitors. In primary prevention, I think we have already discussed and proved that actually calcium score can make a lot of difference in really trying to identify higher risk people, even in FH population, right? So definitely those with higher CAC burdens, greater risk, these are the people that we have, let's say, direct the resources that we have in order to provide these more intensive therapies and certainly reduce the cost and be more effective. This is how I see it, Thank
you, Rahul. And now the final question, Stephen. So, we have seen the whole spectrum of cardiometabolic. Hypertension really plays a prominent role. Of course, there is significant value of intervention, physical activity, weight loss, alcohol consumption. How do you think that there is a role maybe for an early pharmacological intervention, even at a younger age? And how do we get and convince the primary care that the 130 is the new 140?
Excellent questions. And as a primary care doctor, it's a battle I feel like I'm frequently fighting. So I think you're right. To some extent, the arguments against the overwhelming trial evidence have focused on generalizability to populations that aren't represented by the studies. So I think like many cardiovascular disease risk factors, that includes the young. And then also this notion of kind of benefit in a low risk group. And so I think your point, maybe what you're hinting at, is this idea of risk factor reduction peripheral to hypertension. And so we know two of the most important lifestyle interventions for blood pressure reduction are weight loss and sodium reduction in the diet, as well as adopting a more DASH concordant style pattern of eating. And so with regard to weight reduction, it's very challenging to do from a lifestyle behavioral intervention, but certainly something that should be initiated early. I would say in the 20s, 30s, 40s, well before we even start thinking about the trial populations for pharmacologic management. And as was alluded to, semaglutide and some of the other GLP-1s, they have showed great benefits for long-term or longer-term weight reduction. And if you look at some of at least that recent semaglutide trial in the New England Journal, there was blood pressure reduction as well. And so I think, in addition to our early lifestyle counseling that's very appropriate for the young, I think we should think about some pharmacologic therapies in particular to weight in those that seem to be struggling with the behavioral interventions, particularly because of the proven or demonstrated effects and benefits for blood pressure. With regards to sodium, the SAS trial conducted in China, which again, generalizability, there are a lot of differences in culture and dietary sources of sodium, but I think demonstrate very well the importance of even small population reductions in systolic blood pressure of 3 to 4 millimeters of mercury having profound impacts on heart outcomes like stroke, which we believe is because of blood pressure pathways. And so I think lifestyle cannot be understated. And, whether or not you want to adopt earlier treatment with pharmacologic therapy, I think, my one question often to folks who cite limitations of the trial is, well, what's the evidence not to treat these folks, and what trials have been conducted in individuals that have not been included to suggest that the findings wouldn't be generalizable? And so I don't know if that answers your question.
That's perfect, Stephen. Thank you so much, and everyone for joining for this wonderful session. And now, with further delay, I would like to hand off the next sessions to my dear friend and colleague, Dr. Miguel Quinzos, who is the Associate Director for Cardiovascular Research in Prevention. So he will be co-moderating that with the other leads moderators. And Miguel, welcome. Thank you so much for joining us today live.
Thank you so much, Dr. Nasser. Thank you to our speakers, the moderators, and for the opportunity to be part of this fantastic event. And now for session 3, we're going to be talking about high-risk subgroups. And we're thrilled to introduce Dr. Lakshmi Mehta as moderator for this event from the Ohio State University. She's a professor of medicine. She's the director of preventive cardiology, director of women's cardiovascular health, and the director of the Lipids Clinic. She's a true leader in the field, and we are thrilled to have her today joining us as moderator in this wonderful session, in which we're going to be talking about South Asian health. We're going to be talking about hypertensive disorders of pregnancy. We're going to be talking also about low testosterone levels, and finally about inflammatory conditions and the associations with increased risk of ASCVD. Dr. Mehta, thank you so much for joining us, and looking forward to a fantastic session.
Thank you, Dr. Quinzos Echquera. This is an important session on high-risk groups that often fly under the radar. So it's my pleasure to introduce our first speaker, and who's my dear friend, Dr. Garima Sharma. She's the Director of Cardio-Obstetrics Program and Associate Director of Preventive Cardiology Education at Johns Hopkins University School of Medicine. Dr. Sharma will present to us about hypertensive disorders of pregnancy and what do we need to know. Dr. Sharma?
I'm Garima Sharma. I'm a preventive cardiologist at the Chickering Center for the Prevention of Cardiovascular Disease, and I'm going to be talking about hypertensive disorders of pregnancy. Cardiovascular disease is the leading cause of maternal morbidity and mortality in the United States, and US maternal mortality is the highest in all of the developed nations. Hypertensive disorders of pregnancy complicate anywhere between 5 to 10% of all pregnancies and do cause a significant morbidity in this time frame. The US Preventive Task Force recommends low-dose aspirin of 81 to 150 milligrams per day from 12 weeks to about 28 weeks during gestation. Earlier, the better. They prefer to start it before 16 weeks of gestation and recommend it up until delivery. Labetalol and nifedipine are the first-line agents in the management of hypertensive disorders of pregnancy, and postpartum timeframe is an essential time in cardiovascular disease prevention, in management, and risk assessment in these patients. So the objectives are to discuss the hypertension disorders of pregnancy and their management, as well as to focus on cardiovascular prevention in the postpartum timeframe. What are the trends in hypertensive disorders of pregnancy? This is data from the CDC, which looks at the trends over the last several years, starting from 1989 to about 2018. And the overall prevalence of hypertensive disorders of pregnancy has increased. And if you look at the recent years from 2015 to 2018, there has been a significant increase in hypertensive disorders of pregnancy, but also an increase in other cardiovascular risk factors such as chronic hypertension and diabetes. And so it is safe to say that there is a change in the birthing population in the United States, and women are getting pregnant at a later stage. So very advanced maternal age, which is this, orangish line here, has also gone up, and so has grand multiparity. This is also data from the CDC that looks at the prevalence, the statewide prevalence of hypertensive disorders of pregnancy. And there's a lot of state variability after adjusting for age and ethnicity and patient-related factors. And it gives us a good sense of what are the hotspots in the US in terms of higher prevalence of hypertensive disorders of pregnancy, and where sort of public health should and resources should be focused. And Texas kind of sits somewhere in the middle of the pack, along with Maryland, around prevalence of around 7%, but not as bad as Alaska and some of the other southern states. So what are adverse pregnancy outcomes? These are cluster of disorders, such as hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, small for gestational age infants, and placental abruption that have shared pathogenesis. We think it is because of placental and maternal vascular risk factors, endothelial dysfunction, ischemia, inflammation, and vasospasm. But they also have, women who have these problems also have increased pre-existing cardiovascular risk factors, such as hypertension, obesity, dyslipidemia, and insulin resistance. So important preventive aspect in the care of these patients. Broadly, hypertensive disorders of pregnancy are four main phenotypes. It's important to recognize that preeclampsia is the most malignant form, which is associated with de novo new onset hypertension beyond 20 weeks of gestation, with a blood pressure of 140/90, can be very catastrophic to the mother as well as the fetus, is associated with multi-organ failure, convulsions, seizures, and a very toxic form of preeclampsia. Catastrophic malignant form is the HELP syndrome, where you have consumptive coagulopathy and liver dysfunction as well. Gestational hypertension does not have end organ damage, but is new onset hypertension after 20 weeks. And then the two other types that also require mentioning and management are chronic hypertension and chronic hypertension with preeclampsia that is superimposed, which have important clinical implications for women during pregnancy and are often associated with other APOs as well. So the pathogenesis in the preeclampsia is in the placenta, The placenta tends to be hypoxic, and the spiral arteries tend to be vasoconstricted. And we think it is because of an imbalance between androgenic biomarkers and anti-androgenic biomarkers. And FLIP1 is an anti-androgenic biomarker, which is a soluble form of vascular endothelial growth factor that inhibits vascular endothelial growth factor and prevents the placental arteries from being healthy. And they are impacted. And this FLIP1 to placenta growth factor ratio is highly predictive. Greater than 38 is highly predictive of a preeclamptic pregnancy than earlier. And there's a lot of studies that are looking at the impact of FLIP1 and placenta growth factor ratio on many other multi-organ problems during preeclampsia, but also the postpartum period. How do we manage hypertensive disorder of pregnancy? And so this is important to recognize because the U.S. Preventative Service Task Force recently revised their guidelines. The data on the left is from 2014, where if you had one high-risk factor, and high-risk factor is either a prior history of preeclampsia or diabetes or lupus or chronic hypertension or twin pregnancy or current twin pregnancy and chronic kidney disease, you qualify for aspirin, which should be started earlier in pregnancy, ideally between 12 to 16 weeks of gestation, and you can do anywhere between 81 to 152. There's new data from Europe that supports the use of 152 in the high-risk population. And they recently modified this moderate zone. Initially, they would recommend 2 or more moderate risk factors to qualify for aspirin or perhaps consider aspirin, which now they have revised to maybe 1 or more because we are finding a lot of women who fit this criteria will end up actually having a preeclamptic pregnancy and could benefit from early aspirin. And how low should you go in the management of hypertension? This is important to recognize because the ACC guidelines differ in the management and targets of hypertension during pregnancy as compared to the UK guidelines and as well as the Canadian guidelines. But anyone who has hypertension should be monitored closely. And, much of the ACC guidelines is under review and perhaps may get changed or altered to sort of reflect the change in how we're managing hypertension overall. But if you have mild to moderate hypertension, which is blood pressure, systolic blood pressure of 140 to 159 and a diastolic blood pressure of 89 to 100 millimeters of mercury, they would say watch, wait, treat if severe. I think much of this data is coming from multiple meta-analyses and systematic reviews that have looked at tight control may not necessarily lead to reduction of adverse pregnancy outcomes. And this is one of the larger ones that looked at about 31 trials in this, looking at management of mild to moderate hypertension, whether or not it actually prevented poor outcomes for the fetus as well as for the mother. And while it didn't find a whole lot of significance in prevention of proteinuria, preeclampsia, or neonatal deaths or miscarriages of small for gestational age infants or preterm birth, they did find that treating mild to moderate hypertension during pregnancy would halve the risk of developing severe hypertension. So it should be treated. And it's, and I think recognizing that the woman can manage some of her blood pressure at home with ambulatory blood pressure monitoring, encouraging her to call providers and clinicians if the blood pressure has increased or she has developed any signs of end-organ damage is important. What drugs can be used, barring ACE inhibitors and angiotensin receptor blockers, which can be fetotoxic, can be associated with renal toxicity, renal tubular dysgenesis, or anuria, or oligohydramnios. The others are fairly safe. Beta blockers, apart from atenolol, which can be associated with significant intrauterine growth restriction, labetalol and metoprolol are quite safe and can be used and are often first line. In terms of calcium channel blockers, nifedipine is first line, and you've got to watch out for maternal hypertension and fetal hypoxia and some sort of cross-reactivity with magnesium sulfate. And we use nifedipine and labetalol quite generously. So if you have mild, moderate, non-severe hypertension in pregnancy, whether it's chronic hypertension or you're developing preeclampsia, starting labetalol low and then going up, going slow. Low and slow is a good idea. along with extended release nifedipine. Now, alpha-methyl-dopa is still used a lot in resource-limited countries, but it's generally, sort of fairly well tolerated. But in the US, I think the predominant antihypertensive in this time frame is available, and nifedipine. Second and third line are hydralazine and hydrochlorothiazide. Diuretics are generally kind of watchful in terms of how much we give them and how quickly we increase or titrate, because we're worried about volume depletion and growth restriction in these women. And what about severe? So if you've got severe hypertension, I think if preeclamptic pregnancy can be fairly catastrophic, and we are focusing on getting the blood pressure down as close to normal as possible, as quickly, and we'll move on, providing resources for the fetus as well as early delivery as well. But IV labetalol, IV hydralazine, and immediate release nifedipine are encouraged in this time frame. So what is the association with hypertensive disorder of pregnancy and future cardiovascular risk? Hypertensive disorder of pregnancy are strongly associated with long-term cardiovascular events. There is well recognition of this now, that in addition to coronary artery disease and heart failure, there is also valvular heart disease, which can increase over time. And I think it's really important to recognize that much of it is mediated through the development of chronic hypertension postpartum, but not all of it. And so it does give us a window of opportunity in the postpartum timeframe to make significant changes so that we can sort of alter these strong associations between hypertensive disorder of pregnancy and premature coronary disease and heart failure. They're also linked to premature mortality. This is also data that came out fairly recently and really looked at different types of hypertensive disorders of pregnancy and their individual associations, but also cumulative associations. And the cumulative incidence of premature mortality was 42% higher in women with hypertensive disorder of pregnancy. And this sort of attenuated a little bit after controlling for pre-pregnancy dietary, lifestyle, and reproductive characteristics, but it remains largely explained by chronic hypertension, but not entirely. And so, we wrote an editorial on this talking about what are we to do in women that develop chronic hypertension, but then what are we to do about women who do not develop chronic hypertension and may still be at risk? And the answer is still kind of out there. Yes, definitely improving pre-pregnancy counseling and postpartum follow-up is a given. It's a low-hanging fruit, hypertension management. But it's really difficult to engage these women, and sometimes there's a lot of loss to follow up. And so I think giving a message very clearly and frequently and through multiple angles, through the pediatrician or through the primary care doctor or through the cardiologist is all important. But in addition to that, I think contemporary treatment of these women is going to require a better assessment of what their subclinical risks are and how do we incorporate our subclinical assessment in the management of these women that have hypertensive disorder of pregnancy. What information does proteomic, metabolomic, or epigenomic profiles of this woman provide us that has changed in the postpartum timeframe that acting on it can reverse their overall trajectory? And so how do we mitigate these risks? I think it's really patient engagement and doing it over a span of time and not forgetting about the postpartum timeframe, which they call the fourth trimester, and bringing in lifestyle interventions, management of blood pressure, BMI, dyslipidemia management is really important and is something that we can all do. But prevention starts in the womb, and we wrote about this. This is our wonderful resident, Richard Shaw, who's applying for cardiology and wants to do cardio-obstetrics as well. Management of chronic hypertension, dyslipidemia, obesity, physical activity, smoking cessation, diabetes should start not in the postpartum time frame, but should start very early, especially in women who are at high risk, and maybe in the antenatal period as well. Engaging them and talking to them repeatedly about their cardiovascular risk is important. So what is flying under the radar? I think important to recognize that hypertensive disorder of pregnancy provide a unique opportunity to understanding healthcare disparities in the US. Because much of the burden of hypertensive disorder of pregnancy and the risk postpartum and maternal morbidity and mortality is in the non-Hispanic, Black, Hispanic, and indigenous population in the US. And so we looked at the heterogeneity of cardiovascular risk factors based on maternal nativity. And this is Ellen Boche, who works at Dr. Blaha's lab. who looked at the risk factors in US-born and foreign-born African-American or non-Hispanic Black population from the Boston-born cohort. And it's not a surprise that the US-born African-American non-Hispanic Black population had higher cardiometabolic risk as compared to their foreign-born age-matched counterparts. And when we also looked at the prevalence of preeclampsia, the US-born women had higher prevalence of preeclampsia as compared to foreign-born women, and that sort of foreign-born advantage waned as the women had accrued more cardiovascular risks and had were living in the US greater than 10 years, probably talking about the impact of acculturation and unhealthy assimilation, but also providing a unique window that immigrant health can inform us about our own cardiovascular risk factors. And lastly, this is a paper that hopefully will be coming out soon that looks at the impact of social determinants of health and cardiovascular health and pregnancy. I think it's really important to look at a woman from the overall impact of social determinants of health, what has community and social context done to cardiovascular risk factors, physical environment, economic stability, healthcare system issues, and education and food insecurity, and how does it impact cardiovascular health. And we really divided social determinants of health into 4 different quartiles, the 4th quartile being the most adverse, where women were asked a questionnaire and were grouped into the ones that had the most amount of toxicity in that time frame, and found that cardiovascular health was the worst. And so we need to talk about this, and we need to inquire, and a lot more research to be done about this in the future. This is again my summary slide. Important to talk about hypertensive disorder of pregnancy and how they impact cardiovascular health. Thank you.
Thank you, Dr. Sharma, for an excellent presentation. It's my pleasure to introduce our next speaker, Dr. Miguel Quienzos-Echeverria, who's an assistant professor of preventive cardiology and associate director of preventive cardiology, research and education at the Houston Methodist DeBakey Heart and Vascular Center. He'll be discussing ASCVD risk in people of South Asian ethnicity.
Thank you so much, Dr. Mehta and Dr. Maser, for this nice introduction and this invitation to present today these updates, what is new in 2021 in terms of South Asian cardiovascular disease. My name is Miguel Quienzos-Echeverria from Houston Methodist. It's a great honor to be here today. This is going to be a brief talk, so I'm going to be focusing on key updates in this space. But first of all, I wanted to just mention that I don't have any relationship with industry to disclose. But I do have other disclosures that I would like to mention. And some of you might be wondering why this guy from Spain with this strong Spanish accent is so interested in South Asian cardiovascular health. There's actually a good reason for this. I used to work as a cardiologist in Barcelona, Spain, where we have a large community of South Asians, particularly Pakistani people living in Barcelona. And when I was working there, we were very used to seeing patients from Pakistan coming with chest pain, which eventually ended up being premature myocardial infarctions pretty often. We're talking about patients who were 30, 35, 38 years old. So we ended up coming up with these several clinical studies and region-wide registries that actually informed my PhD thesis. And they're being used now to inform local prevention efforts, public health efforts aimed at improving the prevention of cardiovascular disease in the local South Asian communities. Most recently, I moved to the US, where I had the honor to join the Masala investigator team, working with Alka Kanaya, Namrata Kandula, Nadia Islam, and others under their fantastic leadership and mentorship, trying to also collaborate and participate in South Asian research here in the US. So very excited about this topic. I think it's a really important and high impact topic, and one that is near and dear to my own heart. So in terms of key updates and questions, there are going to be 6 topics that we're going to be talking about today. First one is whether actually ASCVD cardiovascular disease is still something that is relevant in South Asians in 2021. We're very used to reading studies from the 80s and the 90s from the UK talking about South Asian cardiovascular disease. But what about 2021? Is this still a group that is at increased risk of ASCVD compared to the other groups? And that's actually definitely the case, a big yes here. This is, for example, a study published here in the US in 2020 using data from Kaiser Permanente, in which the authors showed that compared to other groups, South Asians, they have a 2-fold higher odds of having CHD compared, for example, to whites in the US. And this is a very recent data from Kaiser Permanente. And those were, of course, multivariable adjusted analysis. The same trends were observed also in this recent analysis published by Ani Patel and colleagues in Circulation using data from the UK Biobank, where the authors, they also observed using recent data from the UK that individuals of South Asian ancestry compared to Europeans or individuals of European ancestry living in the UK, they have a twofold higher hazard of having CAD events. And this was in analysis adjusting for multiple confounders. So definitely this trend showing a higher burden, a higher risk of CHD is still present in most recent studies. And we also are learning more and additional interesting things in this space, specifically this paper that was recently published in JAMA by Nilesh and colleagues using data from the National Center for Health Statistics here in the US. The authors observed that the burden of gestational diabetes among South Asian women in the United States, mostly in this case, South Asian Indians in the US, they observed that during the study period, Asian Indian women, they had the highest burden of gestational diabetes, which now we know that is an important risk factor both for the mother and also for the child. And this was consistent across between 2011 and 2019. So definitely this is an important risk factor that we also need to screen, and we also need to be aware of this when we are approaching cardiovascular prevention, specifically in South Asian women. So we continue to learn about this increased risk and the potential causes of this increased risk, but definitely a very important topic in 2021. Question number 2, are all South Asian national groups the same in terms of risk? And clearly that's not the case. We're talking about, when we talk about South Asians, we're talking about a very large group, a group with 1.9 billion people and a very large South Asian diaspora. So you would expect there to be room for heterogeneity also in terms of CHD and ASCVD risk, and that's definitely the case according to most recent studies. Going back to the Circulation paper that I just mentioned by Ani Patel and colleagues, they show this clear trend with a higher burden of CHD risk and events in Bangladeshis compared to Pakistanis, whereas Indians would have the lowest risk of CHD within the South Asian group in this study. The number of Bangladeshis, including this analysis, was only 200, so we're talking about a study that was not sufficiently powered for these comparisons between groups. And actually, as you can see in the figure, the confidence interval for Bangladeshis was pretty wide. But the trend that they described was very consistent with the one that we observe in Catalonia using region-wide databases. And in this case, in this analysis, we included data for 121,000 first-generation Asian immigrants, including more than 80,000 immigrants from South Asia. And in this analysis, we observed consistent trends with Bangladeshi men having the highest burden of CHD, followed by Pakistanis, whereas Indian men would have the lowest risk among South Asians included in the study. And among women, we observed that it was Bangladeshi and Pakistani, the ones who had the highest burden of CHD, whereas Indians had the lowest. This was consistent with other studies, classic studies like the Interheart analysis in 2007, where Pakistanis and Bangladeshis had the highest burden of most cardiovascular risk factors compared to Indian participants in the analysis. This is also consistent with studies conducted in the UK by Julia Hippiesley-Cox and other groups. So there seems to be a higher burden of cardiovascular disease and CHD in Bangladeshis, followed by Pakistanis. Why is this? We really don't know, and this is a very active area of research right now. Multiple studies going on. Some studies, like this classic analysis by Dr. Bhopal, Professor Bhopal, in BMJ in 1999, they have suggested that a potential risk factor or a potential upstream determinant for Bangladeshis having a higher burden of risk factors, most risk factors, and CHD compared to the other groups would be the fact that Bangladeshis, they often have more adverse social determinants of health, lower income, lower education, and other characteristics that are associated with adverse cardiovascular health. So this is definitely one of the potential hypotheses, but there are others that have been proposed, like for example, cultural differences with Bangladeshi diets potentially being less healthy than those for the other groups, lower levels of physical activity have been reported in several studies, and also a higher burden of tobacco use. And we've seen this, for example, in our analysis in Catalonia. Bangladeshis, they tend to have a higher burden of tobacco use, a higher prevalence of tobacco use, particularly in middle-aged Bangladeshi males, compared to the other group. And this is definitely an important risk factor that needs to be taken into consideration when we approach cardiovascular prevention in South Asian individuals, particularly if there's a large proportion of Bangladeshis in the population that is being approached. But as I mentioned, this is an area of research right now in which we really need to invest, because this is going to be very important in terms of understanding why this higher risk in Bangladeshis and Pakistanis, and how can we better approach prevention in these groups, both in the US and elsewhere. Question number 3. What about Indian immigrants in the United States, which is the largest Asian and South Asian group in the country? How should we approach risk estimation, risk assessment in these individuals? Should we use the pool cohort equations? Well, the very reason why I'm focusing on Indians in this specific question is because, as I mentioned, Indians, they have become the largest Asian group in the country, according to most recent US Census data. And also, they are the largest South Asian group. They represent close to 85% of US South Asians. And even though other South Asian groups are growing fast in the country, Nepalese, 200% increase between years 2010 and 2017. And other groups are now very large, like Pakistanis and also Bangladeshis. The question is, for this very large group, which is US Asian Indians, how should we approach cardiovascular risk estimation in the context of the fact that they are at increased risk of cardiovascular disease compared to the other groups? We tested this in a recent analysis using Masala data that was recently published in Atherosclerosis. And we observed, to our surprise somehow, that when you use the equations for whites, the pool cohort equations for whites, which is the approach recommended by the ACC/AHA when risk estimation is being conducted in a group that is not African Americans, when we use the equations for whites, actually, they work pretty well at the extremes of risk. So when you have a patient that is Indian, and the reason why I'm focusing on Indians is because they are also 83% of participants in Masala Wave A, the original Masala study. When the risk, the estimated risk is low, 83% of them, they actually have a CAC score of 0, which, as you know, based on multiple studies, a CAC score of 0 is associated with a very low rate of CHD events during follow-up in multiple racial ethnic groups. So individuals who get a low estimated risk, and they are South Asians here in the US, using the pool cohort equations, they seem to be actually pretty low risk in terms of the burden of CAC, at least in this analysis that we did in Masala. In terms of individuals who get a high estimated risk with the pool cohort equations, most of them, they are actually high risk. We're talking about 84% of them having a CAC score greater than 0, and 61% of them having CAC scores greater than 100, which, as you know from many other studies, that's associated with a high burden of CHD events during follow-up. So again, for low and high risk, the pool cohort equations seem to work pretty well. And as a first step in risk assessment in Asian Indians in the US, that seems to make a lot of sense. So we would recommend that at least until there are specific equations for risk estimation in South Asians in the US, which at some point we would expect those to be available based on Masala data. Question number 4. What about the South Asian as a risk enhancing factor approach? Should we implement that? Is that a good idea with South Asians in the US? And you know that this was recommended in the ACC/AHA guidelines in 2018 and 2019. South Asians were listed as, together with other characteristics, and are associated with increased risk of CHD in populations. But what about at the individual level? Is this a reasonable approach? Our analysis, that the one that I just showed you with Masala data, recently published in Atherosclerosis, does suggest that considering most South Asians at intermediate risk as good candidates for statin therapy, it does make sense because we're talking about 70% of them having CAC greater than 0, 37% of them having CAC greater than 100, even though at the same time, you can also see in this figure that 30% of them, they did have a CAC score of 0. We need more data, we need more prospective data to understand what is the prognosis of individuals with CAC 0 who are South Asian and have an intermediate estimated risk. But this analysis seems to suggest that even though in most of them it's going to be reasonable to use statins, maybe there might be some room for personalized allocation of statin therapy in this intermediate risk group in South Asians, maybe using CAC score to inform those decisions. But particularly in borderline risk individuals, South Asian individuals with this borderline estimated risk, 54% of them, at least among Indians, which were, again, the majority of participants in Masala, 54% of them, they had a CAC score of 0. So this analysis is suggesting that at least for borderline risk individuals, considering all of them on the basis of South Asian ancestry as candidates for statin therapy might not be completely justified. Maybe we can use tools as the CAC score to identify good and maybe not as good candidates for statin therapy, and potential room for personalized allocation of therapies in this subgroup. So there's a lot of room for nuance, and we think that particularly for borderline risk South Asians, CAC might be a very good tool to personalize allocation of intervention. Question number 5. Can we further enrich this notion of risk enhancer sufficient ethnicity as a risk-enhancing factor. And we do think that there's room for more depth in that consideration, specifically because in this analysis, what we observe is that among South Asians at intermediate risk, at borderline risk, and even among those with a CAC score of 0, they do have a very high risk of developing diabetes. There's a high prevalence of pre-diabetes, a high prevalence of abdominal obesity in these individuals. So they are at high odds of developing diabetes over time, which is a major risk factor for cardiovascular disease, particularly in South Asians, as you know. So we would definitely endorse using South Asian ethnicity as a risk-enhancing factor to pursue aggressive diabetes prevention through healthier lifestyles with reduced intake of carbs, increased levels of physical activity, tackling abdominal obesity, and other interventions aimed at reducing the risk of diabetes incidence in these individuals, because definitely that's something that we see that is highly prevalent also in South Asians in the US, and definitely the high prevalence of prediabetes and abdominal obesity, even among individuals with CAC scores of 0 in this study, is definitely striking and is calling for additional interventions in this group, both at the population and individual level. Finally, question 6, what is next in 2021 and moving forward? And there's a lot of interest in this space of Asian cardiovascular health at this. I think at this point is a topic that many people are interested in. There's a lot of interest in this research, and many studies that are going on right now, and many analysis planned with Masala and other studies. And I think this is a nice list of key topics that we're interested in right now: understanding the burden of Bangladeshis, the burden of CHD in Bangladeshis and Pakistanis, specifically here in the US, because most of the studies that I showed you that showed that gradient of higher risk in Bangladeshis followed by Pakistanis come from Europe or other countries, but not necessarily in the US. So we want to characterize this specifically in the US. We want to understand what are the upstream determinants leading to a higher risk in South Asians compared to other groups, and in Bangladeshis and Pakistanis in the US compared to Indians, if that were the case and if that were confirmed in ongoing studies. We also want to characterize the burden of premature CHD, specifically in South Asians and early plaque, which is something that has not been evaluated. And keep in mind that Masala included 40 plus years of age as an inclusion criterion. So we want to understand what happens at age 25, at age 30, age 35 in South Asians in the US. And studies are going to be needed to address this important research gap. And finally, we also are interested in understanding the burden of heart failure in South Asians, because they have multiple risk factors that lead to a higher burden of CHD, of diabetes, and those are powerful risk factors for heart failure as well. So there's a lot of interest in this space, and we also led a review paper in this space in Circulation Heart Failure last year. The Masala study is going to be expanded to include additional 1,150 participants in New York and Chicago from Bangladesh and Pakistan, and we think this is going to be a major improvement and a major development in this space moving forward, because we're going to be able to get a better understanding of the burden of cardiovascular disease in these South Asian subgroups, which are so important as a risk based on studies coming from Europe. And I think that's all. I'm looking forward to addressing questions and discussing these pathways forward in the Q&A session, but this was a 15-minute session, so I wanted to at least focus on most important developments in this space. Thank you so much for your attention. I look forward to the discussion. Thank you.
Thank you, Dr. Kenza Chira, and for highlighting ACSVD risk reduction in South Asians and differentiating even the countries within it. It's exciting to see that Masala is expanding out their cohort to different ethnicities within South Asians. So look forward to more data in the years to come. It's now my pleasure to introduce our next speaker, Dr. Nehal Mehta, who's a Lasker Senior Investigator and Chief for the Lab of Inflammation and Cardiometabolic Diseases at the National Heart, Lung, and Blood Institute. He will speak on inflammatory conditions and risk for premature cardiovascular disease.
My name is Nehal Mehta. I am the Chief of the Lab of Inflammation and Cardiometabolic Diseases, and I will be speaking to you today about inflammatory conditions fueling the risk for premature CVD, lessons learned from psoriasis. I'll start with a case from my practice. 44-year-old female presented for general evaluation. She had borderline hypertension and untreated psoriasis. She was on no medications. Her family history was significant for a mother with type 2 diabetes, a father with premature myocardial infarction, and her social history was significant for tobacco use of half pack per day. She had no general medical complaints. Her physical exam was significant for a blood pressure of 144/89, a body mass index of 32, and a waist to hip ratio of 1. She had 9% of her body covered with plaque psoriasis. Her laboratory data demonstrated a total cholesterol of 210 milligrams per deciliter, an LDL of 159, triglycerides of 200, an HDL of 40, and a fasting glucose of 116. See, she's 44, and she has untreated moderate psoriasis. She smokes and has a family history of CAD. She has diastolic hypertension. She's obese, and her glucose is 116, consistent with prediabetes. What is her cardiovascular risk? Using the old Framingham risks calculator for 10-year cardiovascular risk based on LDL, you'll find that her Framingham risk score is 9%, demonstrating her to be low risk. However, what about the inflammation associated with her psoriasis? Inflammation matters in cardiovascular disease. These are data from the Women's Health Study demonstrating that an elevated CRP, or a nonspecific marker of inflammation, portends a fourfold risk of future cardiovascular events. In psoriasis, which is a chronic inflammatory skin disease shown here in the upper right, it is a common disease that is underdiagnosed, has a lot of immune cells activated throughout the body during a severe flare. For example, shown here, there's over 1 billion T cells and neutrophils activated during this psoriatic flare. Cardiovascular disease in psoriasis is highly prevalent. Shown here on the right are two curves, one in blue for those who have psoriasis and one in red for those who do not. There are two findings here. The curve with psoriasis is shifted 5 years to the left, demonstrating premature mortality. Those 5 years of life lost are due to infection, cancer, and most commonly cardiovascular disease. The red arrow points to an age interaction whereby a young psoriasis patient has a twofold risk of having a heart attack when they have severe disease at a young age. And shown in the bottom left are hazard ratios for various cardiovascular outcomes of interest. Anywhere between 43 and 58% of the increase of cardiovascular risk is attributable to psoriasis in fully adjusted models. Therefore, our conceptual model of studying chronic inflammatory disease using psoriasis as a model is shown here. Through immune activation, systemic inflammation, and lipoprotein dysfunction, there's accelerated myocardial infarction. At the NIH, we have 2 ongoing cohort studies to study the effect of chronic inflammation on cardiometabolic diseases. In the top, we have a scheme for the psoriasis study, which consists currently of 5 visits over 4 years. Visit 1 is a screening visit. Visit 2 is a follow-up at 1 year, and visit 3 is 2 years, visit 4 is at 3 years, and visit 5 is at 4 years. And the purpose of this is to deeply phenotype subjects using PET-CT, PET-MRI, coronary CTA to understand the impact of waxing and waning inflammation on cardiometabolic and cardiovascular outcomes. Tissues of interest such as skin and adipose are collected, and all of these data are compared to healthy patients in protocol number 2 or patients with diabetes and coronary disease to conceptualize the findings. So what evidence do we have that chronic inflammation fuels premature CVD? Well, first, shown here are patients with psoriasis, 120 of them, compared to patients who are having an acute coronary syndrome. One will notice that when one looks at TNF-alpha levels and IL-1 beta levels, these are 9 times elevated compared to those with ACS and 5 times elevated compared to those with ACS in terms of inflammasome activation. Psoriasis is as inflammatory as having an acute coronary syndrome. Second, when one looks at what the effect of chronic inflammation is on lipid composition, one sees this ApoB shift, where there's this increase in intermediate density lipoproteins and an upregulation of small dense LDL as well. Finally, chronic inflammation decreases HDL efflux capacity. Shown here is a macrophage loaded with cholesterol, which is visited by a nascent HDL and through the ABCA1 transporter, esterifies the cholesterol into a mature HDL and then excretes that out into the bile. This process is about 12% retarded in psoriasis and other chronic inflammatory skin disease, loading macrophages, therefore, with cholesterol and accelerating the process of cardiovascular disease formation. When one wants to look at the effect of chronic inflammation on vascular diseases, there need to be some surrogate markers that are reliable. We cannot wait for cardiovascular events to occur in these young patients. So at the NIH, we've set up a multimodal imaging program of vascular beds that include the following: FDG PET-CT, so radio-labeled glucose and injected in to estimate inflammatory burden, or TBR, target to background ratio of FDG in the aortic wall; FDG PET-MRI to understand aortic distensibility and aortic wall thickness; and then finally, every patient also gets a coronary CTA to directly assess plaque burden. By looking this early, we hope to find reversible or preventable causes of future cardiovascular events. Using FDG PET-CT, we first show here that the patient on the right has diffuse inflammation throughout the body compared to the person on the left who does not have psoriasis. 4 cardinal findings are shown here in this FDG PET-CT. Number 1, there's uptake of the skin in psoriatic lesions. Number 2, there's uptake of FDG in the joint spaces. Number 3, there's increased uptake of FDG in the liver, consistent with the psoriatic liver or increased hepatic uptake of FDG. And finally, there's this diffuse vascular inflammation throughout the aortic tree. That vascular inflammation itself can be shown here. On the right, psoriasis has this increased uptake of FDG at the aortic arch compared to controls. And when one looks at the adjusted target to background ratio, one finds that the amount of psoriasis here on the x-axis is directly related to the amount of vascular inflammation on the y-axis. Furthermore, when one looks at the vascular inflammation pattern in CVD post an MI, one finds a very similar pattern of aortic vascular FDG uptake throughout the entire aortic tree. Therefore, it begets the question if inflammation in fact drives CVD, and psoriasis serves as this example, might the coronary artery disease itself start early? So we use coronary CTA here, and we have 2 such machines of 320, and our usual scan is less than 1.5 millisieverts. And shown here is the 3D reconstructed image of the coronary CTA, and using digital subtraction, we will remove the myocardium as well as the osseous features, and we will be left with this vessel of interest. And in this case, the highlighted vessel is that of the left anterior descending artery. And then once the left anterior descending artery is isolated, it then leads to these 4 views here on the right side of the screen where you'll see an inner and outer border. Here's a mixed calcified plaque. Here's a mixed non-calcified plaque. And this will go down until about 2 millimeters. Shown in cartoon format is how we derive this subclinical atherosclerosis and coronary plaque burden. We have the total volume of the vessel, we subtract out the lumen volume, and we get a plaque volume. This plaque volume is a measure of the coronary wall, and atherosclerosis is a disease of the wall before it's a disease of the lumen. So therefore, we can get this plaque volume, and then we index it to the length of the segment so that we report a plaque index for each patient and each artery. So the first finding here to demonstrate that chronic inflammation does in fact fuel premature cardiovascular disease is that the total plaque burden in psoriasis compared to healthy age and gender matched volunteers is approximately 20% higher. The non-calcified burden is approximately 15% higher just by the sheer presence of psoriasis when adjusted for age, sex, blood pressure, lipids, glucose, current smoking, and lipid treatment. This non-calcified plaque is the most common culprit in myocardial infarction, therefore is of great importance. So are high-risk rupture-prone plaque present in psoriasis patients? Shown here is an image taken from one of our papers that demonstrates a right posterolateral myocardial infarction. This plaque here showed positive remodeling as well as low attenuation. And these plaques not only are present in psoriasis patients at the same degree as they are with somebody who has hyperlipidemia and is of 60 years of age, but they occur 14 years sooner. Therefore, the impact of chronic inflammation over the period of time is accelerating premature coronary atherosclerosis leading to ruptured plaque. So finally, the last piece of the inflammation that is important in CVD is when one treats the primary source of that inflammation, there may be modulation of vascular health. So shown here is a tomograph, is an image from a patient, right coronary artery, demonstrating that there is a shaggy plaque in the wall that after 1 year of biologic therapy has soon regressed or at least lost its presence. So the question then became, did treatment of this chronic inflammation modulate coronary disease characteristics? In consecutive patients with moderate to severe psoriasis who started new biologic therapy, we compared them to those who did not. Baseline coronary CT angiograms were compared at baseline in 1 year. In those receiving biologic therapy for systemic disease, or for severe disease, there's a 33% reduction in inflammation. Compared to those who did not receive biologic therapy, there was no reduction in inflammation. All other cardiovascular risk factors also stayed the same. Following 1 year of biologic therapy for the skin, there was an improvement in lipid-rich necrotic core shown from here A to B, as well as an increase in calcified plaque with a decrease in fibrofatty burden plaque. Furthermore, there was a decrease in all patients who took biologic therapy of 5 to 7% of non-calcified plaque compared to those who had no change or even some worsening when they did not go on biologic therapy for severe psoriasis. So again, uncontrolled inflammation for a year is driving more subclinical atherosclerosis. And in fact, what happened to high-risk plaque in those who got treated with biologic therapy, there was a reduction of fibrofatty burden as well as necrotic core by 55%. And in those not on biologic therapy, these parameters increased. Fibrofatty burden and necrotic core increased in these patients, suggesting that an unopposed inflammation over time was damaging the arteries. The biologic therapy used in this study was anti-TNF therapy, anti-IL-12/23 therapy, and anti-IL-17 therapy. Subgroup analyses demonstrated that anti-IL-17 therapy had the most profound effect on necrotic core. Finally, when one looked at coronary inflammation as a marker before and after biologic therapy, these data demonstrate when one looks at the fat attenuation index, one demonstrates that after biologic therapy, there's an increase in the fat attenuation coefficient, decreasing coronary inflammation, thereby demonstrating an improvement in vascular health in the coronary. Shown a different way, this is those who did not go on biologic therapy showed no change in their coronary perivascular fat attenuation index. And those who underwent biologic therapy saw an improvement or reduction in this perivascular fat attenuation, demonstrating a decrease in coronary inflammation. Finally, when one looks at histopathologic validation of these software and finds that when one looks at the lipid-rich necrotic core, accessible by these parameters, one finds that 1 year of biologic therapy and in fact reduces this lipid-rich necrotic core of the plaque. Furthermore, there's a stabilization and an increase in calcium, suggesting that these plaques are becoming healthier or at least less prone to rupture. So what happens when chronic low-grade inflammation is unopposed? Well, in our 4-year study, we found that things do get better when you do in fact treat the inflammation. However, left unaddressed, this is our 44-year-old patient demonstrating serial stenoses in her left anterior descending of 30 to 49% and 70%. So what do we do in the meantime? We remind ourselves that the American College of Cardiology and the American Heart Association has called chronic inflammatory conditions a condition whereby you may offer early statin therapy. And I do believe that education and awareness of these conditions is of utmost importance at this time. So in conclusion, systemic inflammatory diseases such as psoriasis accelerate CVD. Systemic inflammation in psoriasis is associated with a spectrum of cardiovascular and cardiometabolic disorders. Education and awareness are much needed to improve CVD-related mortality. And I will end with this infographic, which demonstrates the root of all of this hyperkeratosis is systemic inflammation. And in this systemic inflammation, we see heart disease, obesity and diabetes, mental health disease, as well as mental illness, as well as chronic arthritides and those affecting the musculoskeletal system. I'd be happy to take questions in the live Q&A, and I can be followed at Twitter at Nehal Mehta MD, as well as emailed at nehal.mehta@nih.gov. Thank you for your attention.
Thank you, Dr. Mehta, for an excellent presentation, and thank you for your outstanding research on the association of psoriasis and cardiovascular disease. Now it's my honor to introduce our next speaker, Dr. Matt Budoff, who is professor of medicine at UCLA and has an endowed chair of preventive cardiology, and he's an investigator at the Lundquist Institute. He will be speaking to us about CVD prevention in those patients with low testosterone.
Okay, hello, this is Dr. Matthew Budoff presenting to you on cardiovascular disease prevention considerations among those with low testosterone. I have no conflicts of interest relative to this presentation. So a huge issue is low testosterone, labeled menopause or andropause, huge opportunity for research and a huge prevalence among older men losing muscle mass, vitality, erectile dysfunction as testosterone levels decrease. Beyond the physical, there's also cardiovascular implications of low testosterone. This is the epidemiology of low T. You can see up to 40% of men over the age of 45 have hypogonadism. The Baltimore Longitudinal Aging Study looked at this over time and reported 20% of men in their 60s and 50% of men in their 80s have hypogonadism. That led to and they estimated a 1.6% per year decline in serum testosterone with associated increases in LH and FSH. So as we think about the epidemiology of this and the vast numbers, as our population continues to age, more and more men are going to be diagnosed with low testosterone. And the question is, should we replete them? Should we just treat them for their CV risk factors? We need to understand that there is a direct relationship between hypogonadism and atherosclerosis and ultimately mortality. These men are more likely to develop insulin resistance and metabolic syndrome, which could lead to diabetes. These men have the hypogonadism can promote vascular stiffness, which leads to hypertension, and they get dyslipidemia. And all of those things contribute to atherosclerosis, and atherosclerosis obviously lends itself to a worsening cardiovascular mortality. So these men are more likely to die with low T. The epidemiology is quite clear. The question is, should we be repleting them? So this was a randomized trial published in the New England Journal of Medicine looking at testosterone administration. The TOM trial, 10 grams of transdermal gel, either placebo or 100 milligrams of testosterone was applied daily for 6 months. Only 209 men were enrolled at the time the trial was terminated. It was a double-blind, placebo-controlled trial, but it was stopped prematurely because of higher rates of cardiac events, but also respiratory events, as well as some dermatological side effects from the administration. Here you can see the cardiovascular-related events were significantly higher. Remember, this was a 6-month trial, and you can see dramatic curve separation with testosterone patients doing much worse rapidly by being randomized to testosterone as compared to placebo. So in this small study that was truncated early, we saw a dramatic increase in cardiovascular events among those patients randomized to testosterone repletement instead of placebo with a p-value less than 0.001. Since that time, there have been a number of observational studies. I'll show you the vegan study. but looking at these two observational studies, both not randomized, but large observational studies demonstrating that if testosterone repletion was given, there was an increase in mortality, myocardial infarction, and stroke. So the combination of the TOM trial plus these observational studies led the FDA to change their warning about testosterone replacement and caution about using testosterone products for low testosterone due to aging, and required a label change to inform of possible increased risk of heart attack and stroke. I'll just show you this one study. This is from Rebecca Vegan, published in JAMA, retrospective national cohort study looking at men in the VA system that had low testosterone. They were observed for all-cause mortality, myocardial infarction, and stroke. It was not randomized. There were 7,500 untreated patients and 1,700 treated patients. And here you can see in the testosterone group had worse outcomes than the no testosterone group. Again, not a randomized trial, but when controlled for all other factors, there was still an excess risk of death. This is just a survival curve here that you can look at as patients who are randomized and the number needed to harm. The difference between these two groups was 5.8% absolute risk. So a number needed to harm by using testosterone repletion in elderly men was 17. Now, this was a patient population that went to the cardiac cath lab, so you can argue that maybe they were at increased risk because of underlying CAD. So then the testosterone trials were done, an NIH trial looking at men over the age of 65 with low testosterone. The intervention was androgel or matching placebo. And then I led a sub-study of the overall testosterone trial, which was 7 different trials looking at things like vitality, muscle strength, cognition, erectile dysfunction. I led the section on cardiovascular disease, and this was our publication in JAMA on testosterone treatment and coronary plaque volume. We did serial CT angiography in patients. They had to have atherosclerosis to be randomized. They were randomized to either placebo or testosterone replacement in a double-blind placebo-controlled trial. You can see in blue what happened to the placebo group over the course of 1 year: mild increase in non-calcified plaque, an increase in total plaque, and all the different factors, low attenuation, fibrous fatty, fibrous and dense calcific plaque. And then in red, what happened under the influence of testosterone. We saw dramatic increases in non-calcified plaque with testosterone as compared to placebo. That was the primary endpoint of the study. The secondary endpoint of the study was total plaque. And here you can see total plaque also increases significantly. And then across the 4 different components, we saw increases with low attenuation or vulnerable plaque, increases in fibrofatty plaque. The largest increase was in fibrous plaque and no change in dense calcific plaque. But we concluded that testosterone accelerated overall atherosclerotic burden as evidenced by both non-calcified and total plaque burden. So there was concern. The testosterone trial was a small study. The 1-year study looking at atherosclerosis, not endpoints. We have the TOM trial, but that was truncated early. So we need a large trial. So this trial is now ongoing. This is called the TRAVERSE trial, looking at major adverse cardiovascular events in men on testosterone. There are 6,000 participants randomized, again, to either androgel or placebo. Time to major adverse cardiac events is expected to be 5-year trial, and a composite of non-fatal MI, non-fatal stroke, or death due to cardiovascular disease. So standard 3-point MACE. The trial is ongoing, and we have no early information yet related to the outcomes. So what do? Well, you have older men with symptoms of low testosterone, libido loss, muscle loss, vitality loss, other issues that they may be concerned of. We're supposed to measure testosterone. You should draw 2 samples before 10 a.m. Generally, total testosterone levels below 275. Some studies use 300 as a cut point. And then you should think about, if you find people with low testosterone, you should think about low T causes, medications such as opioids or corticosteroids. Obviously, if they're using anabolic steroids, their natural expression will be suppressed. Obesity and type 2 diabetes are both common in this population, but think about other things: excessive alcohol use, hemochromatosis, severe hypothyroidism are all possible secondary causes of low testosterone, which obviously would not require repletement. If you are going to go after testosterone repletement, personally, I would consider avoiding it until more is known. If you are going to use testosterone repletement in your patients, I would target lower levels of serum testosterone. The goal in the T trial, where we showed the atherosclerosis progression, was to take 70 plus year old men and make them 40-year-old men. I think that you might want to get their serum testosterone, if you are going to use repletement, to the lower limits of normal. So if they're low, you get them up to low normal, not to moderate or high levels. Some people use a lot of testosterone, and we all know the complications of steroids over time. I would also urge you to consider a calcium score or another screening for atherosclerosis. And if they have severe atherosclerosis, I would avoid testosterone in that population, as we know it promotes more atherosclerosis. And in both the observational studies as well as the randomized TOM trial, there were more cardiovascular events in these older men. We want to certainly focus on traditional risk reduction, certainly based on the coronary screening, statins, aspirin, aggressive blood pressure control, lifestyle, in addition to or separate from the testosterone repletement. But don't forget your basic tenets of preventive cardiology in this older population of men who are by definition at increased risk. So big picture, while we know that there are differences between men and women, it's long been proposed that the women have less cardiovascular events or a later onset of cardiovascular events due to higher levels of estrogen. But I think it's likely that higher levels of testosterone in men may account for some of the age-adjusted cardiovascular event rate differences. The higher levels of testosterone in men may be promoting atherosclerosis, causing them to have an earlier onset of atherosclerosis than women, who generally run with lower testosterone levels. If you are going to go down this road of testosterone repletement, you should be monitoring your patients carefully. Again, I would advocate some form of cardiovascular screening and or monitoring, whether it's a coronary calcium scan or a CT angiogram or carotid ultrasound. But I would urge you to consider CV screening prior to initiation. And if you find high levels of atherosclerosis, I would certainly be very cautious about giving any testosterone repletement. The only good data we have so far is that testosterone repletement is associated with more CV events. Again, we're waiting for the TRAVERSE trial, but until that is known, I think the presumption is, as the FDA put it, that there may be a cardiovascular risk associated with testosterone repletement. And if you take somebody with a high baseline risk, like a severe calcification or a known obstructive disease, you could exacerbate that significantly. So thank you very much, and I'll be glad to participate and answer questions in the panel discussion. Have a great day.
Thank you, Dr. Buddha, for a nice presentation. Just to get us back on time, I just have really quick, brief questions for each of you. We'll start with Dr. Mehta. And, for our everyday clinician that's out there taking care of patients with inflammatory conditions like psoriasis, What should we be asking them to monitor in their patients after listening to you? Should they be checking CT angios in all of their patients, or just the inflammatory markers good enough?
It's a great question, and I'll be brief to keep us on time as well. So I call them the 3 Bs, and I usually will close most lectures with saying that one should know their blood pressure, one should know their body mass index, and one should know blood for cholesterol and glucose. So we call that the 3 Bs. If most people are given those values in psoriasis, you'll probably pick up about 60 to 70% undiagnosed cardiac risk factors. So that right there is the most important. And then in terms of inflammatory markers, I would say that hsCRP underperforms in a lot of these inflammatory diseases. So starting with risk factor modification as well as risk factor detection is probably your biggest bang for your buck, if you will.
Thank you. Now, my next question is to Dr. Sharma, who eloquently described the association of hypertensive disorders of pregnancy and future CVD risks. This is an important area, and it's not just for the clinicians to be dealing with this or the patients. Is there a broader role for society and a need for health policy changes? And you're muted, Dr. Sharma.
Every day. Yes, absolutely. So, as a clinician that sees these patients, I think one thing that's most striking here, Dr. Mehta, is that about 40% of women with hypertensive disorders of pregnancy and even preeclampsia with severe features will not follow up at their 6-week visit with their MFM. And so there is going to be a leaky pipeline across the spectrum of women with, these complications. So I think the first thing that all societies have to do and health policy intervention has to do and public health intervention really has to take a look at is expansion and retention of these women into postpartum clinics, because you cannot treat what you cannot diagnose. And these women will come if they're motivated, and that starts during pregnancy. We can also do many other different type of interventions like telemedicine, which is cost effective in many of these resource limited areas. But beyond that, the bigger problem is expansion of Medicaid. Most of the women that have hypertensive disorders of pregnancy in rural or inner city areas do not have any care after 60 days postpartum. So if you are a woman who's had a hypertensive disorder of pregnancy, even if you wanted to see a doctor, you can't after 60 days, or you'll have to go through an additional insurance plan. So that's like the really low-hanging fruit where Medicaid expansion saves lives. And so I think health policy interventions really have to look at taking that science and implementing that science at the level of, at the level of these patients.
Thank you, Dr. Sharma. My next question is for Dr. Budoff. Patients often say they feel better with testosterone. So how do you counsel your patients about the CVD risks? And then are you recommending, if they don't have any atherosclerotic plaque to start off with, are you recommending serial management or testing in these patients?
No, that's a great question. I think that I think we keep making a mistake of trying to take older people and making them, back to their prime. For example, in these trials, we took 75-year-old men and said, we're going to make you 40 years old based on your testosterone level. In some of the estrogen repletement trials, we took 70-year-old women and said, we're going to make you premenopausal. And I think that that's too extreme. So the one thing I would advocate is if you're going to replete patients, go to the low end of normal rather than trying to get them to high normal. They might not feel 20 again, but they'll be safer and they'll live longer. And that's part of our charge. I think if their score is 0, or if their carotids are clean, or if they're low risk, I don't necessarily retest them, although the guidelines say to consider it every 5 years. I think that's reasonable. I think if they have a high score for calcium, or if they have a lot of plaque, or you perceive them to be high risk, I would do serial testing, maybe every 1 to 2 years, just to make sure things aren't getting worse. And until we know the results of the TRAVERSE trial, we have to presume that testosterone is harmful for men from a cardiovascular standpoint. There's no data pointing the other direction. So I think we just have to be cautious and make them feel better, but not make them live shorter. It's quality and quantity of life, I think, are both important.
Thank you. Before I pass the mic back to Miguel, I want to thank all of you speakers for outstanding presentations. And just one comment I would say to Miguel, thank you for highlighting South Asians and risks with cardiovascular risks. But one of the gaps that's going to remain for our patients is the cultural barrier, right? I mean, you're talking about diabetes and cardiovascular issues, but rice and the concept of exercise, and there might need to be pilot studies on how do we engage the patients better in that aspect. So I'll pass the mic back to you, Miguel. Thank you.
Thank you so much, Dr. Mehta. I think that's a very important question. A lot of interesting work going on right now. I think particularly the Masala investigators in Chicago, they are doing a lot of interesting things with young South Asians, South Asian women, trying to engage them to do more physical activity in ways that that the intervention is culturally relevant to them. Bollywood dancing and other approaches. I think that's the way to go. We are also trying to implement this in Barcelona, in Spain as well, trying to, first of all, understand the cultures, and second, trying to tailor our interventions to make them more meaningful and relevant, because we think that's going to make them more effective, right? So that's definitely one of the areas of research in this space, and I think definitely Masala will bring important answers to this question.
Perfect. Thank you, and I'll let you take over again.
Thank you so much. Thank you, Dr. Mehta. Thank you to our wonderful speakers. This was a fantastic session. And now we're going to move on and move to the next and final block, last but definitely not least. And now we're going to be talking about common scenarios in the preventive cardiology clinic. And for this, we have a wonderful panel of speakers as well. And I'm very honored to introduce as moderator our dear friend, Dr. Marta Gulati. Dr. Marta Gulati, she's the Chief of Cardiology in the University of Arizona in Phoenix. She is a professor of medicine, and she's the president-elect of the American Society of Preventive Cardiology. She's an international leader in preventive cardiology, and particularly in women's cardiovascular health, and she is going to be moderating this session together with myself. I don't know, we have Marta online? Okay. Seems like she's having trouble connecting. No problem, I can introduce the first speaker, who is also a really good friend of us here in Houston Methodist, Dr. Mike Shapiro. Dr. Michael Shapiro, he is a professor of cardiology. He is the director of preventive cardiology at Wake Forest Baptist Health. And he's one of the world's experts in cardiovascular risk, in lipids, and in lipid-lowering medications. We're very much looking forward to his talk, and looking forward also to a great discussion later. Thank you so much.
Well, thank you very much. It's really a pleasure to be at this second annual Houston Methodist Cardiovascular Disease Prevention Symposium. And I'm going to be addressing the question as to how I assess and manage statin intolerance. Here are my disclosures. So I'm going to frame today's conversation within the context of 4 questions, starting with why do we prioritize statins as lipid-lowering therapy in almost all circumstances? 2, how common is statin intolerance? 3, what are statin-associated muscle symptoms, otherwise known as SAMs? And how do I deal with these issues? So let's start with that first question. Why do we always prioritize statins as lipid-lowering therapy in almost all circumstances? And there are a variety of reasons for this. First of all, they produce remarkable reductions in LDL cholesterol, particularly those high-intensity statins, as you can see here for atorvastatin, rosuvastatin. They can produce LDL reductions as high as 55 to 60%, which really rivals the PCSK9 inhibitors. Moreover, they treat almost every lipid problem that ails you. So I have a particular interest in lipids, but if you're not as enthusiastic as I am, you're probably never going to be wrong when somebody asks you what lipid-lowering therapy, at least to start with. Statins are likely going to be the answer. Certainly, we know that for LDL cholesterol, and I'm going to provide even more details there, but also for triglycerides. They're actually reasonably good triglyceride-lowering agents. I think many are not aware of this because all the statin mega trials were really tested in individuals who had normal triglycerides. That was part of the inclusion criteria. But when they've been looked at in other circumstances, they're actually fairly good at lowering triglycerides in individuals who have elevated triglycerides. And like all other triglyceride-lowering therapies, their ability to reduce triglycerides is contingent on baseline triglyceride levels, but they can generally get a 25 to 30% reduction in triglycerides. They're also reasonably good at raising HDL cholesterol for whatever that's worth. Some of the statins are associated with about 10% increase in HDL cholesterol. But more importantly than that is we know that most patients with low HDL cholesterol is related to insulin resistance, whether it's prediabetes, metabolic syndrome, or frank diabetes. Low HDL cholesterol is actually part of this mixed dyslipidemia, which also includes high triglycerides and elevated non-HDL cholesterol, elevated ApoB, elevated LDLP, however you want to look at atherogenic lipoproteins, and therefore statins address the increase in atherogenic lipoproteins in individuals with low HDL cholesterol. So they're really good in almost every dyslipidemia. Most importantly, though, they have really remarkable cardiovascular outcome trials data, as we know from the cholesterol treatment trialist collaboration, that for every 40 milligrams per deciliter of LDL cholesterol achieved with statins, we see a corresponding 22% reduction in major adverse cardiovascular events. And this has been seen consistently across a wide range of trials. Interesting, statins lower risk, even if LDL cholesterol is not the risk factor. A tenet of risk assessment and treatment is the initiation of statins according to global risk assessment. So we start out in primary prevention patients without known cardiovascular disease, with a quantitative risk assessment tool. We now currently use the pooled cohort equations, which don't actually have LDL cholesterol as a covariate. So if you exceed estimated 10-year risk of heart attack or stroke of 7.5%, if your risk is higher than that, then statins are generally recommended. So we prescribe statins according to risk, not necessarily only due to elevated LDL. Fortunately, statins are inexpensive. We've had these drugs since the 80s. The first statin was approved in 1987. Of the 7 statins that are currently available, 6 of them are generic, and it generally, for a generic statin, costs about $40 per year. So based on all of this remarkable data, should statins be in the water? And I think the answer there is clearly no. Firstly, we don't have any long-term studies of continuous statin treatment for years and years and years. Most importantly, though, the number needed to treat for low-risk patients is enormous. So we don't necessarily want to give statins to patients who aren't likely to get much benefit. And as we're talking about today, statins do have side effects. Now, what is the incidence of these side effects? How many patients are actually statin intolerant? It depends where you look. If you look in the randomized controlled trials, confirmed intolerance is about 5%. But if you look in real-world data, registries, observational studies, intolerance is much greater. It's about 20 to 30%. And I think for many of you in your clinical practice, you encounter this issue quite often. So why do we actually care about statin-associated effects? What are the implications of this? We really do need to care about it, because here, from this very nice analysis just a few years ago, looking at a large cohort of Medicare beneficiaries, they looked at individuals with high statin adherence versus those who had low adherence due to statin intolerance. And relative to those with high statin adherence, those with statin intolerance had a 50% higher risk for recurrent MI and a 51% higher risk for coronary heart disease. The hazard ratio of statin intolerance was a 1.5 for recurrent MI and CHD events. And this other recent analysis published in the journal Clinical Lipidology, we see that patients with statin intolerance were less likely to reach their LDL cholesterol goals. They incurred higher healthcare costs, and they experienced a higher risk for non-fatal cardiovascular events than patients without statin intolerance. So let's talk about some of the details about statin-associated side effects. Well, SAMS, statin-associated muscle symptoms, is by far and away the most common. This refers to myalgias, muscle cramps, even weakness. But there are other important side effects, including dysglycemia, cognitive dysfunction, elevated transaminases. For the purposes of today's brief discussion, we're just going to be talking about SAMS. So how do we make a diagnosis of SAMS? Unfortunately, there's not an imaging study or a lab test that we can simply get, but there are factors that favor a clinical diagnosis as follows. First of all, SAMS is symmetric and proximal large muscle pain or weakness, typically worsened by exercise. So for the individual who says, my left pinky hurts every other Tuesday, that is, of course, not SAMS. It tends to be the thighs, the shoulder girdle, and symmetric. Generally, the onset of symptoms is 2 to 4 weeks after statin initiation, though it can be seen later, but most commonly it's pretty quick. And the resolution is quick, generally within 2 weeks of discontinuation. And then upon re-challenge, this is really where we can confirm the diagnosis if patients are willing to do this. Those symptoms will generally return within 2 weeks after we reintroduce the statin. Now, symptoms occurring with 2 or more different statins, at least one of which is prescribed at the lowest dosage, is a practical definition that we'll talk about in a little bit more detail in a minute. So a number of professional societies have come up with definitions of SAMs to help clinicians in making the diagnosis and to help patients achieve their LDL cholesterol goals despite having side effects. This is from the Statin Muscle Safety Task Force of the National Lipid Association. And they define myalgias as aching, stiffness, or muscle cramps. Myopathy as frank weakness, myositis involving inflammation, and then, of course, myonecrosis, where we see elevation of CK, and can be defined as mild, moderate, or severe. And then finally, rhabdomyolysis is myonecrosis with significant elevation in creatinine. The European Atherosclerosis Society convened a consensus panel also to define SAMs. In their definition, if an individual is taking a statin and describes muscle symptoms, but has a normal CK, they consider that myalgia that may or may not be related to statin. If they have muscle symptoms and elevation of CK increase, that is then, in their definition, statin-associated muscle symptoms. If the muscle symptoms are accompanied by a large increase in CK, they call that myositis or myopathy. And of course, if it's severely elevated, they call that rhabdomyolysis. But I think probably the most useful definition of SAMs comes from the 2017 focused update of the 2016 ACC Expert Consensus Decision Pathway on the role of non-statin therapies. Is defined here as really unacceptable muscle-related symptoms that resolve with discontinuation of therapy and occur with re-challenge. That's something that we talked about before. This should happen at least with 2 or 3 statins, 3 statins preferably, ones that use different metabolic pathways and have different lipophilicity, which I'll discuss in a moment, and one of which is prescribed at the lowest approved dose. So this is a clinical diagnosis. It requires trial and re-challenge. So you start a statin. If somebody has muscle symptoms, you stop it. You try maybe another statin. And if they have SAMs or have muscle symptoms again, that may be SAMs. If a patient is willing to go with a third challenge, that really is diagnostic if they have recurrent symptoms. So I just mentioned this concept of lipophilicity, and I want to talk about the pharmacological profiles amongst different statins. Lipophilic statins diffuse non-selectively into extrahepatic tissues such as muscle, and at least historically have been believed to be associated with a higher incidence of SAMs. Simvastatin is the most lipophilic statin and is certainly associated with the highest incidence of SAMs. The hydrophilic statins are actively transported into hepatocytes and are technically or theoretically associated with a lower incidence of SAMs. And 2 hydrophilic statins would be pravastatin or suvastatin. So these tend to be used in individuals who have muscle symptoms. And changing from a lipophilic to a hydrophilic statin is a reasonable first-line alternative drug strategy for patients who are encountering muscle symptoms. Another approach would be to use a statin with a long half-life, such as rosuvastatin. So rosuvastatin has 2 advantages. It's hydrophilic, and it has a half-life of almost 24 hours. So it can be a good choice for intermittent dosing. So for patients who are really struggling with statin, you could start rosuvastatin once or twice a week, and then maybe move to 3 or 4 times a week. And if tolerated, maybe a low dose every day. But even at 2, 3, or 4 times a week, you can get significant LDL lowering. Of course, not the same as if they were to take it daily, but it can still be significant. I would point out there are a number of tools that are available online as apps for helping decide whether or not a patient has SAMs. I think this is one of the most helpful tools. It's the Statin Intolerance app from the ACC, tools.acc.org/statin intolerance is where you can find it on the web. And it takes you through the evaluation and follow-up and does drug comparisons as well. So it's really nice. It walks you through the whole process for any of you who are interested in that. What about exercise in statin myopathy? A couple of principles here. Exercise generally causes many of the CK elevations attributed to statins. So individuals who are doing a fair amount of exercise, we may blame the statin when in fact the CK elevations are exercise. We need to be careful. Exercise certainly magnifies statin muscle symptoms and CK increases. And some patients report weakness, but there's little objective data on muscle strength or exercise performance. Finally, we want to make sure our patients are fully aware of the indication for the statin treatment, intended benefits and safety of statins. What I mean by that is, patients may be thinking that the statins are only prescribed to lower LDL. While that's true, the real reason we're prescribing statins to patients is to prevent heart attack and stroke, not to make the lipid panel better. So we really need patients to understand why we're prescribing statins. There are a number of predisposing factors for SAMs, and if you look at the literature, the lists are endless. I just wanted to point out the most common and most important ones so that you can keep this in your memory. Older age is probably the most important for individuals who are 80 years or up. It's really quite common to see statin-associated muscle symptoms. Female sex and Asian ethnicity are also important. Family history of myopathy or family history of SAMs is definitely associated with SAMs in an individual taking a statin, as are alcohol use and rheumatological disease. You'll also come across as predisposing factors chronic liver disease and chronic kidney disease. There are a number of medications that are associated with SAMs. The combination of a fibrate and a statin is a well-known one, but I'd point out that really is related to an older fibrate, gemfibrozil. You cannot combine gemfibrozil and a statin. The fenofibrate and other newer fibrates, you can do so, particularly at lower doses. But as you can see here, colchicine, some non-hydropyridine calcium channel blockers, protease inhibitors, antibiotics, antifungals can also be contributors to SAMs when combined. Now, a lot of patients use a variety of therapies, including supplements, that try to manage their myalgias, but you need to ask about this in patients who are having muscle symptoms, and patients need to be counseled that none of these have actually been proven to help with SAMs. Coenzyme Q10 and vitamin D definitely have not they do not have strong evidence of benefit. Red yeast rice can lower LDL, but it's essentially lovastatin. So if an individual tolerates red yeast rice, you're better off just prescribing them a low dose of lovastatin, which is regulated and is far less expensive than red yeast rice. Berberine is another supplement that you'll see patients taking. It lowers LDL, also lowers glucose, but again, is often associated with a lot of gastrointestinal side effects, and patients are probably better off, certainly better off taking a statin if they're willing to do so. Whereas years ago, if patients had SAMs, we really had to try every trick in the book to try to get them through that, particularly in individuals who had established cardiovascular disease. Fortunately, we're now in an era where we have multiple non-statin agents, many of them with good evidence that they reduce cardiovascular events. So I don't think we have to struggle as hard as we used to. Now we can try 2 or 3 statins and the patients don't tolerate them. We can pivot. We have drugs like ezetimibe, bempedoic acid, the combination of ezetimibe and bempedoic acid, PCSK9 inhibitors, and soon to be approved inclisiran. So we don't have to, and patients don't have to struggle for as long of a time before we get them on alternative LDL lowering drugs. So to summarize, this is how we manage SAMs. You start a statin. If patients develop muscle symptoms, you stop it. On rechallenge, you can lower the dose of that statin, or you can switch the class. Remember, specifically looking at the lipophilic statins, rosuvastatin and pravastatin. Or if patients can't tolerate a statin at all, or they can only tolerate a low dose of the statin, we can either switch to a non-statin or add a non-statin to a low-dose statin. So in summary, statin-associated side effects are important because they impact cardiovascular outcomes. Of all the statin-associated side effects, SAMs is the most common. It's practically defined as not being able to tolerate at least 2 statins, one of which is prescribed at the lowest approved dose. We want to educate patients as to why they're taking a statin. They need to understand that the real reason that they're taking a statin is not only to lower the LDL, but to prevent heart attack and stroke. And of course, there's a variety of strategies to manage SAMs, including the use of new non-statin lipid-lowering therapies. And that, with that, I'll end, and I'll be happy to take any questions. Thank you.
Well, thank you, Dr. Shapiro. That was an excellent talk, and we encourage you to put in your questions into the question space, but we'll take all the questions at the end. Our next speaker is Dr. Basu Ray, who's an electrophysiologist coming from the Memphis VA and also faculty at University of Memphis School of Public Health. He's also faculty at MIT and a visiting professor at the All India Institute. And he's going to be speaking on stress reduction. Does it work?
Good morning, everybody. It's a pleasure to be here. I'd like to thank Dr. Nasser for giving me this scope to present to you guys. We have been working in the field of role of stress and how we can use non-pharmacological measures to curb stress and its effect on cardiovascular disease. So let's get started with today's presentation. My talk today would be stress reduction, does it matter? So I'm going to basically talk in three different important issues here. One, we're going to talk about the psychiatric disease and the role of stress in that. Then we're going to talk with psychological stress and what it does, how does it cause CVD. And finally, we are going to describe the molecular mechanisms of stress so that we understand exactly how stress works at the molecular level, at the genetic level, at the epigenetic level, and induces coronary artery disease, heart failure, severe deadly arrhythmias, altogether, which is the largest killer in this planet and kills almost twice the number of patients than the second largest killer, that is cancer. So let's get started with the first slide. So one of the important mental issues that causes a lot of stress and is directly responsible for cardiovascular disease is depression. It is way back in the 1970s that it was first shown that hospitalized patients who are depressed, they tend to get higher mortality. And then there were many other studies which actually showed that there's a threefold increase in mortality in patients who have depression than those who do not have depression but have been admitted to hospitals for the same reason. Since then, we have had large number of studies till now that clearly shows that depression not only increases mortality, a person with myocardial infarction having depression has twice the amount of mortality than the same person, the same cohort, same age, same sex, same risk factors, but without depression. In 2017, we had the good fortune to write down the AHA scientific statement on the role of meditation in cardiovascular diseases. And we found hundreds of articles that showed direct experiments, reviews, and case control studies that clearly showed that depression actually increases cardiovascular mortality in multi-folds than people not having depression. Next important thing that we need to talk about is anger and hostility. So higher levels of anger and hostility is associated with poor outcomes in both healthy and cardiac population. Somebody who is easily angry, somebody who has hostile personality, like type A personality, tend to have 19 times more chance of developing cardiovascular disease, including myocardial infarction, heart attack, atherosclerosis, than a person who is not. And the important aspect of this is if you're already a cardiac patient, then you have a greater risk of developing or having unfavorable incident, which includes myocardial infarction and a bunch of other things, worsening heart failure. Basically, your MACE, M-A-C-E, is increased in case you have an angry or a hostile personality. So next part that we're going to talk is about stress and actual cardiovascular disease. Again, there has been a large number of studies talking about real psychosocial stress and cardiovascular disease. So the first point I like to bring in is when we talk about stress, we talk about two different things. One is acute stress and then chronic stress. They both are damaging, but one is more damaging. Chronic stress is more damaging than acute stress. Now, while we talk about stress, it is important to understand the different types of stress, and some are beneficial, some are not. For example, tomorrow I have an interview for a new job and I have a stress. That's good stress. That's not toxic stress. That stress might actually improve my performance. And there has been research using microelectrodes in the brain and other PET scanning that it can actually increase protein formation in my temporal lobe, which makes my memory better. So if I'm giving an exam tomorrow and I have exam stress, that is normal. Obviously, as soon as the exam gets over, my stress goes off. But there's something called toxic stress, which means the stress continues despite the acute trigger is completely gone. It is this toxic stress that causes a large number of heart disease, including sudden cardiac death, severe arrhythmias, heart failure, and certainly myocardial infarction. So let's talk about some of those acute and chronic stress and how it causes increased cardiovascular disease. So acute stress, any form of acute stress, whether it's natural or it is man-made, increases heart attack, increases sudden cardiac death, increases decompensation in patients with having chronic heart failure. Whether it's earthquake, whether it's blizzard, whether it's man-made problem, everything. So for example, when the World Trade Center was collapsed after multiple planes hit them, within the 2 weeks following it, the number of myocardial infarction increased twice-fold. And this twice-fold increase not only happened in New York, but actually happened even in Louisiana, which is hundreds of miles away from New York, even in families which did not have any direct correlation with what has happened in New York. So this has also been compared with September 11, multiple years before and multiple years after. And there has been an increasing, slight increased trends that has been seen even years after the 9/11 took place, which shows that not only stress is important, but also perceived stress is very important. And perceived stress does include cardiac mortality, almost 2 to 2.5%, 2 to 2.5% times than just like normal stress. And obviously, just like this man-made disaster, there are multiple natural disasters we have on an everyday basis. There's fire somewhere, there's tsunami somewhere, there are multiple earthquakes. For example, the earthquake in San Francisco in 1989 increased cardiac mortality, increased heart attack, increased cardiac decompensation in ischemic and non-ischemic cardiomyopathy. So all these natural stress also causes an increase in cardiac decompensation and in heart attacks. Now, we do not know the mechanism now, and a lot of genetic, epigenetic causes have been delineated, and we'll discuss a little bit about them today. But what is important to understand that this is not population-based. For example, it happens only in America, or it happens only in India, or it happens only in China. It's not like that. This is a worldwide phenomenon. After earthquakes, whether it's in Athens, whether it's in Japan, the increased mortality is concomitantly seen in every population. So this is what we now know, and we shall discuss a little more as we go forward, is something we as a human being share, irrespective of whether we belong to India, Pakistan, Japan, China, or the America, or the United States of America. Next important thing to understand is chronic stress. Chronic stress is where stress continues despite the acute stress is no more there. This is, as I said, there are different types of stress. This is what we term as toxic stress. So the trigger is there, you get stressed, trigger goes away, you stop stressing. That's normal, and most of the time that sort of stress is actually beneficial. Then comes a form of stress, and you have a stress, and then the stress goes off, but you're still sad, you're depressed for some time. For example, somebody's parents dies, somebody has a divorce. All of them cause stress, but the stress goes off in a month, couple of months, 6 months, in a year. But it is the chronic stress that lives forever, despite the trigger being gone. That's what is highly toxic and has got severe cardiovascular ramification, as we shall talk. So I'm just going to, because of the talk is restricted in time, I don't want to go to a lot of studies, but there's been hundreds, literally hundreds and thousands of studies on the role of chronic stress and heart disease. But one of the landmark study that is pretty old, but still a landmark study, is the InterHeart study that had almost 12,000 people as active group and 13,000+, almost 14,000 people in the control group. It was spread over 52 countries and at least 260 medical centers all over the world took part in this study. What it clearly showed that the people who had first MI, their first attack of myocardial infarction, had much, much greater stress, whether it's work stress, stress at home, stress with siblings, stress with spouses, general stress, and permanent stress. And that is true for age and sex matched controls. So there was no particular predilection either through age or sex, but it was only the fact that you are stressed, and the cause of stress is as wide as you can think of. Those people are the ones who generally get acute MI, and their statistical significance as far as that is concerned. Now, as I had mentioned before also, it's important to understand that it's not only stress, but also perceived stress. Are you perceiving that you're in stress? You may not be in stress. Your job may not be in danger. But still, if you consider your job is in danger, you're likely to have a myocardial infarction. You're likely to have a cardiac decompensation. You're likely to have a poor control of your heart failure. So it is not the stress, but also perceived stress, which causes it. And we'll discuss a little bit of this as we go forward as to what the reason is. The good news is that because of massive development in technology, we've been able to go inside and see the functional and neuroanatomy of the brain and how it functions in different physiological states. We have been able to find the molecular signature of stress, and thus it has been possible for us to understand why chronic stress is so toxic, and we'll discuss some of them in today's talk. So this is a whole group of study that I wanted to show you guys, and it's, as I said, we are restricted to a 16 minutes, 15 minutes talk, so it's not possible to discuss everything. But as I said, there have been hundreds, literally, studies that has discussed different types of stress. And it's not possible to highlight all of them in a small 15-minute talk. But I purposely have put this extremely busy slide. My intention is not that you go with each and every one of them, but just to highlight some of the important points that I want to bring out. As I said, every aspect of stress causes increased cardiovascular mortality, whether it's stress in childhood, if you've been sexually abused, if you have been poorly treated, if there was any other form of child abuse, everything increases cardiovascular disease. Job, one of the most studied aspects of job is one of the most studied aspects of stress that causes high myocardial infarction, MACE, whether it's strain in your job, whether it's losing your job. And it's also important to understand that it's not only the whole job as such, whether people think, okay, if I lose my job, I'll be stressful, and that'll increase my myocardial infarction. That's not true. Even day-to-day strain in your job increases cardiovascular mortality, tends to increase atherosclerosis, increases platelet reactivity that leads to that can lead to myocardial infarction because of plaque rupture. We'll touch base on some of these, and as I said, it's impossible to discuss in details each and every one of them in this short talk. Similarly, things like as varied as receiving cancer diagnosis, actually not only that increases stress, there's also increase in inflammatory markers like hsCRP, interleukin-6, and we'll talk a bit of them about some of them in the next few slides. Psychosocial factors can include other vascular events like stroke or even ischemic events in the heart. So there is recurrent cardiac events even when you are stressed out watching a World Cup soccer. I mean, there are multiple landmark studies from Germany where during World Cup soccer, people had more myocardial infarction when their team was losing. And it's funny, but that's true because unfortunately, the body does not differentiate as to the cause of the stress, because whatever may be the cause, you might think it is something as pleasurable as watching a game. But when watching that game, which is a pleasurable thing, initiates stress, the molecular mechanism of the stress being initiated and atherosclerosis or cardiac plaque rupture, unfortunately, is the similar pathway as that which gets activated when you lose your job or your parent dies or you have a tiff with your wife or your boss. So though you might think that this is completely different, but unfortunately, that's not how body thinks. Body has got a very well-defined protocol by how it works and how it acts, increasing cardiovascular mortality. And we'll touch some of them today. So basically, my intention was that to give you guys an overall understanding of how stress increases cardiovascular death. Now, we'll not discuss much about this today, but it's important to remember that when you have stress, there are a lot of negative behaviors like alcoholism, smoking, poor diet, medical non-compliance. And all of us who are physicians have been through this. We have hundreds of patients who have these problems. So that's nothing new. I'm not going to talk, other than this particular slide, I'm not going to talk about behavioral mechanism now because of the lack of time, but I'll move on to something that is more important, that is giving you guys a basic understanding as to how molecular mechanism works for stress. Now, it's very important to understand that we have developed what is known as an autonomic nervous system with sympathetic and parasympathetic. The sympathetic makes you run away, save yourself, and the parasympathetic makes you calm, cool, composed. Now, why do we need this? We need this because in the last couple of million years, we never lived in an apartment and we never got up in the morning saying hi to our children or our parents or our wife or husband. We lived in a cave, and the first thing we got up in the morning and saw maybe a saber-toothed tiger waiting to greet you, or a large anaconda trying to slither inside your cave. So you had two options. You either fight it and kill it, or you run. So obviously our predecessors did the right thing. And that's why we as human beings are the predominant species on Earth. The tragedy is, though we are living in an apartment or in an individual house, though we have a society and societal norms, you just don't go out and kill somebody that you don't like. Despite that, unfortunately, our basic behavior remains that ancient. We have two basic ways to deal with stress. We either run or we kill that. The unfortunate part is the cause of stress cannot be killed. If you lose a job, you lose a job. It's not an anaconda that you're trying to kill, or it's not a saber-toothed tiger that you fight and kill. So what happens is, unfortunately, your body reacts in the same way, whether it is a very small incident, whether it's a perceived incident, or it's a real incident, but the actual trigger for the incident is gone. So whenever you have sympathetic stimulation, tons of catecholamines are released in the blood, and that causes a bunch of things like heart failure, as you know, Takotsubo's cardiomyopathy. It progresses end-stage heart disease. It causes a bunch of arrhythmias. So some of the things that is predominantly run by the sympathetic surge is one, what we call the sudden cardiac death, the largest cause of death in the United States of America. By the time I'm talking to you, I started talking to you, we had at least 5 or 10 Americans dying because of sudden cardiac death. The heart goes fast and they die out of it. And even before they call 911, 70% are dead before a helicopter or ambulance can even reach them. Similarly, we have around 4 million patients with atrial fibrillation or ventricular tachycardia. They're all mediated by stress. We don't know the exact pathway by which the heart and brain connects with each other, but we do know that there's a change in brain's functioning. There's release of neurotransmitters inside the brain that causes sympathetic discharge, and that sympathetic discharge makes the heart go fast, leading to atrial fibrillation, sudden cardiac death, refractory hypertension, and such other problems. But what is more important is when you have chronic stress, there's a complete dysregulation of the pituitary hypothalamic axis, resulting in excess corticosteroids. Not only there's excess corticosteroids, there's excess amount of corticosteroid receptors, which is by a genetic mechanism. The feedback control that stops production of receptors when the amount of cortisol is increased is diminished. Therefore, despite having huge amount of cortisol flooding your blood, you still continue to have high level of cortisol receptors, and that causes increased atherosclerosis. That causes increased endothelial dysfunction. That decreases nitric oxide, and this is exactly what really causes inflammatory reaction in your vasculature, leading to heart attack or myocardial infarction, leading to strokes and leading to peripheral arterial disease. Again, it's a little difficult to go through exact mechanism, but I'll just talk about some of the mechanism. One of the very important mechanism is the NF-kappa beta pathway, which activates the NLRP3 inflammasomes. So this causes massive inflammation by increasing interleukin-6, interleukin-1b, decreasing interleukin that decrease inflammation like interleukin-10. There's increase in TNF-alpha. So all these inflammatory markers are massively increased, leading to vascular inflammation, leading to heart attack, stroke, and a bunch of other adverse vascular events. Last couple of years, we have come to understand another very powerful mechanism, and that is now called the CTRA, or conserved transcriptional response to adversity, where now we know that adverse situation, like say COVID, like say losing a job, like say economic distress because you lost your job, or you're just sad because your elderly father or mother or both died because of COVID. In all these things can cause chronic inflammation. Now, when you have acute inflammation, somebody dies in your house, you can have acute inflammation, but that goes off once the acute trigger is gone. But in a larger number of people, when you have these chronic causes, loss of job, economic distress because of losing job, death in the family or disease in the family, diagnosis of a cancer, you will find that there is chronic inflammation. Chronic inflammation leading to neurodegenerative diseases, cardiovascular diseases, and that is because CTRA is activated. CTRA is a group of 330 genes, and that also plays a powerful role in increasing inflammation. And the sad story is not only it increases inflammation, but it decreases immunity against viral infection. So in COVID, if you're sitting at home, you're lonely, that can, or you lose your job, that can increase the CTRA, activate CTRA, not only resulting in you having increased chance of having myocardial damage, myocardial infarction, myocarditis, or increased heart failure, but unfortunately, you are also opening the gates to get COVID infection, because CTRA also depresses immunity, both innate and adaptive immunity against viral diseases. So it's dangerous. It's between the devil and the sea. Whichever way you go, there is danger. And that's why it's important. And a lot of mind-body medicine things have come up of late, which has been known, including yoga, to actually decrease, and other non-pharmacological measures has now been known to decrease activation of CTRA. So this is a slide that I've tried to bring everything together that I spoke today. So start every aspect of heart, every aspect, whether it is the mechanical aspect, whether it's electrical aspect, whether it is the blood flow, everything is affected by stress. So as you can see here, autonomic dysfunction, heart rate variability is decreased, leading to sudden cardiac death, atrial fibrillation. Neuroendocrine activation, there's increasing circulating level of cortisol, catecholamines that causes rupture of platelet activation, endothelial dysfunction, decreased production of nitric oxide, resulting in myocardial ischemia, myocardial infarction, cardiac rupture. Hemodynamic problems can lead to refractory heart blood pressure. You need more than 3 or 4 medication. Despite that, the blood pressure is not controlled. We already talked about atherosclerotic plaque rupture, which happens because of activation of the coagulation pathway. That is part of the inflazome that I talked about, NRP3 activation due to NF-kappa beta pathway activation, which increases blood viscosity, increases fibrinogen production, increases platelet activation. The alpha granules in the platelets is seen to be increasing, so there's increased chance of rupture, resulting in myocardial infarction, stroke, as well as peripheral artery disease. And unfortunately, there's also immune activation, but this level of immune activation, instead of being a friendly immune activation, it's an unfriendly immune activation. This immune activation increases all the bad players like interleukin-6, which can result in myocarditis. For example, in COVID, it has been seen the interleukin-6 level can be increased multiple times. And we now know that people who develop myocarditis, in most cases, it's not the actual virus that actually invades the myocardium. Because in one study with dead patients who all died because of COVID, only in 16 to 18% cases, that is less than 20% cases, they physically found virus based on PCR in the myocardium. But most people who died had severe fall in EF, had myocardial swelling, there was massively high level of interleukin-6, but no virus could be found, which makes us believe that possibly in COVID, what is happening is due to stress, activation of CTRA, infection of kappa beta pathway, and multiple other things. Myocarditis is actually inflicted by the cytokine levels and other odd immunological reaction rather than by virus directly attacking. So this is a busy slide, but I just want to give you a basic understanding. So we have stressors, brain makes changes, activates autonomic nervous system. There's also a couple of other pathways. For example, serotonin is decreased, dopamine is increased, which causes more depression. Then there's acute psychological stress, and there is chronic stress, as we talked about. There's change in immune reaction, and bad players like interleukin-6 and all are activated. There's a chronic pro-inflammatory circulatory states, which increases platelet addition, which increases platelet activation, which can cause rupture of plaque and leading to heart attack, myocardial infarction. There can also be arrhythmic consequences. There can be vascular consequences like endothelial dysfunction, increased cellular adhesion where macrophage adhere, leading to plaque maturation and rupture. There's atherosclerosis progression that has been clearly documented in both animal studies and in humans. Plaque dysregulation and rupture, absolutely, as I've said before. So all this leads to cardiovascular disease, stable coronary artery disease, unstable coronary artery disease, acute coronary syndrome, and also stroke. So we are coming out with the world's first book called The Principle and Practice of Yoga in Cardiovascular Disease. This is a medical book that describes all these different pathways and how yoga at the molecular level may help reduce some of these problems. Because we know pharmacology has a role to play, but if we could add mind-body to it, there is a lot of data now that mind-body actually plays a very important role in bringing down some of these chronic inflammatory markers like interleukin-6, and also brings down active platelet activation and a bunch of other factors, changes heart rate variability to prevent mortality and morbidity. Thank you very much. I really appreciate for having me in this talk. Thank you very much.
Well, thank you, Dr. Basu Ray. And maybe some of you can see my dog relaxing and doing yoga in the background. Our next speaker is Dr. Danielle Bellardo. She's a preventive cardiologist in Newport, California, and she's going to be speaking on some practical advice about what dietary advice should I give to my patients. Danielle.
Hello, my name is Danielle Bellardo, and I'm a cardiologist in Newport Beach, California, and I'm so honored to be included in the Prevention Symposium today, and I'll be talking about what dietary advice should I be giving to my patients. I have no disclosures. So starting with what we know about, in general, nutrition science overall, sometimes it can seem quite daunting or confusing, like there's a lot of different dietary patterns people should be following for different disease processes. But actually, generally, the research overall, when you look at multiple levels of evidence, when you look at epidemiology and prospective cohorts, all the way down to randomized controlled trials, there's a few common themes in nutrition science that show up to be beneficial for our cardiovascular disease prevention and for patients who already have cardiovascular disease. So when you look at the InterHeart study, this is a large population-based study that evaluated risk of cardiovascular disease in men and women across various different areas. And they found many risk factors, these 9 specific ones associated with increased risk of cardiovascular disease. 3 factors that were associated with decreased risk were daily consumption of fruits and vegetables, regular but modest alcohol intake, and regular physical activity. Not much of a surprise. Additionally, we have things like the Nurses' Health Study, Health Professional Follow-Up Study, all of this long-term epidemiological data that shows us time and time again, they identify factors that lower CVD risk. And in the Nurses' Health Study specifically, they found maintaining a normal weight, not smoking, regular physical activity, drinking at least half an alcoholic drink per day, a diet high in cereal fiber, marine omega-3 fats, folic acid, a high ratio of PUFA to saturated fat, low in trans fat, and low in refined carbohydrates. So the key factors to reducing risk of cardiovascular disease, as we all know, are controlling, preventing, doing everything we can to put into remission either hyperlipidemia, diabetes, hypertension, and of course, working on smoking cessation, obesity, and exercise. And those factors alone, even if there are genetic components contributing, nutrition can actually be quite impactful for hyperlipidemia, diabetes, hypertension, and obesity. So it's important to be a part of every patient's prevention program. But when we find out, what is the best for weight loss? What about obesity? What do we do? What do we tell our patients to eat? Well, the truth is when you look at the data, truthfully, almost all diets end up at the same point with a bit of a regression to the mean, where all patients end up kind of either gaining weight back or losing maybe not as much weight as they needed, or losing some and then gaining some back, losing some more. So the pattern seems to be consistent, whether you're on a low carb Atkins diet, Zone, Weight Watchers, or Ornish when compared head to head. So far, no dietary pattern has really found to be the #1 winner for tackling obesity. But that being said, it doesn't mean that what we eat is not important, because it certainly is. There was one study that showed at 6 months that the fully plant-based arm of a study, when individuals were randomized to vegan, vegetarian, pesco-vegetarian, semi-vegetarian, or omnivore, that the fully vegan arm of the trial had lost the most weight. But then again, as I mentioned, even though that's the case at 6 months, at a year, it usually ends up all kind of evening out. So it's important for us to note that, I am a huge advocate for eating a plant predominant diet, whether that be a fully plant-based diet or a Mediterranean style diet. But I think there's a lot of confusion in the language. And I think it's important to remind our patients that just abstaining from animal products in and of itself is not necessarily healthy. Oreos are vegan. And so this great study in JACC looked at healthful versus unhealthful plant-based diets and found that, an unhealthful plant-based diet, one that's filled with fried or processed foods, refined grains, things like that, was just as unhealthful as one really high in animal products. So truthfully, we're trying to get our patients to eat more whole plant-based foods, lean proteins, things like lean vegetable protein or fish, to help them reduce their risk for cardiovascular disease. And we know that from both primary prevention, but also such a robust study with the secondary prevention in the Mediterranean Lyon Diet Heart Study. This was a study with people that have cardiovascular disease. They were randomized to control or the experimental arm in a free living RCT, where their experimental arm was a dietary intervention consisting of increasing bread, legumes, vegetables, fruits, decreasing meat, decreasing cheese and butter, increasing a polyunsaturated fat margarine, and fish stayed about the same, maybe slightly increased. They found a 50 to 70% lower risk of recurrent heart disease. And this was measured by 3 different outcomes: cardiac death, non-fatal heart attacks, stroke, angina, heart failure, and all of these plus events that required hospitalization. So quite impressive from this dietary intervention to see such a really impressive reduction of cardiovascular risk. And so really emphasized in our guidelines and in nutrition science through multiple levels of evidence is emphasizing a diet, the total dietary pattern, right? With fruits, vegetables, legumes, if someone wants to eat whole grains, nuts, and if they eat animal proteins, to focus on fish. Replacing saturated fat with mono and polyunsaturated fat sources to lower LDL cholesterol and ApoB, avoiding trans fats. Reducing dietary cholesterol, despite what people may say, reducing dietary cholesterol actually still can make a difference in your ApoB and your LDL cholesterol, although not as substantial as the change in what you see replacing saturated fat with polyunsaturated fat. Sodium reductions, and also, reducing refined carbohydrates, sugar-sweetened beverages. That's low-hanging fruit. Our patients should not be drinking their calories if they are overweight with metabolic syndrome. They should stick to diet or water only. And protein, so eliminating processed meat intake, focusing on things like plant protein, or if you eat animal products, things like oily fish. And this is reflected in our 2019 primary prevention guidelines, which outlined it beautifully. So the challenge is when you're talking to patients this time, right? No one has that much time. You're seeing a patient discussing all of the challenges and all of their medications. And in 15 minutes, how can you do it? So truthfully, it's not going to be done at every single visit. It's not going to be done extensively at every visit. It may be done at just a few visits, but at least make a point to discuss nutrition at some point with the patient in your course of treating them, especially when it comes to prevention. It helps to know what your patient normally eats and what they know about nutrition, and it helps to ask them what their beliefs are about health, because you may be surprised as to what they think could be healthy. They could tell you that they think red meat and bacon are incredibly healthy because it's keto, when in reality, if they want to do a keto diet for whatever reason, personal preference, etc., that's possible, but they should replace that red meat that can raise their LDL. They should and make them a higher risk for colon cancer. They should replace that with something like a plant protein or a fatty fish or avocado or olive oil. And they can still follow a low carb diet that's high in polyunsaturated fat. So it's really important to know who and what your patients are thinking about nutrition first. Sending your patients to registered dietitians if possible. I know that insurance is a challenge and this can be difficult, and not everyone has a registered dietitian at their office. We have 2 and we are fortunate, but referring your patients to registered dietitians if possible, if they can, are able to afford it and have the time, can be incredibly useful. Eatright.org is a great resource. Nutrimity.com does telehealth, telenutrition, teledietetics, which makes it convenient for patients as well. One easy thing you can do is in the waiting room, you can have your patient fill out a 24-hour dietary recall before their visit. Even if you don't have a ton of time to go over it with them, it does get your patient thinking of, well, how many sugary drinks did I have for a day? How many sodas did I have yesterday? What about fast food? How much fast food did I have this week? Chocolates, donuts, and alcoholic drinks. It actually just gets them to reflect. And hey, if you have time and you're able to go over it with them, that's fantastic. But sometimes this alone may just get your patient to start thinking about what they've been eating. Easy, actionable tips. So, on the first visit, you bring up food. It may not be the day that your patient decides, okay, I'm going to follow a fully plant-based diet or a fully Mediterranean style diet. There may be small changes, but some of the smallest changes that can make a huge impact is one is snacking. When someone's trying to lose weight, there really is no need for snacking. Liquid calories should just go. Low-hanging fruit, liquid calories don't help with satiety. They're really easy to maximize and get really high calorie intake without noticing it. And so they just don't help. And alcohol. So for some people, alcohol can end up being a huge portion of their caloric intake and they had no idea. So looking into alcohol is important as well. And fiber. So sometimes I think one of the best goals we can give our patients are fiber goals, trying to get your patient to increase their fiber intake by 5 grams a day. You can have your patient use a free app like MyFitnessPal or Chronometer if they want to track it. And just getting fiber into their diet helps with a few things. One, it helps to drop cholesterol. We know this. Soluble viscous fibers helps to drop LDL cholesterol and ApoB. We also know that eating fiber is good for your digestive system. It's good for preventing various different types of cancers, and the food that comes along with dietary fiber, fruits, vegetables, greens, things like that are good with phytonutrients and super important for our health and vitamins and minerals. But increasing fiber is great because it also helps your patients feel full. It helps with satiety. It helps your patients to feel full. And if weight loss is their goal, increasing fiber can be a great, easy step. So asking your patients to increase their fiber by about 5 grams per day is a safe amount without giving them too much GI upset. Recognizing barriers to dietary modification is always important. There's always going to be cultural, financial, family barriers, or time constraints. And I think just being cognizant of that and trying to work with your patient around some of these different barriers, trying to help them find solutions, and know that it's a work in progress. It's progress over perfection. Not every single day is going to be the day that their diet is perfect. None of us are perfect. And so just encouraging them on the journey to just make changes that are reasonable and that work for them. So thank you so much for having me. It was such an honor to be here today. And thank you for listening to my talk.
Thank you, Dr. Bellardo. What a wonderful and practical talk for all of our patients and for all of us. Well, we've saved the best for last. So Dr. Jamal Rama will be the next speaker. He is the Assistant Physician in Chief, as well as the Chief of Cardiology at Kaiser Permanente in Oakland, California. And he's going to talk to us about ideal cardiovascular health. So what should we really be aiming for? So we're looking forward to this talk.
Hello. The topic of my talk is ideal cardiovascular health, what we should be aiming for. When I looked at the agenda for this amazing CVD Prevention Symposium, I noticed that this was the last talk of the day. So I joked with Dr. Nasser and team that, hey, were you saving the best for the last? So jokes aside, I'm thrilled to be here and especially following the amazing speakers from whom all of us have learned so much from earlier today. Okay. So you may wonder that why I'm showing slides about COVID-19. So these headlines from last year brought out the importance of cardiovascular disease or health even more so. So when we talk about prevention of heart disease in the era of pandemic of COVID-19, our discussions remain extremely relevant. But even before COVID-19 showed us the increasing importance of cardiovascular health, we looked at the trends of mortality in US, and in 2016, with my colleagues, especially with Dr. Steve Sidney, we published a paper in JAMA Cardiology that showed that there was an annual decline in heart disease death rates in US, and it was flat since 2011. So the decline in cardiovascular mortality was actually plateauing. And this was a very concerning finding while we thought that things were going in the right direction. And then everyone is aware that despite whatever is happening, heart disease remains the #1 killer, followed by cancer. So I do want to talk about the importance of cardiovascular disease across the lifespan. The cumulative product of early life and chronic exposures from the environment and health behaviors, such as adverse diet, low physical activity, smoking, and the development of risk factors such as obesity, elevated blood pressure, dyslipidemia, and dyslipidemia leading to clinical CVD events. Primordial prevention strategies focus from birth on lifestyle environment to maintain higher stock of health and prevent the development of causal risk factors is a very important concept. And we're already aware of the concept of primary prevention strategies that identify individuals at risk for incident CVD and attempt to intervene with lifestyle or drug therapies, such as weight loss, smoking cessation, statins, antihypertensive therapies. So what about the concept of cardiovascular health? In 2010, the American Heart Association published the 2020 impact goal, whose stated aim was to improve the cardiovascular health of all Americans by 20% while reducing deaths from CVD and stroke by 20% by the year 2020. And further, they proposed the targeting of 7 cardiovascular health risk factors to reduce the burden of atherosclerotic cardiovascular disease, which, by the way, includes both stroke and heart disease events, with metrics devised to categorize risk factor levels as ideal, intermediate, or poor. And it's nicely called as Life's Simple 7. And indeed, these are well-known risk factors. And I really like this concept of sort of encapsulating it into Life's Simple 7. And then further categorizing them into poor, intermediate, and ideal. So what it does is this, that it helps you quantify your own personal level of health or your patient's personal level of health. So I'll take some examples here. So for instance, take smoking. So if somebody is currently smoking, so that's poor health, and you get 0 points for that. If you're a former smoker, within 12 months, that's intermediate, so you get 1 point for that. And then ideal, which is you never smoked or you quit more than 12 months ago, then you get 2 points. So if you get 14 points, for instance, you are sort of attained or near ideal cardiovascular health. Similarly, the other metrics are body mass index, so less than 25 kg per meter squared, physical activity, more than 150 minutes per week, moderate, or more than 75 minutes per week of vigorous exercise, or any combination of the two. And then we have a more complex concept of diet pattern. And so basically, AHA proposes a well-balanced diet and following the DASH diet, which is to consume more than 4.5 cups per day of fruits and vegetables, more than 2 servings per week of fish, more than 3 servings per day of whole grains, and no more than 36 ounces per week of sugar-sweetened beverages, and 1,500 milligrams per day of sodium. So among those various components, if you're doing 4 to 5 of them, so you are sort of in the ideal category of your diet pattern. And then the well-known concept of total cholesterol, it should be less than 200, the blood pressure less than 120 or 80, and the fasting plasma glucose of less than 100. So what it does is this, that it also has this concept of intermediate, so pre-diabetes. So there is a sort of scale to it, so it's not as dichotomous a pattern. So the concept is Life Simple 7. And then talking more about that, why we should be trying to achieve this, because it is a huge burden. We have 21 million American adults with diabetes. So that's almost 9% of the adult population. Our cholesterol level is not well controlled in 40% of the population. Similarly, about 18 million US adults have high blood pressure. That's about 33%. So the concept that I talked about, that why do you have this flattening of decline or plateauing and decline of cardiovascular mortality in America, these are those reasons. And that's why it becomes even more important to talk about these or remind ourselves these health factors and try to talk about health by decreasing the prevalence of this disease. Now, where we are in terms of this cardiovascular health profile, and unfortunately, few US adults maintain this CV health.
into the middle age, and cumulative exposure to intermediate or poor CVH over the lifetime. And hence data from 2013 to 16 estimated that only 1% or less than 1% of adults meet this criteria for ideal levels of 5 or more CVH metrics. And despite major health promotion efforts by organizations, the forecast has been bad. And we now know in 2021 that we were not able to attain that. And that despite the fact that we have studies done that when people could at least 5 ideal of the Life Simple 7 metrics had an astounding 78% less reduced risk of heart-related death compared to people with no ideal metrics. Another meta-analysis showed that there was a linear inverse relationship exists between increasing number of ideal cardiovascular health metrics for both cardiovascular disease and even all-cause mortality. So there's science behind it that the more you try to achieve these metrics for cardiovascular health, the better outcomes we get. And what makes it even more compelling is that we did a study with lots of my friends and colleagues in preventive cardiology. You'll see familiar names in there, that we showed that even attaining these optimal, in green you see here, these metrics or risk factors led to fewer events per 1,000 person years for cancer, CKD, pneumonia, even DVT and PE, COPD, and all the way to dementia. So it's an amazing concept about achieving health, both cardiovascular and even non-cardiovascular. So there's more data around this that in cardiac study we showed that 60% of young adults who follow the 5 healthy lifestyle of BMI less than 25, no or moderate alcohol use, healthy diet pattern, healthy physical activity, and no smoking, well into the middle ages, they could sustain that compared with only 3% of those with no healthy lifestyle. So what comes up is just how do you have a patient-centered discussion around these risk factors? Like how can you even talk about a patient and quantify with the patient that, look, if you could try to control this particular risk factor, what is the risk behind it? So we did a study of almost 1 million men and women, and we looked at these various factors and tried to quantify that. What is the risk related to each one of those metrics? So in this one, you could see that the red is the combination of yellow, which is stroke, and blue, which is CHD. So BMI, you may be surprised that it's not showing an increased risk of ideal versus poor. The reason for that is that once we control for all the other risk factors, that effect was attenuated. But for cholesterol, for instance, you could see that compared to the poor people who had ideal cholesterol levels, there was a big difference. So poor had a relative risk of more than 1.5. And similarly, interestingly, found that for physical activity, you could see here in red, it was the relative risk was more than 1.5 and was almost similar to smoking. So having sedentary lifestyle or not physical activity was like smoking. And it really talks about like, hey, sitting is the new smoking kind of concept. And not surprisingly, that people who had diabetes or impaired glucose levels and high blood pressure had up to almost 2.5 times more risk factors and when they were not controlled. Now, I do like these American College of Cardiology CardioSmart infographics, which is just a quick sort of cheat sheet or infographic or a reminder for the patients that, hey, what you can do to in everyday life to lead a healthy life. So it could be as simple as dancing or brisk walking or gardening and household chores, vacuuming. So you can find some meaning behind even vacuuming your house, and it can lead to your health. And so it doesn't have to be a fancy gym or fancy different contraptions, but just try to do something all day long or as much as you can.
On the same concept, there's a very interesting paper that came out last year that's about sit less and move more for cardiovascular health. And what the authors did was they actually broke down the day into sleeping times and waking hours. And then they talked about that how much time we spend into sitting. And obviously with COVID-19 and all of us getting virtual, the things got worse. And it became even more important to talk about it, that how we can remind ourselves to get up, walk around, and do a little bit of things. And they call it the staircase approach, that you can start in smaller steps and eventually you can achieve a more fitness by staying active as much as you can all day long. So in terms of diet, it is a huge challenge about what's right and wrong. And you have heard our amazing speakers talk about it, so I'm not going to go too much into it. But it's just a reminder that, what we should be aiming for is lifelong primordial and primary prevention efforts and reminders. And in a cardiac study, we had almost 5,000 young adults, both Black and white, who followed for 32 years. And we showed that participants, so this was not a trial, we told people what to eat, but naturally people who were eating nutritionally rich plant foods. And we allowed a little bit of animal products, of low-fat dairy products, non-fried fish, non-fried poultry, and still considered as a APDQS better score, or higher score in that measure. And there was an astounding level of decreased risk of CVD, and you're looking at hazard ratios of 0.48 and changes over 13 years. So you can start any time in your lifetime, and still you could have beneficial effects of hazard ratios of only 0.39 and people who were doing well in this nutritionally rich plant-based diet. And then finally, as I wrap up, I do want to sort of make us all think that we should not put all the onus on the individual and the person. As the healthcare systems, we should also be taking responsibility and thinking about prevention efforts. So I work in Kaiser Permanente, and we have this large phase program, which is called Preventing Heart Disease and Stroke Every Day. And then we enroll all the diabetes patients automatically in it, and we do active reach out to them regarding their blood pressure control, lipid levels, and blood sugar levels. And in this study, we compared HEDIS measures at a national level to our healthcare system level. And you could see here that over time, in each of these categories, risk factors are better controlled. And it doesn't stop here. These do translate into real hard outcomes. And we showed that from 2000 to 2015, when we compared the decline in heart disease and stroke, it was almost twice as much higher decline in heart disease and stroke in Kaiser Permanente members. And we follow almost like more than 4.5 million patients. And at that time, they were around 4 million patients. And so it's a big impact to having system level interventions. So based on the enormous challenge that we have found in public health, this concept of 2020 was readdressed by Dr. Lloyd Jones. And then it says that one potential target for cardiovascular health promotion is to enhance prevention efforts by 50 by 50 by 50, representing a bold goal of prevalence of ideal cardiovascular health, what I just described, among more than 50% in all segments of the population less than age 50 years by 2050, in order to have equitably achieve the CVD endgame for all. So 50 by 50 by 50. And then finally, this was a very thoughtful piece in New England Journal of Medicine last year. And it says that as the COVID-19 epidemic has demonstrated, we need to explicitly link healthcare systems with appropriately resourced public health and community-based services. These approaches must undergo systematic evaluations that will assess whether and under what conditions they work. As we recover or sort of maintain in this pandemic and address the structural racism and inequities, we have an opportunity to invest in quality in ways that lay a foundation for a healthier future America. And then I call it the healthy circle of life, reminder for all of our patients to every day try to achieve cardiovascular health, In summary, promotion of cardiovascular health across the life course is necessary to focus on both primordial and primary prevention strategies. And then again, given the enormity of the challenge, multi-level interventions are needed, focused on dissemination and implementation of evidence-based therapies at both the individual level as well as policy changes at the population and systems level to produce cardiovascular health. So thank you very much.
Great. Thank you so much. Those were such excellent talks. And so I hope our audience is still with us. And we're just going to have a few questions right now. So I'm going to start with Dr. Shapiro. I want to ask a question because we're all, we're supposed to be very practically focused. So how many statins do you try before giving up? Do you just try one lipophilic and one hydrophilic and say, call it a day? Or what's your practical strategy for us?
Yeah, thanks for the question. That's a great one. I think that one of the points that I was making in the presentation is that just a few years ago we had to struggle through this. I mean, statins were by far and away really the only good drug we had for LDL lowering and for evidence of improving cardiovascular outcomes. So we pulled out all the stops. I mean, it wouldn't be uncommon to try 3, 4, even more statin drugs if the patient was willing. I always try at least 2, and really depends on an individual patient. Some patients just like the idea, of course, of a very effective, inexpensive, safe drug, and so they might be willing to try a lot of statins. But for those individuals who, we meet them quite frequently, get frustrated with the statins relatively quickly, sometimes after the second, we pivot, and now obviously we have all sorts of good options. Good oral drugs, ezetimibe, bempedoic acid, and of course, injectables with the PCSK9 inhibitors. So we don't have to struggle nearly as much. I think it also depends on whether you're talking about secondary prevention or primary prevention. I think in secondary prevention, we'll probably pivot more quickly to some of the non-statins, whereas in primary prevention, we'll try to give the statins a bit longer of a shot.
Great, thank you. Dr. Bellardo, can you tell us a little bit about how we get physicians and cardiologists, for that matter, trained about nutrition? Because I think that's where there's a big gap. I mean, unless you have an interest in it, it seems that a lot of people are not equipped with the, what would they do with your 24-hour recall is really my question. It's a great idea, but how do you use it?
Yeah, so I do think that one of the most important things that we can do is to emphasize utilizing registered dietitians. Even as cardiologists, if you don't feel comfortable discussing dietary changes, and even if you don't feel comfortable, going into it, or you don't have the time, utilizing registered dietitians, just referring patients for teledietetics or for to eatright.org or anything like that can be super helpful. The biggest limitation is insurance coverage. Right now, insurance coverage for dietetics is really not that widespread. It's mostly just for CKD, but even things like hyperlipidemia or hypertension, patients are not able to get RDs always covered. So I do think that that is kind of a broader, larger, more systemic issue we have to work on, getting insurance coverage for registered dietitians. But I would say for a physician that wants to learn more about nutrition, I'm a firm believer that we should have at least some of it in our cardiology curriculum during fellowship training. I think that there should just be some. It doesn't have to be extensive, but it could be literally what we have in our guidelines. And so I think that our 2019 ACC primary prevention guidelines outlined it perfectly. And I think that some integrated into our cardiology training, I think would be beneficial, especially considering we do have one of the, our specialty does have such a significant amount of diseases that are directly impacted by nutrition.
Great, thank you, Dr. Bellardo. And Dr. Rama, the question I have for you is, you showed us those excellent results of what you guys have done at Kaiser Permanente. How do we replicate those to the nation and even those who are uninsured, which is obviously sometimes where a lot of problems are?
That's a great question. I think it comes to what we can say like teamwork, because it's not just the cardiologist who does that. So we have a whole team of our care managers, we have nurses, we have pharmacists. So anytime somebody has a diabetes or heart attack or post-stroke, the whole team follows the patient. As a cardiologist, I cannot follow my patient every week or so. So these teams keep track of their blood pressures, their diabetes controls, their diet, their exercise, and circle back to them. And so I think there's so much onus is put on the patient and, oh, the patient didn't do this. But I think we need to take responsibility as healthcare systems and as society to take care of them as well.
Great points. Well, I'm going to hand this back over to Miguel, but thank you for your excellent presentations and thanks to the audience for being with us today.
Thank you.
Thank you so much, Marta, and our speakers for a wonderful discussion and session, and to all of the people who participated today in this event for a wonderful event. Time for us to adjourn, and I want to thank on behalf of Dr. Nasser, Dr. Patel, and myself, to everybody who participated today, the moderators, the speakers. I also want to thank the social media ambassadors and for sure Amarin Pharmaceuticals for their educational support to this event. Also, special thanks to Dr. Nasser, who is the mind and soul behind this event, for his energy, for pushing us to have this event even with the online format. We're looking forward to next year's, for sure. Also, thank you to Dr. Zogby, Dr. Quiñones, and the leadership in Houston Methodist for supporting CVD prevention as a top priority in our activities, and definitely for their support for this event. And a special thanks to the audience. We had more than 500 people joining us today. It's been a big pleasure to have all these important experts in the field sharing with us their knowledge, and I'm hoping that the audience found these talks very insightful. And we're looking forward to seeing all of you next year for sure, hopefully in person, but if not, online. And looking forward to a fantastic 2022 event as well. You have a wonderful weekend, and thank you so much to everybody. Bye-bye.